So, greetings everyone. Good morning, good afternoon, or good evening, wherever you are in the world. It's my pleasure to welcome you all to the third IJMS International Journal of Medical Students World Conference of Medical Student Research 2024. We are excited to announce that we received over 100 submissions from different parts of the world, and after careful review, we have selected the top 40 abstracts to be featured in these significant events, and each of these submissions reflect the dedication, the innovation, and the passion of medical students who are committed to advancing the field of medicine. Being a student engaging in research is not easy. So many challenges and barriers will come along the way. And the International Journal of Medical Students has been dedicated to creating a supportive platform for these early career researchers and students since its establishment in 2009. Our mission is to empower the next generation of medical professionals by providing valuable opportunities for collaboration, learning, and growth. What we believe is that by fostering a community where students can connect and share their experiences, we can help them navigate the complexities of research and inspire their journey in medicine. So, hello everybody, this is Dr. Sajjad Ahmed Khan, your host for the session, and we'll connect with fellow presenters and judges from all around the world. Now, before I dive into our program, I would like to acknowledge the incredible effort that has gone into making this conference possible. A heartfelt thanks to our organizing committee, to the reviewer, and to everyone who contributed to this event. So from idea to reality, we are here with you. Now, without any further delay, I am honored to introduce Dr. Francisco Vanilla Escobar, the Editor-in-Chief of the International Journal of Medical Students, for his opening remark. So welcome, Dr. Francisco. Dr. Francisco, apologies, we cannot hear you, I think.
Yeah, thank you so much. It is my pleasure to be here today. And I want to welcome everybody to the 2024 edition of the International Journal of Medical Students Research World Conference of Medical Students. As the editor-in-chief of the IJMS and founder of this conference, it is an honor to welcome you all. The International Journal of Medical Students has been a unique platform for over a decade, driven by the belief that medical students are not just learners, but valuable contributors to scientific knowledge. As the first student-led open access journal dedicated to publishing research by medical students, the IJMS provides an opportunity to engage with the academic world on equal footing. Our journal has trained hundreds of students in the rigor of peer review, editorial processing, and publication, equipping them to become the leaders in evidence-based medicine. This conference, now in its third edition, was founded to bring our journal's mission to life in a dynamic, interactive way. The World Conference of Medical Students Research represents a collaborative effort that reflects our mission at IJMS. And none of this will be possible without the remarkable work of our organizing committee and the editorial committee. Their dedication to every detail has brought us to this day, and I'm deeply grateful for their commitment to making this event a success. Thank you, guys. Today's presentations represent some of the finest research in our field, showcasing the dedication, resilience, and creativity of our next generation of healthcare leaders. With over 100 participants from 40 countries, we are gathered here not only to share knowledge, but to foster connections that will drive future innovation in healthcare. Thank you so much, everybody, for joining us to make this conference memorable. Let's embark on a day of learning, sharing, and building connections that will shape the future of medicine. Welcome to the third IJMS World Conference of Medical Student Research. Thank you.
Thank you, Dr. Francisco, for your kind words. Now I would like to invite Dr. Umar, the director of this conference, for his opening remark for the World Conference of Medical Student Research 2024. Welcome, Dr. Umar.
Thanks, Sajjad. How are you, everyone? Nice to be with you today. First of all, I would like to thank the whole committee in charge of the International Journal of Medical Students, IJMS, especially Editor-in-Chief Dr. Francisco Escobar for his faith in me and giving me this great responsibility to manage the whole conference. So, dear great attendees, I would like to welcome you to the World Conference of Medical Student Research 2024. This conference is held to achieve the IJMS vision and goal in enabling medical students and recently graduates to conduct, publish, and present their research. So this conference aims to provide a platform for early career researchers to present their research, and also it provides a great opportunity to exchange experiences between researchers from all over the world. As presentations from more than 40 countries around the world will be presented in this conference. We have selected the best 40 abstracts to be presented, and these presentations will be presented in 4 presentation slots. And each presentation will include a question and answer session. And at the end, there will be an award ceremony to celebrate the best research contributions. So I hope that after the end of this conference, we have reached our distinctive vision and goal in encouraging early career researchers, exchanging experiences between them, and providing opportunities for cooperation between participants from all over the world. So everyone, I would like to welcome you in this conference, and I hope you benefit from this special event, which is the only one of its kind, which has this vision and this goal, and these opportunities for early career researchers. And I would like to thank the all committee, all the WCMSR committee, all our editors and editorial team, our authors, our readers, and our great attendees. So thank you all, and I hope you enjoy this conference. Thanks.
Thank you very much, Dr. Umar, for your kind words. Now, without any further delay, let's get into the session. So let's start our session. Now, to introduce our first session judges, our judges for this session will be Dr. Sharjeel Chaudhary, Dr. Ruchi Kothari, and Dr. Malik Orvi. I welcome all of the judges who are present over here for the first session of this World Conference of Medical Student Research. Now, let's get into the presentation. Our first presenter will be Supitsara Kositbovornchai from Thailand, who is going to present a randomized controlled trial entitled Comparative Effectiveness of Sequential Hygiene Education Intervention Among Primary School Students in Thailand, a randomized controlled study. If you can hear me, you can please begin the presentation now. Yes, welcome, Dr. Supitsara. You can continue your presentation.
Hello, everyone. Can you hear me?
Yeah, sure. You are audible. You can proceed.
Hello, everyone. My name is Supitsara Kositbovornchai. I'm a fifth-year medical student from Chulalongkorn University, Thailand. It is an honor to me to present to you my research study on comparative effectiveness of sequential hygiene education interventions among primary school students in Thailand, a randomized control study. I would like to thank my collaborators and my advisor, Dr. Krit Phongpilun and Mr. Panupong Putakul. First of all, infectious diseases are significant global concerns seen from recent pandemics. Primary school students who are going to see their friends at school is a big challenge target group to prevent the spread of the diseases. Effective hygiene education is critical for reducing the spread of these diseases. This study aimed to evaluate the effectiveness of 2 sequential hygiene education interventions. The first sequence is cartoon animated video followed by a classroom teaching, which is called the C2T. And the second sequence is classroom teaching followed by cartoon animated videos, which is called the T2C. We compare an improvement in hygiene-related knowledge among primary school students in Thailand after receiving the intervention in each sequence. A total of 2,188 students from 6 primary schools were randomly assigned to either the C2T or the T2C intervention groups. Knowledge assessments were conducted at 3 points. The first one is before the interventions, which we call pre-test, after the first intervention, which is called post-test 1, and after the second intervention, which is called post-test 2. The assessment, which consists of 15 questions, allows students to indicate whether they agree or disagree with them. Classroom teaching covers a comprehensive set of 15 hygiene-related questions, which is question 1 to question 15, while the animated videos focus on 4 key concepts. The interventions were evaluated based on improvement in test score, with statistical significance determined using p-values. So these are the results of the mean score of each test and also the difference in score for each sequence. Both interventions lead to significant improvements in students' hygiene knowledge from pre-test to post-test 1 and post-test 2. To make it easier, I will be using this infographics to explain. So let's talk about the initial improvement in knowledge score from pre-test to post-test 1, meaning that the T2C group only receives the classroom teaching intervention and the C2T group only receives the cartoon animated video interventions. From our study, we found that the T2C group showed a larger initial improvement, which the mean change equal to 0.87 compared to the C2T group, which the mean change equal to 0.66, with significantly different between group with p less than 0.001. However, when looking at the improvement in knowledge score from pre-test to post-test 2, the C2T group exhibited a slightly greater overall improvement with the mean change equal to 0.42 compared to the T2C group, which the mean change equal to 0.31, with significantly different between group with p equal to 0.006. These results suggest that while the T2C approach is more effective in short term, the C2T approach may lead to better long-term retention of knowledge. So both educational sequences effectively enhance hygiene knowledge among primary school students, with each approach offering unique advantages. The T2C method provides a stronger immediate impact, while the C2T method supports sustained learning. These findings highlight the importance of considering the sequence of educational interventions to maximize their effectiveness in promoting hygiene practices. So here is the end of my presentation. Thank you for listening. If you have any questions, please feel free to ask.
Thank you for the presentation, Dr. Supitsara. Can we please get the QR code here for the audience to vote? And now I would like to get back to our judges. Do we have any question to the presenter?
Yes, I would like to ask.
Dr. Ruchi, welcome Dr. Ruchi, Dr. Malik, and Dr. Sharji. Do we have any question to the presenters?
Yes, thanks, Dr. Sajjad and
Yes.
Supitsara. I would like to congratulate you. It was a brilliant presentation. I quite liked your topic. It is really interesting in today's context. I just have two questions for you. What was the rationale behind you choosing this particular topic for your research?
So personally, I'm a person liking health prevention because I think to prevent is better than to cure after like getting the disease. And from the COVID-19 pandemic, I saw that like many kids doesn't really take care of their hygiene, and they don't really know how to take care of themselves properly, like when to wash their hand before they eat or before they're gonna touch their eyes and stuff. So I think to get them to prevent the spread of the disease, like preventing before they getting the disease is the topic that really interests me.
Well said. I could understand that you wanted to motivate the practice of maintaining hygiene, right? So,
Yes.
as per your conclusion, I can make out that long-term sustenance of knowledge was more with C2T approach. Like you start with classroom teaching and then you proceed to animated videos, right?
The C2T is the cartoon animated
For
video
long-term,
followed by. Yes,
for the
it's better.
long-term impact. Okay.
Yes.
My second question is, which statistical software have you used for taking out the results, for analyzing your results?
Can you repeat the question?
Statistical tool. Which
Is
statistical tool have you used?
is generalized estimating equations.
Sorry?
Generalized estimating equations.
Okay. Okay, great. Over to you, Dr. Malik.
Hello everyone. Am I audible? Am I audible?
Hello, hello, Dr. Malik. Yes, sir, you are audible. You can proceed with the
Okay.
question, please.
Okay. Thank you so much, Miss Supisora. Sorry.
Yes, that's right.
Hello, Dr. Malik. Are you there? Okay, so I think Dr. Malik is having some technical issue. We can perhaps now get back to the QR code for the audience to vote the presenter. I request the tech team, yeah. So now you can see the QR code on the screen. Please vote the presenter. I request all the audience to please vote the presenter, as we'll be having winners based on the audience judge as well. You can see the QR code on the screen. Please vote for the presenter. Okay, so I think now we can get back to the second presenter. Our second presenter is Dr. Lakmani Senevirathna from Sri Lanka, who is going to present a topic entitled Knowledge, Attitude and Practice on Mask Wearing for Respiratory Tract Infection during the post-COVID-19 period among the visitors coming to the outpatient department at a teaching hospital in Haroon, Sri Lanka. Welcome, Dr. Lakmani. You can please proceed with the presentation.
Hi, can I get to know whether I am audible to you?
Hello, yeah, sure, you are audible. You can proceed with the presentation.
Hi everyone, I'm Lakmani Senevirathna and I'm going to present the research done on knowledge, attitudes and practice on mask wearing for respiratory tract infections during the post-COVID-19 period among visitors coming to the outpatient department at Teaching Hospital Peradeniya, Sri Lanka. Background: SARS-CoV-2 virus caused COVID-19 pandemic which ultimately led to thousands deaths worldwide. Mask usage was one of the main components of a comprehensive package for the prevention and control of this disease. If this skill was acquired with an understanding, it would be beneficial.
We cannot see your slides. Can you please share the slides? We cannot see your slides now.
Sorry.
Can you please share the slides?
Can I get to know whether can I go to the initial and then continue?
Yeah, sure. You can continue from the beginning. Your time starts now. Please proceed.
Okay, thank you very much. Hi everyone, I'm Senevirathna and I'm going to present the research done on knowledge, attitudes and practice on mask wearing for respiratory tract infections during the post-COVID-19 period among visitors coming to the outpatient department at Teaching Hospital Peradeniya, Sri Lanka. Background: SARS-CoV-2 virus caused COVID-19 pandemic which ultimately led to thousands deaths worldwide. Mask usage was one of the main component of a comprehensive package for the prevention and control of this disease. If this skill was acquired with an understanding, it would be beneficial as a transferable skill for preventing respiratory tract infections even during post-pandemic period. Objectives: we aim to describe the knowledge, attitudes and practice towards mask wearing in our study population. Methods: this was a cross-sectional descriptive study done at Teaching Hospital Peradeniya, Sri Lanka, which is a tertiary care hospital located in Kandy district with 1,000 bed occupancy. The population was 423 visitors who were seeking treatment from the outpatient department and who were aged between 18 to 75 years. We used convenient sampling method because it was easy to collect data in a busy setup like OPD. After getting ethical and administrative approval, we collected data through a validated self-administered printed questionnaire and an observation chart. The questionnaire included demographic data and questions on knowledge, attitudes, and practices regarding mask wearing for respiratory tract infections. The knowledge and practices scores were calculated and the knowledge score was compared with demographic variables during data analysis process.
I'm sorry to interrupt once again, but please keep changing your slides as you move on because we can still see the first slide.
Okay. Here are some of the characteristics of a study population, and according to that, there were 394.
Sorry, I'd like to interrupt. Can you hear me? I'd like to interrupt once again. I'm sorry, but we cannot see the. Yeah, sure. Please proceed.
Can you see now?
Yeah, sure. Please proceed. Keep changing slides as you move on. Thank you. Please carry on.
Here are some of the characteristics of our study population, and there were 394 completed questionnaires while only 29 were incompleted. Out of the completed questionnaires, the majority was female, and there were 238 young adults, and there were 199 patients and 195 guardians. Regarding results, source of information, here are according to this graph, the primary source of gaining knowledge regarding mask wearing and respiratory infection was healthcare professionals, which was closely followed by television or radio and social media or internet. This indicates that the public trust the healthcare workers as well as the new emerging role of the social media or the traditional media. Therefore, it is better to improve the quality of communication between healthcare workers because it will essential for the better health outcome in health promotion. Knowledge on methods of transmission of respiratory tract infections. According to this graph, the correct responses for the aerosols was lower than the correct responses for the droplets. Even though the word aerosol was defined in the questionnaire, this depicts that there is a considerable knowledge gap regarding droplets and aerosols. This may be because of the term airborne transmission is interpreted differently in scientific literature, which ultimately cause a confusion in the society and create a knowledge gap like this way. Overall knowledge score was not normally distributed, and the minimum was 6 and maximum was 18 out of total mark of 19. The median knowledge score was 15.00. We graded the overall knowledge score according to the Bloom's cutoff, and according to that, we found that the majority possessed moderate knowledge score, which was in between 60 to 79%. We compared median knowledge score across different categories, and we found that there was no significant differ across age, gender, categories of experience with COVID-19, comorbidities, and vaccination categories. However, individuals with qualification above school level had significantly higher median knowledge score than those who didn't. This type of same results will appear in a cross-sectional study done in South Korea. Attitudes on mask wearing with vaccination status for COVID-19. Out of the participants who had incompleted vaccination course, the majority was disagreed for the statement that there is no need to wear mask after getting vaccinated in the post-COVID-19 period. However, out of the participants who had completed vaccination course, the majority was agreed for that statement. The difference may arise from incompletely vaccinated individuals feeling unprotected, while fully vaccinated individuals feel protected. Therefore, this reflects that there is a lack of knowledge about other respiratory infections and their impacts. Regarding current practice, the majority declared that there is no current practice of mask wearing those days. However, among all the participants who declared that they were having a practice of mask wearing those days possessed good knowledge score. Over 50% of participants declared that they were wearing masks constantly when they had respiratory infections or someone were close to someone with respiratory infections even during post-COVID-19 period. Maintaining a high proportion of preventive practices with considerable awareness is essential for the reduction of the transmission of respiratory infections because it helps to prevent the spread of aerosols and droplets. However, on observation, we found that majority was not wearing mask in the OPD setup, and out of them, there were 205 participants.
1 minute time left. I'm sorry to say I can see the same slide. Please keep changing slide as you move on. And you just have 1 minute.
Accompanying someone with respiratory symptoms. And among the participants who were wearing masks, the majority were having or either associate with respiratory symptoms. Therefore, this indicates that there is a difference in between declared practices and actual practices. In conclusion, the overall knowledge of the majority on the transmission of respiratory tract infections and mask usage was moderate with reduced mask usage during post-COVID-19 period, even in instances where it would be beneficial. So here are some of our limitations and here are some of our references, and thank you very much for listening.
For your kind presentation. Now I would like to request the tech team to please get the QR code on the screen for audience to vote. I hope the audience can see the QR code on the screen. Please vote the presenter. So thank you. Now I would like to get back to our judge, Dr. Ruchi. Do we have any questions to the presenter?
Yeah, sure. First, Lakmini, I would like to say that it was a nice presentation from your end. Although you spoke well, the unfortunate part was we were not able to scroll down the slides because it was
very sorry,
madam. No issues. The only question from my side is, as you mentioned that there were certain limitations to your study. Since we were not able to see the slide of the limitation, can you just enumerate one or two limitations? What were the challenges for your study?
Means we were using convenient sampling method. There was there could be a selection bias, and also we ask about in our questionnaire we ask about the knowledge, attitude, and practices that from the participants, and there can be a recall bias because they cannot remember well about their practice and they may be just answering the questions. Therefore, there can be a recall bias as well. And also in our country, OPD setup is a very busy setup and the people are just seeking treatment, not coming for participate for research actually. So there may be limited time to go through our questionnaire. Therefore, we hope that there may be some difficulties for the participants to fill out the questionnaires with proper understanding as well, madam.
So there were 3 questionnaires, each of 19, or only one questionnaire comprising of total 19 questions?
We made one questionnaire based on knowledge, attitude, and practices. There was no any validated questionnaires that we could found. We go through some of the previous questionnaires, and we made the questionnaires and then validated our questionnaire and then gave to the participants.
All right. Thank you so much.
Thank you very much.
Thank you, Dr. Lakmani, for your presentation, and thank you, Dr. Buchi, for your question to the presenter. Now it's time to get back to our third presenter, Dr. Ashley Deng, who is going to present a cohort study on the topic psychiatric outcome in patients with trigeminal neuralgia treated with anticonvulsant with or without antidepressant, a retrospective cohort study. You can begin your presentation, Doctor.
Hello, everyone. Can you see my slides?
We cannot see your slides now. Can you please share the screen? Can you please share your slides?
I am sharing screen right now. Is that working?
Sorry, we cannot see the slides. I request the tech team to please help her with the slide.
Sorry, can I just rejoin in 1 second? I think I need to restart my Chrome. Is any of this working?
Sorry, we cannot see anything.
Okay. Yeah, if someone could pull up my slides, that would be great. I can just present from there if that's possible. Can you see this? Yes. Does that work for everyone? Can you see my slides now? Okay, fantastic.
We can continue. We can see the slides now.
Okay, thank you. Sorry for that, everyone. Hello, my name is Ashley Deng. I'm a second year at the Drexel University College of Medicine in the United States. My project is psychiatric outcomes in patients with trigeminal neuralgia treated with anticonvulsants with or without antidepressants. So to start off with the background, acute craniofacial pain is generally well managed, but chronic conditions like trigeminal neuralgia, abbreviated TN, presents clinical challenges. TN affects the trigeminal nerve, causing sudden, intense pain, often described as electric shocks, and that severely impacts quality of life. Causes of TN include primary nerve root compression and secondary factors like tumors or multiple sclerosis, and also idiopathic causes. Compression can lead to nerve fiber demyelination and abnormal nerve impulses, resulting in TN's characteristic sharp pain. It is associated with higher rates of depression, anxiety, and disrupted sleep, with the American Academy of Neurology recommending anticonvulsants like carbamazepine for classical TN treatment. The objective of this study is to evaluate anticonvulsants' effectiveness and explore adding antidepressants to improve psychiatric and sleep-related symptoms in TN patients, where we hypothesize that the combination will enhance our overall outcomes. To discuss a little bit about methods, the data source is a platform called Trinetics, a global health network with over 250 million de-identified patient records from over 120 hospitals. Our study population focused on data from the 61 United States healthcare organizations within Trinetics, selecting patients diagnosed within the last 20 years. The first cohort is TN patients prescribed both anticonvulsants and antidepressants, and the second cohort is TN patients prescribed only anticonvulsants. Patients with pre-existing bipolar disorder, depressive episodes, or persistent mood affective disorders were excluded to avoid confounding, and other chronic illnesses such as cardiovascular, respiratory, or metabolic diseases were not prevalent and therefore not considered. The outcomes, the matched outcomes were assessed using ICD-10 codes listed on the slide for major depressive disorder, anxiety, and sleep disorders. Our statistical analysis comprised of a risk, odds, and hazard ratio using the Cox proportional hazard model. Now, starting to look at our results, this is our table 1, where after a 1-to-1 propensity score match for age, gender, ethnicity, race, each cohort comprised 15,129 patients. Post-matching, both cohorts showed a balanced profile, mean age of 59 years, 73% female, 71% non-Hispanic or Latino, and 71% white. For table 2, we compared risk and odds ratio following the treatment of both cohorts, where patients with TN taking both anticonvulsants and antidepressants had a higher risk and odds for development of depression, anxiety, and sleep disorders than their counterparts taking only anticonvulsants. Depression showed a particularly high increase in risk with a risk ratio of 10.448 and an odds ratio of 10.906. Similarly, in table 3, patients with TN taking both anticonvulsants and antidepressants demonstrate a markedly higher hazard ratio in depression, anxiety, and sleep disorder development. Based off of the Cox proportional hazard model, the larger chi-square value generally indicates stronger evidence of an association between the medication and the outcome, and the chi-square and the p-value indicate whether the medication had a significant impact on the determined outcomes. A p-value of less than 0.05 is generally significant. So for depression and anxiety, the larger chi-square value corresponding with their small p-value less than 0.05 indicate that combination anticonvulsant and antidepressant therapy was statistically significant on the impact on time to development of depression and anxiety, although this is not necessarily the case for sleep disorder. In summary, combining anticonvulsants and antidepressants in TN patients was associated with an increased risk of psychiatric symptoms and sleep disturbances. We hypothesized several factors may explain these findings. Anticonvulsants, commonly used for TN, stabilize neural activity by reducing sodium channel conductance. This may also increase the risk of depression by promoting inhibitory neurotransmitter release or reducing excitatory signaling. And antidepressants, which boost mood by enhancing serotonin and norepinephrine, can also cause side effects like insomnia. When combined, these drugs can interact in complex ways, potentially reducing each other's efficacy, increasing the risk of hyponatremia, and elevating psychiatric risks, including serotonin syndrome. Overall, the study suggests heightened psychiatric risks with the combined use of anticonvulsants and antidepressants. However, careful attention to dosage and the mood-stabilizing effects of anticonvulsants may help mitigate some of these risks. In conclusion, this study is, to our knowledge, the first and largest retrospective analysis of the psychiatric effects of antidepressants on TN patients using anticonvulsants. Given the rarity of TN, a retrospective cohort approach was necessary to gather sufficient data. Our findings highlight the complexities of treatment, suggesting that while anticonvulsants remain crucial for pain management, adding antidepressants may increase psychiatric symptoms in some patients. However, clinicians should consider a multimodal approach that addresses both pain and psychiatric comorbidities, tailoring treatment to unique needs of each patient. We'd like to acknowledge the IJMS, Reading Tower Health Hospital, and the Drexel University MSSRF Fellowship. Thank you.
So thank you, Doctor, for your presentation. Now I would like to get back to our judge, Dr. Ruchi, for a question to the presenter, and Dr. Malik.
Yeah, thank you.
Sure, you can proceed with the questions to the presenter.
Okay, thank you, Ms. Ashley. Can you hear me?
Yes.
Okay, you have a nice presentation, but I have a few questions. My first question is that I didn't really get the rationale behind your study, and what is the novelty in this your study? Can you enlighten me on your novelty and your rationale for this study? Then,
Yeah,
okay,
so this study was significant because trigeminal neuralgia is a very rare disease, and therefore it's really difficult to study and to have randomized controlled trials for it, especially because it also is a chronic pain disease. So there really is no acute treatment. So the novelty and significance of this study is that we were able to, through retrospective cohort analysis, really create a very high power study with over 15,000 patients in each cohort. And also we were able to study the psychiatric effects of different pharmacotherapies, which is something that is not necessarily, that has not been thoroughly studied and has not thoroughly been documented in literature yet.
Okay, thank you.
Thank you, Dr. Malik, for the question. Dr. Ruchi, do you have any question to the presenter?
Yes. Ashley, well done. It was a very nice presentation. I would like to know in which year of medical school are you studying?
I'm a second-year medical student.
So for a second year student, I must congratulate. It's a very huge project that you have undertaken. And just one question from my side, that your objective was to suggest the clinicians about multimodal approach, whereas your conclusion is you want an individualized psychiatric treatment to be prescribed, right? Because a combination is producing troubles, isn't it? It is producing psychiatric complications. So the objective was to start with a multimodal approach, but the conclusion is going against it. So what is your opinion?
Right. I think what we meant by that is that clearly with psychiatric treatment for any patient, it needs to be tailored to the individual based on genetics and different coexisting drugs that the patient may be taking. There can be a lot of adverse reactions. And so what we encourage physicians to do is to be able to, especially with a chronic pain diagnosis, to be able to consider not just treating the pain, which is the anticonvulsant, but also considering the psychiatric symptoms that are usually associated with chronic pain, such as depression, anxiety, sleep disorder, which in some patients may be beneficial to treat with antidepressants, but through our study, not necessarily, it could not necessarily be helpful. But this is why it's important to get the correct dosage and to be able to personalize care.
So according to your study, the nutshell is that you should only prescribe anticonvulsant rather than adding on antidepressants, right?
Right.
Thank you.
Thank you.
Okay, so thank you, Dr. Ruchi and Dr. Malik, for the question. I would like to thank the presenter for presentation. Now, I request the tech team to please get the QR code on the screen. Now, I request the audience to please vote the presenter. Audience, please vote the presenter. Okay, so now I would like to get back to the next presenter, who is now the next presentation is by MD Ali Nawaz Khan, who is going to present on the topic prevalence of diabetes mellitus and its associated factors among tuberculosis cases in Taluk Tuberculosis Unit, India, a hospital-based exploratory cross-sectional study. Welcome, Dr. Ali Nawaz, and you can proceed with the presentation.
Hi, one and all. Am I audible?
Yeah, you are audible. You can proceed, please.
Yeah, is my screen visible to all?
Sorry, we cannot see your screen. Yeah, it's visible now. You can proceed with the presentation.
Yeah.
Yeah, please
Thank
go
you,
ahead.
one and all, everyone. Today I'm presenting by, shall I start? Yes, I'm presenting my study. The title of my study was Prevalence of Diabetes mellitus and its associated factors among tuberculosis cases in Taluk Tuberculosis Unit of India, which was a hospital-based and exploratory cross-sectional study. Myself, Dr. Muhammad Ali Nawaz Khan, and I'm an intern. So just a brief about me as per the norm. So I'm an intern in the state of Karnataka state of India, and a brief as per the norm of our today's event. I should not to just to brag upon. Just a summary of my career of medical life, what I have done and achieved so far. So I have been awarded with the prestigious Dr. APJ Abdul Kalam Memorial Award for my academic excellence by Indian Medical Association, as well as by state government. I have been recognized with Rajiv Gandhi University of Health Science Hall of Fame Award, as well as I have 4 undergoing research projects. Moreover, 45 years of experience international and national awards and 300 chosen this title or gone. We know that currently around one third of the world population has been infected with the tuberculosis, which may be asymptomatic as well. And as per National Tuberculosis Elimination Program (NTEP) of India, it states that there were 25,52,000 cases of tuberculosis in last year 2023. Out of those, the study which was conducted in the state of Karnataka itself had 81,331 cases. Whereas talking about the diabetes mellitus, the Indian population, 9.3% of Indian population is known case of diabetes mellitus. So now both the diseases have a duplex and interacting with each other, as I will just refer through it. There were certain studies which I've gone through, like Fauci et al., who has explained the pathogenesis between the correlation of these two diseases. One of them was that diabetes mellitus, it weakens the cell mediated immunity by dysfunctioning the T cells as well as the macrophages. And as per one of the studies, that was Shrath et al., he had talked about that Th1 is being affected most commonly. On the other hand, tuberculosis, like a chronic comorbidities, which is associated with hyperglycemia due to accelerated counter-regulatory stress hormone production. This was given by our one of researcher, that is Kertix et al. And so amalgamation of these two, one is communicable and another is non-communicable disease, is turned out to be a matter of concern for all. So hence such exploratory study becomes crucial to determine the severity. So the aim of my study is to determine the prevalence of diabetes mellitus and its associated factors among RNTCP, that is Revised National Tuberculosis Control Program of India, who are registered tuberculosis cases in the Taluk tuberculosis unit, and using WHO criteria for knowing the diabetic status. The objectives of my study included to determine the diabetic status of diagnosed cases of tuberculosis and explore the sputum positivity and site of mycobacterium infection among those cases, and as well as to study the socioeconomic class and the nutritional status of them. So the methodology which I have used to derive the study is like it is exploratory cross-sectional study, and the source of data were the hospital based, which is amalgamated to my medical college in North Karnataka state of India and belonging to the Taluk TB unit. Proportion was calculated to be 116 for the study population, which covered about 5% absolute precision with 95% confidence level. And the study was conducted for 6 months from 1st July 2022 to 31st December 2022. Inclusion criteria included all those who were above the age of 18 years of age, admitted to our hospital and were registered case under RNTCP in the third quarter of the 2022, and those who were willing and willingly they have given the informed consent. Exclusion criteria excluded all those who were seriously ill, like ICU patients or were pregnant, and as well as those who denied for the consent. Regarding the ethical consideration, the protocol was approved by the Institutional Ethical Committee. So the entire procedure of my study was like first the study was explained to the patient, and then the informed written consent were taken from them. Socioeconomic and social demographic details were collected and documented, and then the details about the tuberculosis infection, like sputum positivity, site of infections, were also documented. Later, the glucose loading containing that 75 gram of anhydrous glucose was dissolved in 300 ml water and were given. So 2 hours after the giving postprandial, the capillary blood were measured by pricking finger and using the glucometer. And then after the WHO criteria were used to classify the diabetic status on the basis of oral glucose tolerance test. Criteria that included like less than 140 is non-diabetic, 140 to 200 intolerance, impaired glucose tolerance, and more than 200 was declared as diabetic. And then the statistical analysis were done using SPSS software version 19, and the appropriate statistical tests were applied. So the most interesting part of my study, that is the result, which is the most awaited part. In the result, what I have come across, among the study population of 116, 63% were sputum positive, but non-diabetic, whereas only 9.2% were sputum positive and diabetic. Whereas among diabetic, 3.3% were those who were sputum negative, but they were found to be diabetic. In terms of site of infection, it was found that majority, 75.8%, were having pulmonary tuberculosis, but they were non-diabetic. Whereas among pulmonary tuberculosis, only 10.8% were found to be diabetic. Among extrapulmonary like lymph or bone tuberculosis, only 2.5% were non-diabetic, whereas 1.6% were diabetic. Now, socioeconomic status, which was classified using modified BG Prasad classification 2022-24, which depends on the per capita income. That is class 1 less than 952, means like 1,000 per capita income. Class 2 is 1,000 to 2,000. Class 3 is 2,000, 3,000. Class 4 is 3,000, 6,000. Class 5 is more than 6,000 per capita income. So when it was surprising to find that in class 1, none of them were diabetic who were tuberculosis cases. Whereas similarly in class 2 as well, there were no one found to be diabetic. And in class 3, 11.7% were non-diabetic, whereas 0.8% were only diabetic. And moreover, as we go ahead of the class 5, it was interesting to find that 10% were diabetic, where only 5% were non-diabetic. And in nutritional status, when I will look through, that was done using the BMI criteria of WHO for Southeast Asian region. Underweight were less than 18.5 kg per meter square, normal were 18.5 to 22.9, and overweight were above 23 kg per
Dr.
meter square.
Alina, I'd like to interrupt over here. We just have 1 minute time more remaining for the
Yeah.
presentation. So you're supposed to sum up within that limited time.
Thank you. So, what is the aspect we conclude from my study is like this study can be very helpful for the collaboration between the RNTCP, that is for tuberculosis, and NCCDC, that is the National Program for Control of Cancer, Diabetes, and Cardiovascular and Stroke Disease. And we can have more, as we saw the complication, how the improvement and treatment are correlated with each other, how one is involved in the pathogenesis. That will be very helpful. So that is the summary of my study. How many, my only 12.5% were having the prevalence rate of diabetes and tuberculosis, which is against 7.7% of national report of NTEP. So this is the references which I have used in my study. Thank you so much.
Thank you, Dr. Ali Nawaz, for the presentation. Now, I would like to get back to the judges for questions to the presenter.
Okay, thank you, Dr. Khan. It was a nice
Yeah.
presentation. I have some questions. I actually I want to ask you what you meant by exploratory cross-sectional study. I believe you use it as your study design. So can you please explain what you mean by explanatory questionnaire study? And then I observed that
Yeah.
you have many abbreviations in your abstracts. I think you need to try to um, spell out all those abbreviations because someone like laymen may not understand some of these words. So in case of next time, you should try to spell the full meaning of these abbreviations. Then in your presentation, your results section, I realized that you have so many um, percentages without their frequencies. So I believe it's necessary for you to try to include those frequencies alongside with your percentages. And again, I don't know why you give us your brief your introduction about yourself when presenting the abstract. I believe you wasted more time trying to tell us about yourself than even the major work. So next time, you try to be concise and go straight to the point. Thank you.
Thank you so much for compliment. I will try to improve. Yeah, your question was regarding to explain the term I have used exploratory in my study, right? Actually, I want to like when I had done this project, I was in just third phase of my undergrad. So that time I was not being exposed much to this research field and all that. So exploratory, actually, I meant to speak. It was just an exploration to the prevalence in my hospital in North Karnataka state of India. So there was nothing intervention or the
Okay, okay.
experimental
So
aspect from my side. That's why it was just an exploratory. I hope you got the answer for this question.
okay, so can you do you how many cross-sectional studies do we have? Because I know there are descriptive cross-sectional study and observational cross-sectional study. Okay, so I want you to, I don't know, I don't want to lecture you, but I'm confused with this exploratory. So maybe I'm wrong. Maybe there's a new finding about exploration. Uh, okay, but it's okay. Um, maybe you can go back and try to learn more about various study designs so that you will not get confused, because the meat of the matter of this presentation lies on your methodology. Once your methodology is a little bit wrong or shady, you might not get the proper results. You understand? But it's fine. Congratulations to you and all the best. Thank you.
Thank you. I accept it. Thank you so much.
Thank you, Dr. Malik, for the question. Now, I would like to get back to Dr. Ruchi if she have any question to the presenter.
Yeah, Linavas, it was a nice topic to be chosen for an undergraduate student. I would just like to highlight here one thing. If you are keeping the word prevalence in your topic, I think the sample size needs to be sufficient enough. So, according to my knowledge until date, I think that 116 is a bit small sample size for detecting a prevalence rate. So, can you tell us that how you calculated that? What was the method of calculating sample size?
Yeah, I will be very honest about it. Actually, we have a statistical department in our college. I have just gone through to the one. I just sat and discussed with her. So she has one calculating app. We had put through the prevalence of our college as per the pilot study and the studies behind. So I just put it. It was like the confidence rate and all that we had put. So it came out to be around 120. So I know I accept that the prevalence is too low, 116, but I think as per the flow of the patient in my hospital, that was assured by my guide and staff, this should be appropriate for you, which is acceptable value. And being a second year, third year undergrad, I was not being sure what may be the after whatever I was being guided, I just accepted it happily. Thank you.
All right, no worries. So a pilot study was conducted. That is the main
Yes.
thing I was looking for. That was there any reference article? Because generally, when we calculate sample size for prevalence studies, we consider a reference article or a pilot study. So in your case, it is pilot study. So that's all right. Thank you.
Yes, ma'am. Yes, ma'am. There were many. Yeah. Yes, ma'am. I can name a few. It's okay. They were there. Gupta et al. And that Raghuraman, and I remember a few of them. So they had been
They were
conducted
from
in
India.
in Pondicherry.
Indian
Yes, ma'am.
studies.
In Pondicherry, ma'am. Union Territory of Pondicherry. It was conducted. So I remember those names specifically, ma'am. Thank you, ma'am. Thank you.
So thank you, Dr. Ali Nawaz, for the presentation, and I would like to thank Dr. Ruchi and Dr. Malik for their question. Now, I request the tech team to please get the QR code on the screen for audience to vote. So I hope the audience can see the QR code on the screen. I request to please vote the presenter. Okay, thank you. So now let's get back to our next presenter. So our next presenter is Dr. Mian Ahmed Haroon, who is going to present on the topic comparison of sleep hygiene index in virtual, textbook, and hybrid learners in undergraduate students. Welcome, Dr. Haroon. You can begin the presentation.
Hello, can you hear me?
Yeah, you are audible. Please proceed with the presentation.
Good morning, everyone. My name is Mia Ahmed Haroon. I am a fifth-year medical student at Shalimar Medical and Dental College in Pakistan. And today I will be talking about my research, comparison of sleep hygiene index in virtual, textbook, and hybrid learners in undergraduate students. To begin with, let's get to know what sleep hygiene is. Sleep hygiene is a set of behavioral and environmental factors that promote healthy sleep. Inadequate sleep hygiene is presumed from activities that disrupt quality and sleep and daytime alertness controlled by the circadian rhythm, which is influenced by the light-dark cycle. Blue light emitted from screens of devices is known to suppress circadian melatonin release, leading to an increase in evening alertness, sleep latency, and REM sleep, thus causing negative effects on sleep hygiene, leading to sleep loss, irregular sleep patterns, and poor sleep quality. This affects healthcare students, and they are at an increased risk of developing poor sleep hygiene due to the challenging academics and the increased amount of resources that's piled on them. Let's get to know the background of this research. There are several studies that have been carried out related to this topic, And as you can see, there are a significant number of Afro-Asian university students experiencing poor sleep hygiene, and disturbances often linked with mental health issues such as anxiety and depression. Studies among Saudi medical students revealed that approximately 37% reported poor sleep quality. A study in India found that 87% of students who reported difficulty falling asleep had more than 2 hours of screen time. Another study with 293 participants showed that 60% had good sleep, while 39% had poor sleep. A few studies in Pakistan, a study in Bahawalpur found that 61% of students had poor sleep hygiene, with 14% getting less than 5 hours of sleep. Another study in Lahore revealed that 77% of medical students experience sleep difficulties associated with academic stress. The aims and objectives of this study are to determine and compare the sleep hygiene index of virtual, textbook, and hybrid learners, and to find any correlation of screen time with sleep hygiene index. Our methodology includes this study was a cross-sectional study. It is a questionnaire-based study. The target population of this study are the undergraduate students of Shalimar Institute of Health Sciences, and the sample size was 400 students. The students were chosen by simple randomization technique, and the inclusion criteria included MBBS students and allied health students who were above the age of 18. Students using sleeping pills and antidepressants or anxiety medication, or students who are receiving cognitive behavioral therapy were excluded from the study. Data was collected using a validated questionnaire circulated via Google Docs consisting of consent and confidentiality information, demographic details and criteria questions, preferred mode of learning, study screen time, and sleep hygiene index instrument. The SHI score was calculated using the Likert scale. As you can see here, the Likert scale consists of always, frequently, sometimes, rarely, and never, with each option having a specific score. The total sum of the score is the sleep hygiene index score. Scores below 26 are considered as healthy, 27 to 34 are normal, and 35 and above are considered unhealthy scores. Data analysis was conducted using SPSS software 28. Percentage frequencies, chi-square test, ANOVA test, and Tukey's post hoc test were also calculated, and the correlation coefficient was also calculated. As you can see here, approximately 20.9% of students are hybrid learners, 20.9% of students are textbook learners, are virtual learners, and 58% are textbook learners.
Hello, Dr. Haroon.
Hello, I am
Hello,
sorry,
Dr.
I'm facing a technical difficulty.
Yeah, sure, we can hear you. We can perhaps proceed with the presentation. Are you there, Dr. Haroon? I request the tech team to help him to see what he's struggling with.
in undergraduate students, consisting of consent and confidence, and students using sleeping pills, antidepressant medication, or anti-anxiety medication, and receiving cognitive behavioral therapy were excluded from the study. Data was collected using a validated questionnaire circulated via Google Docs consisting of consent and confidentiality information, demographic details and criteria questions, preferred mode of learning, study screen time, and sleep hygiene index instrument. SHI scores were categorized into 3 groups based on the Likert scale. Scores below 26 are considered healthy, scores between 27 and 34 are considered normal, and scores above 35 are unhealthy scores. Data were analyzed using SPSS 28, employing chi-square tests to assess associations between learning modes and SHI scores, correlation analysis to examine the relationship between studies time and SHI scores, and ANOVA to identify differences in SHI scores among different learning modes. Tuckey's HSD post-hoc test was also used to further interpret significant findings. Moving on to the results, the pie chart shows the distribution of different types of learners. 20.9% of students were textbook learners, 20.9% were virtual learners, while 58.1% were hybrid learners. The bar chart on the right shows the percentages of different learners with good, normal, and bad sleep hygiene. Blue represents good sleep hygiene, green represents normal, while gray represents bad sleep hygiene. As we can clearly see, textbook learners show the highest percentage of good sleep hygiene, while virtual learners show the greatest number of students having bad sleep hygiene. Hybrid learners show a more moderate level of sleep hygiene index score. The division of scores in each category can be seen in the table. Now let's talk about the mean SHI scores of each category of learners. The textbook learners had a mean sleep hygiene index score of 21.9, virtual learners with a mean score of 34.8, while hybrid learners had a mean score of 24.5. From the whole dataset, 22.4% of students had unhealthy SHI score, while 23.2% had a normal score, and 54.4% had healthy scores. We also decided to look at the mean scores keeping in mind the age, gender, and academic year of the students. Here we discovered a significant difference between the male and female SHI scores, with females generally having lower scores than males. Lower scores were also seen in students younger than 21 and belonging to lower academic years. As you can see here, as the years progress, the average sleep hygiene score also increases, albeit it's a minor increase. Data analysis by conducting chi-square tests for mode of learning and SHI scores showed significant results with p-value less than 0.05. ANOVA test analysis also showed significant differences in SHI scores in each mode of learners with p equating to 0.0, as well as significant differences in study screen times in different modes of learners. To demonstrate the comparison of differences, Tuckey's HSD post-hoc test were also used for analysis as shown below. There was also a positive correlation between study screen time and SHI scores with correlation coefficient equating to 0.36. Moving on to the discussion, our study aimed to ascertain an association between sleep hygiene in medical students according to their learning styles and to compare their respective sleep hygiene levels. We found that poor sleep hygiene was seen in virtual learners. The proportion of virtual learners with poor sleep hygiene is almost equal to the proportion of hybrid and textbook learners with good sleep hygiene and vice versa. This finding aligns with both our postulation and the findings of previous studies. Our study also shows a significant positive correlation between study screen time and sleep hygiene index score, which translates into worse sleep quality with an increase in screen time. No significant difference was noted in the sleep hygiene indices between various academic years of medical school, indicating that variability in sleep hygiene is widespread and more related to gender and mode of learning than year of medical school. While this study offers valuable insights, its cross-sectional design and single institution radius have contributed to its limitations. We also believe students' incoherency while answering questions may also be a factor. Future researches should explore interventional strategies and the role of technology in improving sleep hygiene. In summary, virtual learners exhibited significantly worse sleep hygiene compared to hybrid and textbook learners, with the latter demonstrating the best sleep practices. An unexpected finding was the significantly higher SHI scores in males, warranting further research to explore whether gender plays a role in susceptibility to the negative effects of screen exposure. The study underscores the importance of educating students about the impact of learning modalities and screen time on sleep hygiene to promote healthier sleep practices in medical education. Thank you for your time.
Okay, so Dr. Haroon, we are glad to have you back in online. Now, I would like to request the judges to please for the questions to Dr. Haroon, Dr. Ruchi, and Dr. Malik.
Dr. Haroon, it was a very nice presentation. I just have one question. Can you tell us the sleep hygiene defining criteria which you have considered for your study?
Dr. Haroon, you are mute. Can you please unmute yourself?
Sorry for that.
Yeah, please go ahead.
Our study was based off of the questionnaire, the Sleep Hygiene Index score. So we based our study on that questionnaire, and we used the Likert scale accordingly, and scored and categorized each individual according to that score.
Yeah, that I have understood. I just want to know, how do you categorize or define what is sleep hygiene? What are the 3 or 4 main parameters?
I am sorry, I don't understand your question.
I wanted to know, how will you define sleep hygiene? What are the parameters based upon which you have judged the Likert scale?
So what basically
I apologize for this.
Dr. Haroon, let me paraphrase the question what Dr. Ruchi said. What she want to know is, can you please operationalize the definition of sleep hygiene? What is sleep hygiene as per your research? In what parameters you have assessed the sleep hygiene?
Sleep hygiene basically is how well rested a medical student is, like how mentally and relaxed they are.
All right. There is just one more question. There is a contradiction in the conclusion of your study, which is not matching with the result that you have mentioned. That is, as the year was increasing, you told that the students who were in the 5th year, they had better scores of SHI. Whereas in your concluding slide, you have mentioned that there is no significant correlation with the year of the study. So how will you justify
Yes,
that?
according to the results, according to those results, as the years progress, the SHI score does increase. But if you
Increase.
look closely, the 5th year students, medical students, they have a worse SHI score from 4th year medical students. The increase is not linear. It is a minor change, but it is not that significant.
All right. Thank you.
Okay,
All
thank you,
right.
Dr. Ruchi. Now, I'd like to get back to Dr. Malik. Do we have any question to the presenter?
Yes, I do. Thank you, Dr. Arun. It was a nice presentation. However, I have a few comments and questions. The first comment is that you have some abbreviations in your abstract, which they are not so good enough. Then when you are presenting your background, I don't know the rationale why you are bolding the result. You are trying to present results in your background of study, which I think is not based on my own knowledge. If you are giving a background of a topic, you can just give us an over an insight and overview of the topic itself. You are not presenting results. So the results should be under your own um, recent study. You understand? Then the question is that in your conclusion, you didn't mention a specific recommendation. You said there's a need for us to promote good sleep hygiene. So who are you trying to refer to? Are you referring to the school authorities or the students themselves or the government? Can you tell us about this?
Uh, okay, this whole study is tailored for medical students
Okay. So
because we are
are you okay? Go on.
yes, yes. So basically, we are trying to for this research. It makes us understand that what is the optimal? How do we optimize studying? Because in this day and age, uh, studying is basically we have to study smartly. We can't just study. We can't just we can't just open books and study and data and information. We have to study smart. We have to optimize time. And in a student barely has any time and has too many things to study. So
Okay.
this
So
is how we optimize.
Okay, yeah, I understand you. My question is that students are attending classes, going for lectures, words, and other activities, and they are under some authorities. So I believe that based on your results, you should have a reasonable recommendations that okay, maybe for the policymakers in the school or the authorities or management or so that okay, we have found this, and the conclusion is that we are trying to suggest that this authority should maybe create more, let's say, accommodation to promote sleep hygiene, hygiene among the students. You understand? So that's my own projection for you. Anyway, thank you so much for your presentation, and I wish you all the best.
So thank you, Dr. Haroon, for the presentation, and I would like to thank the judges for the question. Now I request the tech team to please get the QR code on the screen for the audience to vote for their favorite presentation. I request the audience to please vote with the QR code provided on the screen. Okay, so now we'll switch to the next presenter of the session. I would like to welcome Dr. Jennifer Okei, who is going to present on the topic Enhancing Surgical Skill Proficiency in Medical Students, Analyzing the Impact of Student-Led Skill Labs. Welcome, Dr. Jennifer. You can begin with the presentation.
Good afternoon, everyone. I'm Dr. Jennifer Okei, and I'm the director. Good afternoon, everyone. I'm Dr. Jennifer Okei, and I'm the Director of Research of Surgical Interest Group Lagos, Surgery Nigeria, and I hope everyone can hear me and that my slides are visible. So by way of introduction,
Sorry, we
surgery is
cannot. I'd like to interrupt over here. Sorry, we cannot see your slides. Yeah, it's
oh,
visible now. Yeah, sure, you can proceed with the presentation.
yeah, okay. Are my slides visible now?
Yeah, it's visible. You can proceed with the presentation.
Thank you. Thank you very much. I'll start again. Good afternoon, everyone. My name is Dr. Jennifer Okei. I'm the Director of Research of Surgical Interest Group Lagos, Nigeria, SURGIL. SURGIL is an interest group here in Nigeria that spans across 7 medical schools across the Federation that is focused on promoting the interest of surgery in medical students and early career professionals. And I will be presenting one of our research works titled Enhancing Surgical Skill Proficiency in Medical Students, Analyzing the Impact of Student-Led Labs. Here are my other co-authors, and then this work was done under the supervision of Associate Professor Olufemi Bankole of the Department of Neurosurgery. I declare no conflict of interest and no funding was received for carrying out this study. This is my outline, and then I would like to start by discussing about the importance of basic surgical skills in undergraduate medical education. Surgical skills and surgical training is a very integral part of undergraduate medical education. And unfortunately, in this environment, the acquisition of these skills in clinical medical students is less than optimal. And then this is something that stems from personal experience and then also from similar members in Surgery. And then this is also backed by research evidence. So this led Surgery to develop a 4-week basic surgical skills curriculum for medical students known as the Surgery Skills Lab. In subsequent slides, we're going to refer to as SSL. So SSL, like I said earlier, is a student-led faculty supervised training module. This was done in partnership with the Department of Surgery at the College of Medicine, University of Lagos, to teach medical students basic surgical skills through a series of didactic lectures, presentations, and practical sessions. We decided to incorporate small group learning as each course consisted of 12 to 16 participants in order to facilitate learning and then to be able to have enough time to be able to be taught and be able to ask questions and practice. And then both theoretical concepts and practical concepts were taught, ranging from fracture immobilization to various skills such as suturing, knot tying, and concepts on wound healing. And then this here shows the pictures of, these are just pictures from the events that we had. And then what was our aim? Our aim was to determine the impact of this SSL on the medical students' proficiency, their confidence, and then to also get to also assess the overall satisfaction with the training that they received. So this data was collected at 2 points in time, both at the beginning and at the end of the training. And the participants were the medical students in their clinical phase of study. That's from 4th year to 6th year in the College of Medicine, University of Lagos. And then the data I'm presenting now is results from 2 of the cohorts that was conducted in the early half of 2023. And we got our ethical approval from the IRB here at LUTS. And then the data that we collected were social demographics, basic exposure, the previous experience, and then what their confidence levels were both at the beginning and at the end of the training. The confidence level was measured using a 4-point Likert scale that ranged from 0 to 3, where 0 was their inability to perform the skill at all. 2 was the ability to perform the skill with guidance. 0 was their inability to perform at all. 1 was their ability to perform the skill with guidance. 2 was the ability to perform the skill on their own, but then just that they were going to require guidance at any point in time. And then 3 was the ability to perform the skills independently and on their own. And then on my slide, I listed the 7 skills that were measured in our post-test and pre-test questionnaire. And then the data was analyzed using SPSS version 26. So based on our result, a total of 22 students participated in the training in the first 2 halves, and then they filled the pre-test survey. Unfortunately, 2 students dropped out of the research, but however, they also completed the training. So at the end of the day, the post-test only had 30 participants. And then the participants rate, like I said earlier, were in the clinical phase. But however, most people that signed up for the training were in their 5th year of study. As you can see, by 43.8% of our students were in 5th year of study. And only 6 students, that is 18.7%, had a previous attendance at any other basic surgical skills workshop. So this table that I'm displaying on my slide basically shows us the mean levels of confidence. Like I said earlier, it was a 4-point Likert scale measured from 0 to 3. And then we can see an increase in their confidence levels at the end of the training as evidenced by the increase in the scores across all 4 skills domains. The next chart I'm showing is just a more simplistic version of our results, which the blue chart is the pre and then the red is the post. And then this chart is showing the number of students that were able to perform each of these skills confidently, both at the beginning of the training and at the end of the training. And then we can see that there's a drastic increase in the number of students at the end of our 4 weeks training that were able to perform each of these tasks without any form of guidance at the end of our training. And then the other things that we measured were, in terms of measuring satisfaction, 100% agreed that the training was satisfactory and that the learning environment was positive. They also would recommend these workshops to other students, and then they would very much like to see an initiative like the SSL as a part of the medical student curriculum.
Jennifer, I'd like to interrupt over here. You have just 1 minute left for the presentation, so make sure you wrap up within that limited time.
I will do that. Thank you very much. And then it also demonstrated effectiveness. And then our findings are also supportive in findings that were conducted in other countries. In terms of practical applications of our study, first and foremost, I'd like to talk in terms of curricular development of improving and including student-led training programs, as students can be the teachers and the students and the trainees in order to teach themselves these important skills. We can also, based on the result of our program, students can also form practice clubs, and then this can also be supplemented with support from the faculty, as when they get to practices, they can get to also do this with supervision in the operating room. And then with what we're able to do here in College of Medicine, this can form a template for the development of other advanced surgical skills, such as laparoscopic training in medical students and early career professionals. In conclusion, I would like to say that our study, we're able to demonstrate that a student-led surgical skills training is very impactful and is something that would work in our environment. And then based on the findings that we got, we can incorporate this into our medical training curriculum, as this would really be important and will serve most especially in places with reduced training workforce. And we can also expand this program to other medical schools, both in and outside Nigeria. These are my references. Thank you for listening, and I'll be taking any questions now. Thank you very much.
So thank you, Dr. Jennifer, for the presentation. Now, I would like to get back to the judges. Now, before I get back to the judges, there is a request to judges that please, due to time constraint, we can have just one question from each of you, Dr. Ruchi and Dr. Malik, and please make it very concise and streamlined because we are already running out of time. Sorry for the inconvenience.
All right. Dr. Ruchi, you can ask your question.
Okay. Jennifer, it was a very nice topic to hear out from the point of view of medical education. Just a simple question from my side. The confidence level which were assessed by Likert scale, who was the supervisor for judging their confidence? Like how will you say that so-and-so person is having a better score? Was there a supervisor for the confidence judgment?
Okay. Yes, there was a supervisor. Like I had mentioned earlier, that this training was done in partnership with the Department of Surgery. So we had both residents and consultants from the Department of Surgery on the ground. However, this questionnaire was filled by students. So then from the beginning, we asked them, are they able to do this on their own based on what their previous experience had been with surgical education? And at the ending of the training with numerous practice hours, do they feel that they are able to do this on their own? So they were supervisors, but then they were also the ones that were able to gauge their own learning after numerous practices. Thank you.
Great. Thank you.
Thank you, Dr. Ruchi. Do we have any question from Dr. Malik?
We just a question about the methodology. Can you hear me? Am I audible?
Yes, I can. Yes, I can.
Okay, yeah. I want to ask about the validation of your questionnaire. How did you validate it?
Okay, regarding validation of our questionnaire, so what we did was that we looked at other similar studies that had been conducted both within Nigeria and outside of Nigeria. However, within Nigeria, we do not really find a lot of sufficient literature that spoke about student-led surgical skills, but then we could find papers that spoke about assessing impact of basic surgical curriculums within Nigeria. We found papers from IFE and then also from the North. So we put that together. We also ran Combax Alpha with a pretest. Like I said, this data was from a particular group. We had pre-tested this questionnaire in a previous group, and then results of our Combax Alpha was more than 0.8. And then we also showed this to members of the faculty, both in surgery and then also people from community health epidemiology, before also testing this study. So it was something that we had properly looked at within the research team before pushing it out to ensure that our findings are valid and we're able to say that this here is a fact.
Right. Thank you.
Thank you very much.
Thank you, Dr. Malik and Dr. Jennifer.
Thank you.
Now I request the tech team to please get the QR code on the screen for the audience to vote for their favorite presentation. Okay, so now let's get back to the next presenter. Our next presenter for the session is Dr. Nimeka Emmanuel, who is going to present on the topic Challenges and Limitation among Foreign Medical Undergraduate interested in research study across sectional study. Welcome, doctor. You can proceed with the presentation.
Thank you so much. Okay, can you see my presentation?
Yeah, sure. You can proceed with the presentation.
Okay. I don't know why I can't see my presentation. Okay.
Yes, doctor, we can see the slides. You can proceed with the presentation now.
Okay, thank you so much. So, my name is Nimeka Mgbedo. I'm a medical student from University of Georgia. Today I'll be presenting on a topic titled Challenges and Limitations among foreign medical undergraduates interested in research study, which is a cross-sectional study. And on the screen, you can also see my co-authors who also worked with me, and we have nothing to declare. Okay. Yeah. Okay. First, we understand that research is a systematic investigation process according to Health Insurance for Portability and Accountability Act. We know this. The essence of research is for the progress of the department, and the aim of this study boils down to examining the barriers, challenges that limit foreign medical undergraduates in conducting research study. Okay. In our methodology, as I have stated before now, that this is a cross-sectional study. We have 641 students from more than 6 universities in Georgia who participated in this study, and it was conducted between February 10th to 16th of February 2024. We use SPSS software for our statistical analysis, and this study was approved by the University of Georgia Ethical Approval Team. Okay, in our next slide, we'll talk about the results of the participants. As you can see, the total number, we were able to first categorize the majority of the students from major universities, and the rest of the universities that were like that had just 1 or 2 participants. We categorized them as other universities, and you can see the abbreviation below. As you can see, University of Georgia had the highest participants, as well as other universities like Batumi State University. And on the other side of the slide, the right side, you see the gender difference, 44% of the males and 56% of the females. And from this next slide, you also see the attitude and approach of the students towards research study. Students who say that research is a difficult concept, and students who agreed with that, who disagreed with that, and students who are also uncertain with their response. You can actually see students who say that research is interesting, and students who feel insecure about research, and students who say that research should be mandatory in the universities, as well as students who say that research could be helpful in their skills of study and in their career. And this is what you can basically see on these slides, the number of students and their responses. And in our next slide, you also see that, sorry, next slide, please. Okay, in our next slide, you also see the barriers and challenges faced by these students. I can see, I don't know why they are indicated in numbers, but like this table usually shows the barriers. For example, the students who reported lack of funds, inability to participate because of a lack of cooperation between departments, and also students who reported insufficient time, like the lack of timing based on when they are meant to conduct the research. Next slide, please. Okay, now on this slide, as I stated before now, the other slide was meant to have these variables like the funds, infrastructure, cooperation, interest, motivation, time constraint. So these are our independent samples test, which was conducted, and we only found 2 variables to be statistically significant, which was lack of funds and as well as the lack of access to research materials. Next slide, please. Okay, most of the male students reported that lack of access to research database and also funding was their limitation to this study. And we also found this to be statistically significant at p-value less than 0.05. Next slide, please. Okay, point of discussion in this case is that, yeah, this is a subjective study, but we also observe that lack of research funding, timely projects that are not conducted at the appropriate time. For example, when the student must have graduated or when the student must have passed the semester, and lack of confidence as well as lack of access to research paper was also similar to other studies conducted before our study. We also observed the similarity between these studies. Next slide, please. And in conclusion, I would like to say that our study reported significant barriers and limitations encountered by international students interested in research studies. Most participants require research skills and mentoring to obtain essential skills. We encourage research scrubs, organizations to be able to provide opportunity to students who are interested in research study in order for them to be able to access grants, projects funded by different organizations. And thank you so much. And I wait for your questions. Thank you.
So thank you, Doctor, for your presentation. Now I would like to get back to the judges for the question to the presenter. So we have Dr. Ruchi over here and Dr. Malik.
I just have one question for you, that what was the rationale behind of your study? Because as far as I can read from the discussion, already so many studies have been conducted which have highlighted the role of mentorship and the limited access to grants and projects and all. So what was new, or what was the need for you to conduct such a study? What is the rationale?
Okay, at first, before this study was conducted, we already had a preliminary study which we conducted in the University of Georgia, and we observed significant limitation among foreign medical students, because majority of the students in University of Georgia are international students. So because of that, we wanted to know more about Georgia as a whole, because we have no study which have been conducted. And that was why we decided to go further and be able to know if we can advocate for these students, because you know how important research is in our CV or when we want to apply for residencies. Thank you.
So thank you, Dr. Ruchi. Do you have any question from Dr. Malik? I would like to get back to Dr. Malik. Do you have any question from Dr. Malik to the presenter? Okay, I think Dr. Malik is having some technical issues, so we need to proceed forward. I request the tech team to please get the QR code on the screen for the audience to vote for the favorite presenter. Thank you. Now let's get back to the next presenter. So our next presentation is from Dr. Aditya Saran, who is going to present on the topic a cross-sectional study of hypertension and associated factors in young MBBS students at a tertiary care institute. Welcome, Dr. Aditya. You can proceed with the presentation.
Thank you so much. Am I audible?
Yeah, you are audible. You can proceed with the presentation.
Okay, so hello everyone. Myself Aditya Saran, and I am a third-year MBBS student at HBTMC Mumbai, India. And today I will be presenting my research titled "A Cross-Sectional Study of Hypertension and its Associated Factors in Young MBBS Students at a Tertiary Care Institute." The authors for this research are me and Dr. Sarika Puri, and I will be the presenting author for today. So, starting with the background, hypertension is described as a silent killer by the World Health Organization. It is clinically characterized by persistently elevated blood pressure levels that is above 140 by 90 millimeters of mercury. Hypertension ranks among the top non-communicable diseases, contributing to 5.1% of total deaths, and is a high risk factor for 15% of cardiovascular deaths in India. According to the National Family Health Survey, 1 in 10 young adults suffers from hypertension in India. 13.8% of Indian youth suffer from hypertension, with half of them being unaware of their condition. MBBS students are prone to develop hypertension due to various factors like hectic academic schedules, insufficient sleep, study-related stress, dependence on fast foods, and competitive pressure, which are inherent in medical education. In India, studies on hypertension among medical students were mainly conducted in eastern, southern, and northern regions, and with no such service in western states. Thus, this cross-sectional study aimed to fill this gap by comprehensively assessing hypertension prevalence and potential risk factors among young MBBS students at a tertiary care institute. So, coming to the objectives were to assess the prevalence of pre-hypertension and hypertension, both stage 1 and 2, among young MBBS students, to study the relationship between hypertension and severity risk factors associated with it in this population, and also to draw meaningful epidemiological conclusions and results. Now, coming to the methods, the type of study was epidemiological investigation, with study design cross-sectional, having study population of MBBS students with sample size of 250 students. The inclusion criteria included students from all MBBS batches, right, starting from the first years to the interns, age ranging from 18 to 24 years, either of the sexes, and those who were willing to participate with informed consent. And those students who were not willing to participate or outside the age range or suffering from any kind of chronic diseases, secondary cause of hypertension, or conditions affecting their pulmonary, renal, or endocrine systems were taken as the exclusion criteria. Now, coming to the data collection procedures, students who fulfill the inclusion criteria were invited to participate with the informed consent, and a case study form was used to collect the data, which had 18 questions in total. A total of 3 BP readings were recorded, and the final reading was determined by the average of these. Also, we asked other CVD-related questions like chest pain, breathlessness, palpitations at rest, family history, alcohol or smoking consumptions, fast food intake, and awareness of young adult hypertension. We used JNC 8 classification of blood pressure that divided blood pressure into 4 categories: normal, pre-hypertension, stage 1, and stage 2 hypertension. According to JNC 7 classification, systolic blood pressure of more than 140 millimeters of mercury and diastolic blood pressure of more than 90 millimeters of mercury is hypertension. All the data were then tabulated in the MS Excel sheet, and using SPSS software, significant p-values, odds ratio, and 95% CI were determined. The Institutional Ethics Committee has approved this study. Now, coming to the results. Out of 250 students, 57% were males and 43% were females. We found that 32.4% having pre-hypertension, in which 80.4% were males. Out of 22% of stage 1 hypertension, 81.81% were males. And lastly, 3.2% were found to be stage 2 hypertensive, in which 87.5% were males. Rest were found to be normotensives, in which only 42.5% were males. It was also seen that 34.4% were having addictions to alcohol and smoking, 48.4% were having abdominal obesity, 19.6% were suffering from chest pain, and 18.8% were suffering from palpitations at rest. Lastly, 46.8% were having family history of hypertension. We also determined significant p-values along with odds ratio and 95% CI for the following variables, starting with the pulse rate, having p-value of 0.012, waist to hip ratio 0.019, alcohol or smoking consumptions having p-value of less than 0.0001, which highlights the utmost statistically significant correlation between hypertension and addictions. Lastly, lack of awareness of young adult hypertension have p-value of 0.046. Coming to the implications, this study will help to raise awareness about increasing prevalence of hypertension among young adults and encourage early interventions. It will also help to develop public health policy and future research aimed at reducing the burden of hypertension among this population. Healthcare professionals could prioritize hypertension screening and management starting from a younger age itself. Promoting healthy lifestyles, stress management, and regular checkups could improve cardiovascular health for this population. This study will contribute to the existing literature on hypertension epidemiology and risk factors among medical students. Coming to the conclusion of this study were that from 250 students, 32.4% were pre-hypertensives and 25.2% were hypertensives, both stage 1 and 2. Lifestyle factors and lack of awareness has contributed to this issue. It highlighted the multifactorial nature of hypertension and the importance of addressing the modifiable risk factors. Early detection and intervention strategies could reduce the cardiovascular risks and improve overall health outcomes in this population. So, like all other studies, this study has also certain limitations, which are limited generalizability, potential selection bias, cross-sectional design, single-center study, and cause of hypertension was not known. I thank you for listening to my presentation. Thank you so much.
Thank you, Dr. Aditya, for the presentation. Now, I would like to get back to our judges. Do we have any question to Dr. Aditya?
Yes, Dr. Aditya, I would just like to ask one thing, that you have mentioned about the studies being conducted in the rest of the part of the country and not in the Western states. So what is the difference of prevalence that you have noticed? The study which you have performed is quoting a higher prevalence or a lower prevalence with respect to other regions of India?
So, ma'am, thank you for this question. I found that the study conducted in the southern states were equivalent to the results that we found, and the older studies which were conducted in eastern and northern states were similar to my results. So this was a discussion.
Any non-modifiable factor which you can report from your study? Like you mentioned, gender. Males were having more privilege.
Yes. So, ma'am, obesity can be the modifiable risk factors. The addictions, alcohol, smoking addictions can be the modifiable risk factors. And
I'm asking
yes,
non-modifiable. Yeah.
sorry, non-modifiable can be the age and the gender and the
Family
genetic
history.
factors, the family history. Yes.
Yeah. Thank you. Thank you.
Okay. Thank you, Dr. Saran. I want to ask you a question. Am I audible enough? Okay.
Yes,
Yes,
Doctor,
sir, you
you
are.
are audible.
Okay. Can you tell me one most single important strategy to control hypertension among medical students? Just one most single important strategies to control hypertension among medical students.
Um, so we can do the so we can do some uh, like reducing the to how to control the stress management. We can tell the students how to manage the stress management and to reduce the fast food intakes that can be done and like that.
It's okay. It's okay. You know, you can still do further study research on that. Because I used to ask myself about this hypertension of a teen among medical students. It's not easy because of the academic stress and others. So I still believe that the policymakers can still improve on the academic schedules and activities so that to alleviate fears among these students. You understand? Because medical students are actually fearful to express themselves and to go about their normal lives. But it's fine. You have a very good presentation, and well done.
Thank you so much, sir.
You're welcome.
So thank you, Dr. Aditya, Dr. Ruchi, and Dr. Malik. Now I request the tech team to please get the QR code on the screen so that audience can vote for the favorite presenter. Okay, so now we will proceed with the next presentation, which is a systematic review and meta-analysis by Dr. Khalid Moghib entitled Comparative Efficacy of Intravitreal Aflibercept and Dexamethasone Implant in Treating Macular Edema Associated with Diabetic Retinopathy or Retinal Vein Occlusion, a meta-analysis and systematic review. Welcome, Doctor. We can proceed with the presentation.
Yes, thank you, Doctor. You're listening to me well?
Yeah, we can hear you. You can proceed with the presentation.
Okay. Sorry. It's up here now.
Yeah, we can see the slides. You can proceed with the presentation, please.
Yes, you are seeing the slides well?
We can see the slides, Doctor. You can proceed with the presentation.
Yes, okay. Good morning, everyone. I'm Khalid Moghib, a fourth-year medical student at Cairo University, and I am excited to present our meta-analysis on the comparative efficacy of the intravitreal Aflibercept and Dexamethasone implant in treating macular edema associated with diabetic retinopathy and retinal vein occlusion. This study was conducted alongside with my co-author, Ayman Hassan, Yomna Mahmoud, and Ammar Salah. Thank you, my co-friends. And we can proceed with the background. Macular edema, a major cause of the visual loss. Often complication diabetic retinopathy and retinal vein occlusion. Both diseases are prevalent and can seriously impair vision if left untreated. Currently, anti-VEGF agents like Aflibercept and corticosteroid like the Dexamethasone implant are widely used treatments. However, the comparative efficacy of the safety of these two options in the macular edema management remain uncertain. That's where our study comes in. We have an object and a key parameters. About the object, our primary aims was to evaluate which treatment, Aflibercept or Dexamethasone implant, show greater efficacy and safety in the meaning macular edema associated with diabetic retinopathy and retinal vein occlusion. About key outcomes, such as best corrected visual outcome, best corrected visual acuity, and central retinal thickness, CRT. And there are secondary outcomes like the number of the injections needed, and seriously adverse event were analyzed. The data were analyzed by the Revman. We talk about the methodology. To answer this question, we systematically searched database like PubMed, MBBS, and Cochrane Library to up to August 2024. To be honest, there are a new RCT about this topic at the start of the October. We included randomized controlled trials that examined the efficacy and safety of the post-treatment key outcomes such as best corrected visual acuity, BCVA, and central retinal thickness, the number of the injections needed, and I have already said that before, in the key parameters. Let's go to the result. We included 8 studies comparing 453 eyes. The underlying cause were diabetic retinopathy and retinal vein occlusion. Now let's dive into the data. We will discuss BCVA at the 3 months, 6 months, and 12 months. Here is the analysis. And we have, when comparing the Aflibercept and the Dexamethasone implant, there was no statistically significant difference in the improving BCVA at the 3 months, 6 months, 12 months, no period of other. The BCVA results remaining quite similar between the both treatments, showing neither had a superior effect on the visual acuity. We have the CRT. However, when it comes to reducing central retinal thickness, CRT, the dexamethasone implant showed a significantly better result at the 3 months and 12 months. At the 3 months mark, dexamethasone reduced the CRT by an additional 20 microns compared to Aflibercept with a significant p-value of 0.007. Here is the analysis. I'm sorry, I will go back to safety and adverse effect. Okay. One advantage of the dexamethasone implant is the lower frequency of the injections, making it a more convenient option for the patient. However, it comes with a downside and higher rate of the elevated intraocular pressure. And the cataract formation. So we have here pros and cons. So while effective, it may pose additional risks. Analysis. And I'm sorry to say, to get to the conclusion, to summarize, post-treatment Aflibercept and dexamethasone implant are effective for improving BCVA, no period on other, and reducing central retinal thickness in the macular edema. The dexamethasone have shown the period, showed a superior CRT reduction about the dexamethasone, especially in the short term. Though this comes with the trade-off of increased side effect, ultimately treatment choice should be tailored to the patient's conditions. It's up to the doctor. We have already showed what we found on the analysis, and the numbers don't specify for each patient what will take for the medication. And we reached the acknowledgement, okay, declarations, and thank you. Any questions?
Thank you, Dr. Khalid. It was a great presentation. Now I'd like to get back to our judges. If you have any question to Dr. Khalid with regard to his presentation. Yeah, Dr. Ruchi, you can proceed with the question, please.
Dr. Khalid, since it was a meta-analytical study, I would like to ask you, have you followed the PRISMA guidelines or the flowchart?
Yes. I have already mentioned before.
Go ahead.
I mentioned that there are a new RCT have already added by the October, but I couldn't add it in the analysis as I have already submitted the abstract. That means I am interested in the topic, and I will do the full text paper to the journal.
All right. So you said that till August 2024, you were able to extract only 8 studies out of the PubMed search or Scopus or MBase.
Yes. PubMed, MBase, Cochrane Library. Yes, there too, the database.
So, What were the keywords that you have used along with the Boolean operators? Which Boolean
I didn't
operators
understand
have you used? Which Boolean operators have you used for searching?
I have already about the screening or about the analysis.
Search, PubMed search, how
Uh,
you have performed that? Which keywords have you
yes,
used?
yes, the keywords. Okay, we have a protocol. I can open the protocol and say it. The search strategy. Yeah, I can
Just
do
two
it
or
now.
three words are sufficient, if you can
Yeah,
remember.
exactly.
Yes,
Just to
because
clarify,
we have the sufficiency. Okay, I have the senior. I have a senior from the Turkish. Okay, who added the RCT by the October, and I have already have contact with him, and he revised the this research strategy. But the abstract here, he didn't ask me to add his name, but asked me to put his name in the full paper. Dr.
All right,
Osman.
no worries, no worries. Thank you so much.
Okay, thank you.
okay. Thank you, Dr. Roji, for the question. Do we have Dr. Malik over here? Okay, so now I would like to request the tech team to please get the QR code on the screen so that the audience can vote for the favorite presentation. Okay, thank you. So now we'll proceed with the next presentation, which is going to be predicting extended ICU stay following coronary artery bypass grafting and its impact on hospitalization and mortality by Dr. Aya Jibril. So, hello, doctor, you can proceed with the presentation.
Hello everyone, this is Aya from Amman, Jordan. I recently graduated from Jordan University of Science and Technology. I'm doing my internship here at King Abdullah University Hospital in Erbil, Jordan. 2 months ago, I had the chance to work with Dr. Al-Wakfi and some of our amazing colleagues, and now I'm presenting our work titled ICU Stay Prediction After Cappage, Impact on Hospitalization and Mortality. So, coronary artery disease is considered the #1 cause of death around the world.
So, I would like to interrupt over here, Dr. Aya. We can't see the slides. Can you please share the screen?
Yeah, okay. How can I share the screen?
I request the tech team to please help Dr. Aya.
I don't know how to share the screen.
Yeah, we can see your screen now. You can proceed with the presentation, please.
Okay. So this is Aya from Jordan University of Science and Technology. I am doing my internship here at King Abdullah University Hospital. 2 months ago, I had the chance to work with Dr. Al-Wakfi on our work titled RCU Stay Predictor After Cappage, Impact on Hospitalization and Mortality, and I'm presenting our work today here. Okay. So coronary artery disease are considered the #1 cause of death around the world. And coronary artery bypass grafting is considered the optimal surgical option for treating coronary artery disease cases. Although post-operative complications such as surgical infection and stroke and pneumonia associated with prolonged ICU length of stay, preterm ICU patients discharges associated with higher rates of readmission, leading to higher rates of mortality. Thus, determining the optimal discharge time will help reduce poor outcomes and maximize the operating process. In this study, factors contributing to prolonged ICU length of stay more than 48 hours will be discussed based on patients that had cappage in King Abdullah University Hospital, besides its relation with some complications and mortality. This will help develop a more precise index predicting ICU length of stay and lowering its burden on the healthcare service. Okay, so for the methods, this is a retrospective cohort study included all patients who underwent isolated cappage at King Abdullah University Hospital in northern Jordan between January 2004 and December 2022. A total of 1,095 patients were included. Patients were categorized into two groups: prolonged ICU stay more than 48 hours, with the number was 1,313, and normal stay patients less than 48 hours, and the number was 1,082. So patient medical records were reviewed for prior cerebrovascular accidents, elevation of cardiac enzymes, heart failure, diabetes mellitus, hypertension, chronic renal impairment, and peripheral vascular disease. So we discussed the results as of social and clinical characteristics of included patients and for medical records. And we found that the average of patients in the ICU more than 2 days group was significantly higher, 61.5 years, compared to the ICU less than 2 days group, 58.7 years, with a p-value less than 0.001. And statistically significant differences were observed. Patients with a recent MI in group 1 and the percentage 30% were significantly more likely to have extended ICU stay compared to patients in group 2, which was 17.6%. Similarly, a higher prevalence of smoking was noted among patients in group 1. The percentage was 63.6% compared to group 2, which was 55.2%. Notably, a preoperative AFib, atrial fibrillation, was significantly more common in group 1, that was 8.6% compared to group 2, that was 3.7%. Conversely, hypertension, hyperlipidemia, DM, family history of coronary artery disease, history of central nervous system disease, or history of peripheral vascular disease, and the use of some medication like angiotensin-converting enzyme, statin, didn't show a significant differences between the two groups. So for the effects of a prolonged ICU stay on risk of other complications like mortality and hospital stay, the analysis revealed that prolonged ICU stay significantly increased the risk of post-operative stroke or transient ischemic attack. Similarly, regarding the new onset of pneumonia or sepsis. Additionally, the odds of mortality were notably higher in patients with extended ICU stay. An independent sample t-test were conducted to compare the length of stay in the hospital for patients with ICU stay greater than 2 days and those with ICU stays of 2 days or less. There was a significant difference in the length of stay for patients with ICU stay greater than 2 days compared to those with ICU stays of 2 days or less. So in this study, 313 patients experienced prolonged ICU stay, and we analyzed the pre-operative, operative, and post-operative variables to identify predictors of extended length of stay. Several factors actually didn't show a significant correlation with the prolonged ICU stay. These included mitral regurg grade 1 to 2, ejection fraction more than 50%, ejection fraction 40 to 49%, coronary artery stenosis more than 70%. Additionally, BMI and aortic cross clamp time more than 90 minutes were not significantly associated with extended ICU stay. Conversely, several factors were identified as significant predictors of prolonged ICU stay. These include age, ejection fraction from 30 to 39%, presence of a preoperative coronary artery stents, emergency or urgent surgery, intraoperative blood transfusion, exploration of postoperative bleeding, postoperative renal impairment, and postoperative pneumonia or sepsis. Okay, so for the conclusion, we found that prolonged ICU stays following CABG are largely driven by preoperative comorbidities and intraoperative events. These prolonged stays are linked to a heightened risk of severe
for the presentation.
Yes.
Yes, you can carry on, please.
Yes, so we found that the preoperative comorbidities and intraoperative events, these prolonged stays are linked to a heightened risk of severe postoperative complications and increased mortality. And this study highlights the importance of targeted intervention to shorten ICU stays and enhance the overall efficiency of cardiac surgery care. Lastly, I want to thank my mentor as well as my colleagues who supported me in this abstract. And I'm always want to thank everyone who is watching us right now. Thank you.
So thank you, Dr. Aya. It was a great presentation. Now I would like to get back to the judges. Do we have any question to Dr. Aya?
Dr. Aya, it is really huge to assess the data from 1395 patients. So congratulations for having done that. I just have one contradiction over here. Like you have mentioned in group 2, the average age has been mentioned as 61.8. And for the patients who are having less than 48 hours, you are mentioning it as 58.7. So is that age difference statistically significant as per your analysis? Because it seems more or less similar, like 68, 58 and 61. Yeah.
Yes, so as in our study, we found that the 61.5 years compared to a group to 58, yes, it's not that significantly difference between the two age groups, but a huge difference in the outcomes. So we presented it in our study at the significantly difference in the outcomes between two age of the groups. And we
So
depend
I would
on not
suggest
only...
that you can paraphrase that line and remove that p is less than 0.0, because that doesn't look like having that much significance difference.
Yes. And we signify the patients based on other clinical characteristics like the medical records also.
Yeah, that is fine. That's all right. Outcome basis would be different, but the age difference is not
Yes.
statistically that significant. That was the
Yes.
point. Thank you. Thank you.
Thank you.
Okay, thank you, Dr. Ruchi, and thank you, Dr. Aya. So I request the tech team to please get the QR code on the screen. And yes, so I hope you can see the QR code on the screen. I request the audience to please vote for your favorite presenter. Okay, so thank you very much. So basically we are done with our slot 1 research presentation. It was a wonderful session. Thanks to all the presenters and the judges, Dr. Ruchi and Dr. Malik, for your time. So before we begin our slot 2 research presentations, we are going to have a short 18 minutes coffee break. So see you guys soon. Thank you very much. So, welcome back everyone. We are done with the slot 1 research presentation. Now we'll be continuing with the slot 2 research presentation of this World Conference of Medical Student Research. Once again, I would like to welcome you all, the judges and the presenters over there. So, talking about judges, the judges for the slot 2 research presentations we have now is Dr. Ashish Gupta and Dr. Mornike over there. So, without any further delay, I would like to proceed directly into the presentation. So the next presentation is from Dr. Jaya Surya, who is going to present on the topic when immune deficiency meets neurosurgery, brain abscess in a Wiskott-Aldrich syndrome patient. I request Dr. Jaya Surya to please continue the presentation.
We are going to talk about a rare genetic condition which is called the Wiskott-Aldrich syndrome. In this topic, we are going to talk about immunodeficiency meets neurosurgery, a brain abscess in a Wiskott-Aldrich syndrome patient. So I'm the presenting author, Alkrarha Jayasuriya, and these are my co-authors, and this is my affiliation. And I'm Alkrarha Jayasuriya, a final year medical student from YMB University of Sri Lanka, and I'm presenting this case to you. And Wiskott-Aldrich syndrome is a very rare genetic disorder. It's an X-linked recessive disorder, primarily affecting males. Wiskott-Aldrich syndrome is a very rare condition, and probably majority will haven't be come across through any patients of Wiskott-Aldrich syndrome. And in this case, what happens is there's a mutation of the WAS gene is located in the P arm of the 23, the X chromosome, where it affects the immune function of the body. So the key features of this disease is recurrent infections due to immunodeficiency, where the reduction of immunoglobulin, especially IgG and IgM, and there's eczema and thrombocytopenia. So the patients with Wiskott-Aldrich syndrome is high risk of developing severe infections. As I mentioned, there's a reduction of IgG and IgM immunoglobulins. But the CNC infections like brain abscess are very rare, which is a new presentations and extremely rare presentations which came into diagnostic difficulties and management difficulties. So as I explained earlier, the Wiskott-Aldrich syndrome patients are more prone to both bacterial and viral infections due to immunodeficient status, and brain abscesses are rare. So this case highlights how infected eczema can lead to brain abscess. So the CNS infections are both diagnostic and treatment challenges due to immunocompromised state. So as a case or review, the patient presentation, it was a 4-year-old male boy with already diagnosed Wiskott-Aldrich syndrome, has developed sudden onset abnormal behaviors associated left eye and left limb twitching. But it was not as a typical presentation of a seizure, and there's no associated loss of consciousness or generalized seizures, and supportive features like for the seizures such as loss of consciousness and urinary or fecal incontinence. So as the presentation was on focal neurological symptoms like sudden abnormal behavior, left eye and left limb twitching, the case was directed towards a space occupation lesion. Either we are suspecting a hemorrhage due to thrombocytopenic status or infection. And at that time, patient had a history of recent onset infected eczema treated for MRSA positive Staphylococcus aureus. So this is the pictures of infected eczema. At that presentation time, it was healed. So at the clinical examination, patient was clinically well, afebrile, probably due to immunodeficient state, and neurological examination, there was no focal neurological deficits identified. Other examinations were unremarkable. Also, the recent history of healed eczematous rashes was noted as previously shown. So the initial investigation was directed toward checking with the platelet count and the infections. So WBC was the full blood count, the WBC was elevated with neutrophil leukocytosis, and the platelets was severely low, which is 70 into the 10 to the power 9, and hemoglobin was normal. So we have suspected either, as I mentioned, it's either bleeding in the intracranial hemorrhages or infection of the CNS system. CRP was 25, which is a mild elevation, and NCCT brain was promising and found a brain abscess with a ring enhancement in the right hemisphere. And the blood culture was done as we are suspecting infection. It was also positive for methicillin-resistant Streptococcus aureus. And as this patient has a brain abscess with the comorbid thrombocytopenia and immunodeficiency, the multidisciplinary team approach was done with the pediatrician, neurosurgeon, hematologist, and microbiologist, and other health staff. The pre-surgery optimization done with platelet transfusion at the admission it was 70,000, and IVIG, the immunoglobulin was given as immunodeficient state of the patient, and IV antibiotics was started with the microbiological opinion with cefotaxime, metronidazole, and vancomycin, and neurosurgical involvement done a bare hole drainage of the abscess. In here we can identify the suture line here, and the pus culture of the brain abscess was confirmed, the methicillin-resistant Streptococcus aureus, Staphylococcus aureus. So, as the complications after the surgery, 2 episodes of focal seizures was identified during the post-surgical period, where we have started prophylactic anticonvulsant therapy with clobazam and levetiracetam, and close monitoring was done in pediatric ICU care, and patient was continued improving 5 days duration. As a conclusion, brain abscess is rare but serious complications in Wiskott-Aldrich syndrome and need meticulous clinical assessment, and the importance of early recognition and low threshold for investigations, imaging, and multidisciplinary care. And we needed tailored treatment with antibiotics, seizure management in this patient, and positive outcome with early interventions was promising. Thank you.
Okay, so basically this was the recorded version of the presentation because for some reason we do not have the presenter online over here. So now I would like to request the tech team to please get the QR code on the screen for the audience to vote for the favorite presenter. Okay, thank you. So now we'll proceed with the next presentation for the slot 2 research presentation, which is basically the second presentation entitled Perceptions and Expectation of First Year Medical Students at the Beginning of Their Studies for their course in the field of medicine. So, but before that presentation, there's a short announcement from the International Journal of Medical Students that the conference which we are conducting now, the World Conference of Medical Student Research, is being conducted on annual basis. This is basically the third IJMS World Conference of Medical Student Research, and next year conference will be held on 2025, and the abstract call for abstract will open in June 2025. So I request the interested presenter and those interested researchers, students to please submit their abstracts in the allocated time, which will open basically in June 2025. So thank you very much. And I would like to call the next presenter of the session, Dr. Parsalis, to present a presentation on the topic Perception and Expectation of First Year Medical Students in the Beginning of Their Studies for their course in the field of medicine.
Hello to all, my name is Paskalis Evangelidis and I'm a final year medical student at the Aristotle University of Thessaloniki in Greece. And today I'm going to present our work regarding the perceptions and expectations of first year medical students at the beginning of their studies for their course in the field of medicine. The background and rationale of the study included that the concerns of the first year medical students include the finding of a balance between workload and personal life and questions and fears about their future career. The purpose of this study was to investigate the perceptions and expectations of first year students at the School of Medicine of Aristotle University of Thessaloniki for their course of their studies and their future career at the beginning of their studies. The methods, this is a cross-sectional study. At the beginning, an online questionnaire was developed, and the questionnaire included 3 questions regarding demographic data, 2 open questions, and 3 closed questions. The questionnaire was distributed and completed by first-year students in their first lecture. Statistical analysis and thematic analysis were performed according to the Brown and Clark methods. The response rate was 65.4%. Most of the, about the half and a little bit more of the participants were male, while 35.3% of the participants came from Thessaloniki, which is the city that the university is located. Moreover, for 80.3% of the students, Aristotle University of Thessaloniki Medical School was their first choice. Continuing, most students reported that they were quite confident in choosing medicine for their studies and their career. For this question, a scale from 1, which was the totally disagree option, to 10, which was the totally agree option, were available, and the median agreement score for this question were 9. A significant percentage of students considering likely to practice medicine abroad, with median score 6 in the question, a similar scale which the previous one was available for this question. 26.1% of the participants considering likely to work in primary healthcare units for their after their studies. The findings of the thematic analysis, including expectations and concerns of the students, the expectations including need enrichment of their knowledge, achievement of professional success, completion of their studies in a fair time, and social contribution. Concerns included insecurities about their employment, and also the finding of balance between their work life, the study, and the personal life. In conclusion, the majority of the students feel confident in choosing medicine as a profession. A significant proportion report that they consider likely to practice medicine abroad, while 1 out of 4 consider likely to work in primary healthcare. It is necessary to resolve their fears and concerns through close communication between students and teaching staff. Mentoring is also crucial to this field, and also enhancement of education in primary healthcare unit, in primary healthcare, and exposure to the environment of primary healthcare units from their first years of studies are considered essential. Thank you for your attention, and we are at the disposal for any question.
So again, this was a recorded version of the presentation because for some reason we do not have presenter over here. So again, I would like to request the tech team to please get the QR code on the screen so that audience can vote for the favorite presentation. Okay, fine. So our next topic for presentation is identifying key risk factors for incisional hernia post-emergency laparotomy, insights from a case-controlled study from a tertiary referral center of Eastern India by Dr. Riaz Ahmed Ansari. Welcome, Dr. Ansari. You can proceed with the presentation.
Hello, everybody. Thank you. Thank you for this opportunity to allow me to present on such an esteemed conference. I am Dr. Riaz Ansari, a third-year postgraduate trainee at NRS Medical College, Kolkata, India. The topic of my presentation is identifying key risk factors for incisional hernia post-emergency laparotomy. Insights from a case control study from a tertiary referral center of Eastern India. Next slide, please. Can I proceed to the next slide? I'm having some problem.
Sure, you can proceed to the next slide. I request the tech team to please help Dr. Ansari.
Kindly take me to the next slide.
Yeah, please, you can move on to the next slide.
Hello.
Hello, doctor. We cannot see the slides now. Can you please share the screen? And I request the tech team to please help Dr. Riaz in presenting the slides, in switching the slides.
Yeah.
Yes,
Thank you.
please. Can you, yes.
So why did I choose this study? As you can see on the screen, although we have well-established risk factors for development of incisional hernia, the incidence of incisional hernia remains still high, indicating that there are some hidden factors in the development which have not yet been studied. And despite surgical advancements, incisional hernia remains a significant complication, causing morbidity, mortality, impacting patient quality of life, and increasing healthcare costs. So you can see on screen there are technical components which are well known. But what about the adaptive component? Are we able to adapt to these things in our day-to-day life? No. That is why I chose to delve into the depths of the causes that are not well known yet. Kindly. So the aim of this study is to validate the known risk factors and unearth the concealed factors, if any, playing a key role in development of incisional hernia. So the methodology of this study has been represented by this diagram, as you can see on the screen. The total number of emergency laparotomies that were performed at our institute from 2019 until 2021 were 367. Out of these, 9 laparotomies had history of previous laparotomies, so they were excluded. The total patients who presented with incisional hernia in the follow-up period were 54, but 19 such cases had to be excluded because of incomplete records and could not be followed up. So 35 patients who developed incisional hernia post-emergency laparotomy were taken as cases, and age and sex match controls were taken in equal proportions. Data was collected and evaluation was done, and analysis was done using SPSS version 24. The result of the study has been displayed on the screen. As you can well see, the risk factors that were significant in our study has been highlighted. The preoperative factors were BMI, high BMI, diabetes mellitus, chronic lung disease, and the blood parameters that were significant were low hemoglobin, increased total leukocyte count, in low total protein, low albumin, and increased serum creatinine in preoperative period. And next slide, please. And the post and intraoperative period, the factors that were responsible were the increased operation time, increased blood loss, intraoperative blood transfusion, peritoneal contamination, and also the layered closure of abdomen. Significant factors in post-operative period were SSIs, wound dehiscence, and straining in immediate post-operative period. So the next slide shows the diagram which compares the individual risk factors of our study with the studies that have been previously done on larger basis. So next slide. According to this, you can clearly see there are few factors that were not considered as major factors in development of incisional hernia, but our study has found that these factors were significantly associated in causing incisional hernia. These can be categorized as non-modifiable factors like high total leukocyte count, high serum creatinine, and modifiable factors like increased operative time, increased blood loss, and peritoneal contamination. The alteration and the improvement in these factors can lead to decreased incision hernia rates. So the strategic measures that we propose are preoperative patient optimization protocols and improving surgical skills and decrease operative time and blood loss. And the adaptive component should also play hand in hand with the technical components. Otherwise, knowing the risk factors only doesn't decrease the rates of incision hernia. We must apply these factors in our daily practice. But further studies are needed for external validation. Next. Thank you. This is my surgical team at NRS Medical College, headed by my VS Professor Dr. Utpal Deng. Thank you. Any questions, please?
So thank you very much, Dr. Riaz. It was a great presentation. Now I would like to get back to our judges. Do we have any question to Dr. Riaz with regard to his presentation? Yes, I would like to welcome Dr. Ashish Gupta and Dr. Milikan Soleyan, who are our judges for this slot 2 presentation. Welcome, doctor. Do we have any question to Dr. Riaz? Apologies, we cannot hear you. Can you please unmute yourself?
Yeah, I have one. And first of all, I
Yeah.
want to congratulate you. That was a really beautiful study that also had a social justification that can improve. I congratulate you. Really brilliant. My one major question has to do with your identification of the hidden factors. Was there a conceptual framework that informed the decision about the parameters to search for or to look for an association with? Or was it like a shopping spree? What informed the choices of the parameters you were going to look for? Thank you. Over.
Ma'am, I cannot get your question properly.
So actually, many times when you want to look for variables for your studies, you would develop a conceptual framework, which tells you that there is the possibility that this factor might be associated. So I'm asking that for your study, did you have a conceptual framework or did you just go shopping for variables? Otherwise, if you don't have a conceptual framework, then you're just shopping for variables. Yeah.
No, ma'am. I have done an extensive review of literature. From there, all the factors have been taken into account. And some less known factors have been studied properly to know up the associations with the development of incisional hernia.
Okay, thank you.
So thank you, Dr. Millicent. Do you have any question from Dr. Asis?
Yes. Hi,
Yes,
Dr. Riaz. It was a wonderful presentation and a wonderful study. I have two questions for you. First of all, is there any previous Indian study or any Indian population describing all these risk factors which you have studied in your research study? And
Yes,
do
sir.
we have a comparison for that?
Yes, sir. We do have, but not on a larger scale. These were individual institute studies, sir.
Okay. Actually, you didn't mention any comparison of Indian study. It was a study in our Western population that you compared in your graphs. It's okay. And next question is whether did you find any significant risk factor for or any factor which was like undermined or uh, ignored by any other researchers or in previous studies?
Definitely, sir. Those were highlighted in the conclusion portion of my slide. Those were like increased serum creatinine levels in preoperative period, and in intraoperative period, the duration of the duration of the OT and increased blood loss and peritoneal contamination were responsible for increased risk. So reducing these things were helpful in decreasing the risk of incisional hernias.
Okay, that's all from my side. Thanks a lot.
Okay, thank you, Dr. Asis, for the question, and thank you, Dr. Millicent. And Dr. Riaz, it was a wonderful presentation. Now, I hope the audience can see the QR code on the screen. Please vote for your favorite presenter. Okay, thank you. So now we'll proceed to the next topic, which is basically a systematic review and meta-analysis entitled Frequency Rhythmic Electrical Modulated System Frames and its impact on the treatment of painful diabetic peripheral neuropathy, again by Dr. Khalid Moghib. Welcome back, doctor. You can begin with the presentation.
Yeah, welcome back, Doctor. Yes, welcome again, and thank you for your introduction.
Thank you, Doctor. Please carry on.
Yes, I can start now.
Sure, we can proceed.
Yes, welcome back. I have already shared an abstract before, and my second abstract. Good evening now, not good morning. Good evening, everyone. My name is Khalid Moghib, and I am honored to present the result of our systematic review and meta-analysis on the frequency rhythmic electrical modulated system frames and its effect on the treatment of the painful diabetic peripheral neuropathy. This work was conducted with my co-authors, Ayman Hassan and Yomna Mahmoud. Thank you, my co-authors, all of us from Cairo University. Diabetic peripheral neuropathy, or the DPN as abbreviation, is a painful and common complication of diabetes, affecting a million of people worldwide. Traditional treatment often have a limitation due to side effect or poor tolerance. FREMS, a non-invasive electrical stimulation method, offers a potential alternative for managing neuropathic pain in the diabetes. Our aim in this study was to assess the efficacy and safety of the FREMS compared to the placebo or standard care. The placebo, the papers have already presented as a sham FREMS. We conducted this systematic review and meta-analysis following PRISMA guidelines. Databases such as PubMed, Cochrane Library, Scopus, Web of Science were searched up to February 2023. And I want to comment about that 1 year and about 2 years ago. Yes, till now, the paper haven't been published till now. The primary outcome was pain reductions measured by the visual analog scale, VAS, or similar pain scores. Secondary outcomes, including the quality of the life and the nerve conducting velocities. Data was analyzed using Riveman software, and all steps were pre-specified with the protocol registered on the Prosper. Our final analysis included 4 randomized controlled trials with a total of the 210 patients. FREMS significantly reduced pain compared to the placebo or sham FREMS, I have already mentioned before, both during the day and the night. At the daytime, we found a standardized mean difference of the minus 0.45, indicating a moderate pain reductions, while for the night time, the standardized mean difference was minus 0.41. Both results were statistically significant with the values of 0.005 and 0.03 respectively. However, over time, the efficacy of the FREMS declined and its statistical significance was lost. After the follow-up, the period, by then, the standardized mean difference for the daytime pain was 0.11, and for the night time pain, it was minus 0.13, both of which were not statistically significant. This indicates that while FREMS is effective in the short term, its long-term benefit require further investigation. We have a secondary outcome. When looking at the secondary outcomes, we observed no significant improvement in the quality of life or sensory nerve conduction velocity, motor nerve conduction velocity, and tactile vibration and thermal sensation had mixed results across studies, and no major adverse events were reported up to safety and adverse event. No major adverse events were reported, reinforcing that the safety profile of the FREMS. This is what I hope and what makes me pleasure. So now, I'm sorry to reach the conclusion so fast. In conclusions, the FREMS show us a promise as a drug-free and non-invasive option is a good news for the patient, diabetic patient. It's a chronic patient for managing painful diabetic neuropathy, especially for the patient who don't respond well to the standard treatment. I'm one of them, or who experience intolerable side effect. It provides significant short-term pain relief, and while its long-term benefits are less clear, it remains a safe and well-tolerated alternative. We have a future consideration. FREMS may eventually become part of clinical guidelines for treating PPN, and I will be so grateful and so pleasure. Thank you. Any question?
Thank you very much, Dr. Khalid, for such a great presentation. Now, just a reminder to judge, due to time constraint, we can have just one question per judge. Sorry for the inconvenience, and please make it very streamlined, straightforward. And also, I request the judge to please fill up the score form provided to you at the end of the presentation. Now, welcome Dr. Asis and Dr. Vincent. You can please proceed with the question to the presenter.
Thanks, Dr. Khalid. It was a wonderful study. I must congratulate for you that. I just have one question. Can you please explain the technique of delivering that placebo sham FREMS that you have described?
we have 4 RCTs. All of the RCTs have already implanted the same impulse of the technique. One of them have already have actual electronic, and one of them is chain. So the patient is blinded, and the doctor is unblind.
So the patient doesn't feel any like electricity going through.
No, he feels now at the same feeling on the true frames. One of study is a crossover. No patient have already says that there is have already crossover.
Okay, thank you.
Okay, thank you.
Thank you, Dr. Asis. Do we have any question from Dr. Millicent?
Yeah, I just want to ask, thank you. Very nice study, very useful. Did you register this study with anybody? Did you register it? Did you register the study with Prospero? Did you register the study with Prospero or whatever registration body?
There is a registration of on the Prospero. There are a registration on the Prospero for the study. There is no like the same study, the same a similarity in like this study. We are the first systematic review and the meta-analysis for this topic.
I just wanted to know if you registered it with Prospero. So it's registered. Thank you.
Thank you.
Thank you very much. Thank you, Dr. Khalid, for such a great presentation. And thank you, Dr. Asis and Dr. Wilson, for your time and for the comments. Now, I request the tech team to please get the QR code on the screen so that the audience can vote for the favorite presenter. So here you go. Here is the QR code. I request the audience to please vote for your favorite presenter. Okay, so moving further on, now we'll be heading towards the next presentation of the session, which is vertebral artery dissection secondary to malignant hypertension precipitating a posterior circulation stroke by Dr. Avi. I welcome Dr. Avi on to please carry on the presentation.
Hi, everyone. Thank you for this opportunity. I'm Dr. Avi Singh. I'm currently a neurology resident at Emory. I'm a second year, and I graduated from Government Medical College. This is my slides. I hope it's audible and visible to everyone.
I'm sorry to interrupt, but we cannot see your slide. Can you please share the screen to make sure that we can see your slide? Yeah, now we can see it. Please carry on.
Perfect. All right. So good evening, everyone. Today I present on a topic that's very close to my heart as a neurologist who ties medicine together. This is a case of vertebral artery dissection secondary to malignant hypertension that precipitated a posterior circulation stroke. Moving on, I'm just trying to change my slides. Okay. According to the American Heart Association, about 8 million people succumbed to stroke last year in 2019. But most of these are anterior circulation strokes. About 1/4 of them are posterior circulation, which makes it much harder to understand posterior circulation strokes. All the criteria, all the guidelines that we have, the symptoms that we catch very quickly are based on anterior circulation strokes. So these can be very tricky due to involvement of the brainstem, which has very dense cranial nerves with varying symptoms. Also, the report has emphasized the importance of maintaining high index of suspicion for these situations in emergency settings, because the time frame that you have to catch these strokes and do an intervention is very, very critical, within 4.5 hours. And the earlier, the better, because every minute lost means millions of brain neurons die. And that's what I hope to achieve through this presentation. We had a 35-year-old male with past medical history of hypertension, prior Bell's palsy, left ventricular hypertrophy, and chronic kidney disease, who came to the ER essentially for the following symptoms: some dizziness for the last 8 hours, blurriness of vision for the last 8 hours, a couple episodes of nausea and vomiting, and then a global sensation that was there for the last 2 hours. To begin with, when ED called us, they were more so concerned for a GI issue. And then when we intervened and when we saw the exact symptomatology of these symptoms and the time frame, that made us somewhat concerned that this could have been a neurological issue. Like I said, 10 p.m. the night before, suddenly is when he starts developing this dizziness, which ultimately he starts describing as spinning of the room. and which will be important in as you will see. They also described that he was able to eat just fine when suddenly at the night at about 4 a.m. he started feeling that he could not swallow well and had this globus sensation. Past medical history as described. On the exam, essentially, everything was unremarkable except his blood pressure of 217 by 141. He pretty much agreed to have missed his doses of antihypertensive medications because he was too stressed for the last couple of days and forgot taking those. However, other findings in the physical exam were normal, except nuanced neurological exam, as you will see. So on the surface level, most cranial nerves were absolutely normal. However, when I elicited some nystagmus, there was some concerns bilaterally, which was direction-changing nystagmus, which is important to understand is different from your physiological end-gaze nystagmus. And that was a very subtle hint that something else could have been going on. The other thing that was realized was he did have this left lower sided facial droop, but that is something that was similar to his prior exams during prior hospital visits from his facial nerve palsy. So something that was looking most concerning probably wasn't most concerning. If you see on my exam of the rest of the parts of the nervous system, besides the nystagmus, I did find some left upper extremity dysmetria and some ataxia. And he did have some subtle signs of dysdiadochokinesia on the left-hand side. So strength-wise, everything was great. However, these subtle signs were absolutely abnormal. On our investigations, pretty much everything unremarkable, except a stroke cold was called as soon as I saw this patient. And then we did a CT and a CTA right away. The CT itself was essentially normal with no concerns for any large strokes, no concerns for any bleeds. The CTA did reveal some non-opacification or occlusion of the distal left vertebral artery V3s and V4s. But the important thing to understand is in a lot of people, we can have hypoplastic V3s and V4s. So at that time, a provisional diagnosis of lateral medullary syndrome due to vertebral artery dissection was formed, essentially possibly due to hypertensive crisis. And it's important to understand at this time, it was a working diagnosis. We did manage the patient accordingly, but because we made a diagnosis of stroke, acute stroke in that moment, we did end up giving him dual antiplatelet therapy load of aspirin 325 and clopidogrel 300 milligrams. As you would understand from the timeline, the patient came late at night when the MRIs weren't available right away. So we could not wait for the MRI to confirm it. And again, for a stroke code, unless it's a wake-up protocol, you really don't want the MRI to delay your clinical judgment. After he had already been treated with DAPT for stroke, he got an MRI the next day where the FLAIR imaging did reveal, as you can see, a very slight hyperintensity in the left medullary area, which correlated perfectly with his symptoms. On the DWI, it did show concerns for diffusion restriction, which basically confirms this was an acute stroke and not an older stroke. The importance of things that I want to emphasize over here are that a stroke can have diverse symptoms. You just don't need to always see a left facial droop, or you just don't have to see an arm weakness. You have to have a good understanding of what the brainstem involves and what symptoms can have been caused. And the importance of catching it early is because if it's within the first 4.5 hours is only when you can give intravenous thrombolysis. If it's within the first 24 hours is when you can consider mechanical thrombectomy. If you pass that window, essentially all you can do is conservative management, except DAPT load like we did in this case. The other crucial point is non-con CTs, which are the first screening tool for strokes, are pretty insensitive for posterior circulation strokes. As you can understand, there's a lot of bone at the back, and hence the artifact is so real. So the clinical suspicion for a stroke and the focal deficits is what guided our management. The other important thing is to understand that prior deficits like Bell's palsy could make the diagnosis more challenging. So know what is happening during this encounter and not from what is happening from before. NIH stroke scale is something we used to diagnose the severity of the stroke, which pretty much was low in this case. It was 3, and essentially for the prior Bell's palsy. That needs for a comprehensive posterior circulation strokes NIH scale, because all of these data and the symptoms in the NIH stroke scale are based on anterior circulation strokes. The therapy ultimately for these dissections is anticoagulant versus antiplatelets for 3 to 6 months. Especially for vertebral artery dissections, we end up favoring antiplatelet therapies for 3 months, especially because of the safety profile. However, there is no non-inferiority data for either of them. Wake-up protocol, as I previously discussed. So In conclusion, this was a case that ended up being diagnosed as a malignant hypertension crisis causing vertebral artery dissection leading to a posterior circulation stroke, very much emphasizing the importance of a neurology.
I'd like to interrupt over here. Due to time constraint, we cannot give continuity to the presentation because we are already running out of the time.
Perfect.
So it was wonderful to say apologies for the inconvenience. I would like to request the judges to please have questions to Dr. Avi related to his case.
I have no question. Thank you.
Thank you so much.
It was a wonderful case presentation. I think he presented it very well and he has written it very well. I don't think I have any question from him now.
Thank you, Dr. Gupta. Thank you, Dr.
Thank you, Dr. Millicent. Do we have any question from Dr. Millicent? And I request both of the judges to please submit the score form given to you at the end of the presentation. Now I would like to get back to the tech team to please have the QR code on the screen so that audience can vote. I request the audience to please vote for your favorite presenter. Okay, so moving on. Now I'll be carrying out another case report by Dr. Monica entitled Fox-Furdisy Disease, a Case Report. Do we have Dr. Monica over here? I request the tech team to please run the recorded video.
Hello everyone, my name is Monica and I'm a sixth-year medical student at Vilnius University Faculty of Medicine in Vilnius, Lithuania. And today I would like to present to you a case report on Fox-Furdisy disease. I have prepared this case report together with two of my coordinators, Tadas Raudonis and Gintarė Kazbaraitė, who are both medical doctors and work at Vilnius University Faculty of Medicine, Clinic of Infectious Diseases and Dermatovenerology in Vilnius, Lithuania. So what is a Fox-Furdisy disease? Well, it is also known as apocrine miliaria, and it is a rare inflammatory condition that mainly affects the apocrine sweat glands. It is a chronic blockage of the sweat gland ducts with secondary non-bacterial inflammatory response. It mainly manifests with intensely pruritic papules, with the itching intensifying during sweating, stress, and exercise. The lesions are more predominant in the axillary region. However, it can also affect other areas of the body as well, such as the lips or the genital region. Females are more prone to developing this condition than males, and due to its uneven distribution between the genders, it is thought that the hormonal component is of utmost importance in the development of Fox-Furdisy disease. The symptoms of this condition initially present at the onset of puberty. They are mostly present around the time of menstruation and often resolve at the time of pregnancy or after menopause. The treatment of the disease is often intricate. It requires multiple treatment modalities to achieve optimal results. The options mainly rely on reducing the inflammation and reducing the sweating, as well as inhibiting the sweat duct occlusion. Inflammation-reducing approaches, such as topical calcineurin inhibitors, clindamycin, and corticosteroids, are mostly considered as first-line options. However, retinoids may also be used in order to reduce follicular occlusion. We present a case report. So we had a 23-year-old patient who was referred to a dermatologist due to an itching scalp and hair loss presenting for around 6 months. The patient was otherwise healthy and did not have a family history of similar diseases. Examination of the patient revealed erythematous scalp skin and excoriations. The doctor decided to examine other areas of the skin as well and used digital dermoscopy in order to do that. Scalp follicle hyperkeratosis, as well as perifollicular edema in the axillary region, was observed during this dermoscopy method. Here you can see the pictures of the first visit, and you can see both of the axillary regions here. So these are the pictures made with a digital dermoscope. So in both the right and the left axillary region, you can see the perifollicular edema, erythema, as well as excoriations. Upon further consideration, the doctor decided to perform a punch biopsy, which revealed hair follicle epidermal hyperkeratosis and parakeratosis, as well as focalization, spongiosis, lymphocytic and histiocytic infiltration of the basal epidermal layer of follicular infundibulum. Furthermore, histiocyte accumulation was also observed within the deep segment of the sweat duct, overall indicating that the changes are similar to those seen in Fox-Fordyce disease. Hence, the diagnosis was reached. Therefore, the patient was prescribed 5% minoxidil solution for the scalp area and for the axillary areas, also 10 milligrams of peroral isotretinoin, as well as 1% of pimecrolimus cream for the pruritic regions of the scalp. Upon further investigation, after 3 months, we can see that there has been quite a significant improvement in the patient's condition. The regions are less pruritic, there's less erythema, and there's less perifollicular edema. Here you can see the pictures of the second visit. So we can see that there's less perifollicular edema, there's less erythema, but the most important aspect of this treatment that after the 3 months of treatment, we can see less excoriations, meaning that the itching is better than it used to be. The itching has significantly decreased. So to summarize, the management of Fox-Fordyce disease is often intricate. It requires exploring various different treatment modalities in order to find the most effective approach. And here we presented a case of axillary and scalp Fox-Fordyce disease that was successfully managed using topical calcineurin inhibitors and peroral retinoids. I would like to add that this patient is still monitored and still has visits to the dermatologist. So we are waiting to see what the future visits might bring us. We would like to thank the patient who kindly gave consent for the presentation of this case report at this conference. Thank you very much.
So it was a wonderful presentation. Now I request the judges to please have the question to Dr. Monica with regard to her presentation. So we have Dr. Assis and Dr. Millicent over here. Yes, Dr. Assis.
Oh, sorry.
It's okay, you can go ahead.
Thank you. Thank you, Monica. That was beautiful. It was so nice listening to you and the smooth presentation. I was very impressed with that. I have just a single question. What was the importance, what was the significance of this case presentation for you? Thank you. Over.
Thank you, Dr. Millicent. Dr. Assis, you can please proceed with the question.
Actually, I had also a similar question. Like, when can we suspect this disease or this type of conditions? What are like the most common symptoms, and when to suspect this disease in any patient?
Okay. Thank you for both of the questions. To answer the first question, I think the most important aspect of this case report is that, well, this is a rare condition. And once we meet a patient with this condition, it is often very, very difficult to treat because usually the treatment doesn't work very well. So in this case, we saw quite good results with the treatment that was prescribed to the patient. So we think that this is not a result that we see very often. That's why it's so important to discuss this exact case report. Moving on to, if it's okay, I would like to move on to the second question. Symptoms are very different, but most of the time, the lesions are pruritic, and you can often see the plugging in the hair follicle. So if you could compare it to another condition, it could be similar to hidradenitis suppurativa, but it's not bacterial. It doesn't have the bacterial component in it. So it's similar, but at the same time, it's a little bit
different. So yeah, basically the pruritic lesions and the changes in the hair follicle. That's how you can suspect it.
Okay, thank you. Thank you, Dr. Monica, for such a wonderful presentation. And thank you, judges, for your question.
Thank you very much.
Now I would like to request the tech team to please get the QR code on the screen for audience to vote. So I hope now you can see the QR code on the screen. I request the audience to vote for your favorite presenter. Okay, so with this, we'll be moving on to the next presentation for this slot, which is again a randomized clinical trial entitled Efficacy of Intranasal Fluticasone Nasal Spray versus Intranasal Fluticasone with Oral Montelukast and Levetiracetam in treatment of allergic rhinitis, a randomized clinical trial. And presenter for this session is Dr. Muhammad. Do we have Dr. Muhammad over here? If not, I request the tech team to please get to the video.
Good evening. Myself, Dr. Mohammad Afzal, third year PG resident, Department of ENT, Nijalingappa Medical College, Bagalkot. My guide is Dr. Chandrasekharaya S. Hiramid, Professor and HOD, Department of ENT, S. Nijalingappa Medical College, Bagalkot. My study topic is efficacy of intranasal fluticasone nasal spray alone versus intranasal fluticasone combined with oral montelukast and levocetirizine in treatment of allergic rhinitis, a randomized control trial. Coming to background, allergic rhinitis is characterized by an immunological response facilitated by IgE antibodies inside the nasal mucosa, which is initiated upon exposure to allergens present in the air. The illness under consideration is characterized by symptoms including the presence of watery nasal discharge, nasal congestion, sneezing, and nasal itching. It impacts almost 30% of world, which affecting the quality of life of many persons. It is an antigen-mediated inflammatory process of nasal mucosa and may spread to near paranasal sinuses. Although allergic rhinitis is not a serious disease, it can have a detrimental effect on social life, school activity, and work performance. Impaired performance and cost of medicines can have a significant economic effect. Avoiding allergen along with medication has a major role in treating allergic rhinitis. Wide range of pharmacological medicines and their combinations given through various routes have been evaluated for the efficacy of allergic rhinitis. Nasal congestion due to allergic rhinitis may affect normal sleep and it result in daytime fatigue. Various studies have shown that combinations of antihistamine and anti-leukotrienes in allergic rhinitis has more effective when compared with a single treatment. The objective of my study is to assess the improvement of nasal symptoms in both fluticasone alone group and fluticasone with montelukast and levocetirizine combination group at the end of first month and second month. Coming to methods, my study design is randomized control trial and source of data is patients with allergic rhinitis presenting to ENT OPD. My sample size is calculated as 20, means 20 in each group, 20 in fluticasone alone group and 20 in combination group, and study period is 18 months. Inclusion criteria, patients aged between 18 to 60 years of age with allergic rhinitis symptoms, and I excluded smokers, patients already on oral steroids, patients with recent nasal surgeries, patient with nasal polyposis. Coming to methodology, ethical approval was obtained from Institutional Ethics Committee. A randomized control study was done on 40 patients aged above 15 years who had allergic rhinitis. The diagnosis was made based on allergic rhinitis and its impact on asthma criteria. Patients were randomized by simple randomization into two groups of 20 each. After proper history and physical examination of both nostrils along with CBC and absolute eosinophil count, Group 1 received 2 puffs of fluticasone furoate nasal spray in each nostril twice daily for 1 month. Whereas Group 2 received both fluticasone furoate nasal spray twice daily with oral montelukast and levocetirizine for 1 month. Patients were assessed by daily rhinitis diary card. The symptoms were assessed during the treatment, post-treatment at first month and second month. Investigations like complete blood count and absolute eosinophil count were done. Regular follow-ups were done by phone calls to assess the compliance. The parameters assessed by symptom evaluation score, and symptoms evaluated are the daytime symptoms and nighttime symptoms. Coming to result, all the patients in each group completed the study. Both treatment group were almost similar with respect to demographic and baseline characteristics. The fluticasone alone group was composed of 70% of males and 30% females, but in combination group composed of 50% males and 50% females. During pre-treatment, all the patients in this study presented to OPD with moderate to severe symptoms, means symptom score 2 to 3. And symptom score at 1 month, during post-treatment at first month, 90% of patients in both the group attained a symptom score of score 0. And symptom score at second month, means after stopping the treatment, while analyzing the end of second month, the mean score for all the daytime symptoms were significantly improved in both groups. 35% of patients in group 1 have attained a symptom score of 0, and 65% of patients have symptom score of 1. In fluticasone with montelukast combination group showed a symptom score of 0 in 60% and symptom score of 1 in 40%. So the improvement in total symptom score was greater in fluticasone with montelukast combination group. Coming to conclusion, in the present study, we compared the efficacy of intranasal fluticasone nasal spray alone versus intranasal fluticasone combined with oral montelukast and levocetirizine in treatment of allergic rhinitis, and we concluded that allergic rhinitis was more frequently seen in age group of 20 to 40 years with a male preponderance. The main clinical presentation in our study was sneezing and nasal block. The symptomatic improvement was seen in all patients when compared with the pre-treatment. Both groups showed improvement in symptoms after 1 month of treatment. Better symptom relief seen in fluticasone with montelukast combination group. Patients in fluticasone with montelukast group showed better symptom-free interval after stopping the treatment. There is statistically significant improvement in daytime symptoms on both the groups, and there is improvement in nighttime symptoms, but which is not statistically significant. There is no adverse reactions reported during the study period. These are my references. Thank you.
So I request the judges for the session to please submit the score form allocated for this presenter. And at the same time, I request the tech team to please get the QR code on the screen. I hope the audience can see the QR code on the screen. I request the audience to please vote for their favorite presenter. Okay, so I think now we will move towards the next presentation of this slot. Entitled A Cross-Sectional Study on Lower Back Pain Among Medical Students and Foundation Doctors in Malta. This is going to be presented by Dr. Andrea. So Dr. Andrea, welcome to the session, and you can begin with the presentation.
So, hi everyone. As the presenter said, I am here presenting a cross-sectional study on lower back pain amongst medical students and foundation doctors in Malta, and I hope you can see my slides.
Apologies, we cannot see your slides. Can you please share the screen?
Of course, I thought I would. So. So let me try again.
I request the tech team to please help Dr. Andrea in sharing the slide. I think there is some technical issue with Dr. Andrea. Dr. Andrea, are you there? I request the tech team to please play the recorded video. Hello, Dr. Andrea, are you there?
Yes, I'm here. The browser is not letting me share my screen. Apologies.
Welcome back.
We submitted the recording, so if possible, replay that, please.
Okay, sure. We'll proceed with the recording. Thank you, doctor. I request the tech team to please play the recorded video. Dr. Andrea is facing some technical issue to present online, so please play the recorded video. Okay, so we do not have the recorded video for this presentation by Dr. Andrea. So we are moving ahead with the next presentation entitled Marvels, Medical Students Advancing Research, Visibility, Education, Leadership and Support, Student Driving Initiative. And since we do not have presenting author online over here, this is again going to be a recorded video session. I request the tech team to please get the video on the screen.
Good morning, everyone. My name is Molly Mehta, and I am a third-year medical student at Rush Medical College. And today I am very excited to present a student-led initiative that focuses on bridging the gap between medical students and research opportunities. This initiative is driven by the need to make research more accessible to all students, regardless of gender, experience, or specialties of interest. This is just the table of contents. I will go on about the authors, introduction and aims, methods, results, why, practical application, and a thanks and concluding points of our project. So I wanted to start off by introducing the initiative leaders. We were 6 second-year medical students with the question of why it was so hard to get involved in research, meaningful research. And with that stemmed our great project of creating research from research. and our mission being to empower our peers to engage in meaningful research, driving progress in medical education and professionalism, leaving the community in marvel. So a little bit of background about our project. Research is a critical part of professional development for medical students. Yet many of us face significant barriers in accessing research opportunities due to limited mentorship, lack of structured guidance, and the challenges of integrating research into an already demanding curriculum. And we felt the importance of this was to highlight that persistent gap in medical education of the inaccessibility of research opportunities for many students. And by addressing this gap, we empower our future physicians to contribute meaningfully to advancing medical knowledge. The specific aims of our projects are: 1, to foster peer guidance, making research accessible to all students regardless of their background or specialty via student researcher profiles. 2, create a research training system that integrates with medical school curricula through student leaders running mentorship sessions. And 3, facilitating ongoing communication about current research opportunities at our institution via the creation of a database. So, the methodology behind creation of our networks. We've designed this initiative with the collaboration of not only us 6 second-year medical students, but 4 key faculty advisors. And with this, the 3 key networks were adapted to increase student involvement in research. Number 1, a database. It contains information on research faculty, their projects, and mentorship availability, as well as enabling students to identify potential collaborators of projects. 2, the creation of student researcher profiles, which showcases the experiences, advice, and successful projects of students who have been in the same position and worked the network in a positive way, in a beneficial way to their medical school time. These profiles act as a resource for other medical students to understand how to navigate research opportunities, what needs to be prepared, how to go about it, what kind of conduct and communication can be created. And 3, mentorship sessions. These are student-led sessions which build essential research skills, address knowledge gaps, and encourage collaboration between students and faculty. We're building these connections for people that allow them to be the most prepared, the most ready, and the most expertise needed to engage in a variety of projects, whether it requires specific tools, barriers of communication, and or utilizing multiple people to create a project and put it into action. A little bit about the statistics of our project. In just 10 months since its creation, the initiative has significantly expanded our reach and impact. We've connected over 70 new personnel across the university, this including faculty, technological experts, and student leaders, all working behind the scenes to make this more progressive and more holistic throughout our university. We've gathered about 30 researchers from 6 departments and identified more than 45 available projects with these vetted PIs. And this number is continuously growing with our efforts today. And then we've created 21 student researcher profiles within 13 different specialties with the goal of expanding it to every single specialty. And one other fact that's not on this slide is that we've hosted about 3 mentorship sessions with the plans for more. This initiative has laid the foundation for an accessible, collaborative research culture within our institution, and we can't wait to see it flourish and to grow in something more permanent and reliant for students as medical students come into the university. So our future application and the practicalness of what we've created, we've estimated our network growth and student reach to be exponential in the next year. We've collaborated with key personnel, and first, we've successfully supported first-year medical students in designing and conducting independent research projects, which include learning how to write proposals, conduct literature searches, and analyze data, which allows them to engage in more opportunities as they grow throughout their medical career. These skills are directly transferable to their residency applications and future academic work. Our mentorship sessions are also tailored to fill curriculum gaps, ensuring that students have the research proficiency required for increasing competitive academic environments. This initiative is not just a project, it is a sustainable model for integrating research into medical education. And we have seen this by creating our permanent supported council, and within that, a medical student research access group who are also working on our aims to make sure this stays there long term. So in conclusion, this initiative exemplifies how student leadership and collaboration
Okay, I
can
request
bring.
the team to please close the video because we cannot entertain the submission lasting more than 7 minutes. Now, I request the tech team to please get the QR code on the screen for audience to vote. At the same time, I request the judges to please submit the score form for the presenter. Thank you. Now, before we proceed to the next presentation, I would like to go back to the previous one by Dr. Andre, which entitled as a cross-sectional study on lower back pain among medical students and foundation doctors in Malta. For some technical issues, he is not with us, and I request the tech team to please play the video for Dr. Andre.
So, hello everyone. Today I'm here presenting a cross-sectional study assessing lower back pain among medical students and foundation doctors in Malta. As you may know, low back pain, or LBP, is a significant global burden on both an individual and healthcare and economic level. The burden of lower back pain is predicted to increase over the next years on par with an aging population. However, this disease is not specific to the aging population, and it is also a multifactorial disorder. So factors such as older age, poor general health, physical load on the spine, and psychological stress also affect this disorder. We know that there is a high rate of LBP amongst healthcare professionals, as well as medical students, and factors contributing to this include extended shifts, prolonged periods of standing, manual handling of patients, and high levels of psychological stress. And the aims and objectives of this study was to investigate the prevalence of LBP amongst medical students and foundation doctors in Malta, and to develop an understanding of common LBP risk factors in our target population. Moreover, we strive to derive some recommendations for improving medical student and foundation doctors' overall well-being and career longevity. So, to achieve our aims, we carried out a cross-sectional anonymous questionnaire, which contained demographic and lifestyle factors and questions from the modified standardized Nordic questionnaire on LBP. This was distributed electronically to all medical students and foundation doctors in Malta, and all analysis was carried out using JASP. So this is an example of the questions derived from the Nordic questionnaire which were used. As for the results, we had an approximate total eligible population of 910 participants, of which 319 returned the survey. Preclinical students constituted 204 individuals, while clinical students were 117 individuals. 98 foundation doctors returned the survey completed, and in all categories, the sample size required was achieved. Males made up 34% of our study population, and the most common age group were individuals between 82 and 24 years old. And this was 72% of our population. The majority had a BMI within normal range. So the self-reported 12-month prevalence of LBP was 98%, while the 7-day prevalence was 29%. No statistically significant difference in the prevalence between medical students and foundation doctors was noted. However, females were more likely to have low back pain in comparison to males, as well as students who worked during medical school. So what is the practical application of our findings? LBP is associated with increased disability, decrease in quality of life, and potentially reduced career longevity in medical students and foundation doctors. A way to combat this can be to teach ergonomics early, which can lead to downstream improvement of their posture and working habits, which can relieve these individuals from musculoskeletal pain. In hospital, using a systems approach based on human factors and ergonomic principles can help to tackle these issues using a biopsychosocial perspective. So in conclusion, in Malta, LBP is a significant problem amongst medical students and foundation doctors, and females and students who work are higher risk of developing low back pain. Human factors and ergonomics is one way we can tackle this issue, which can help minimize disability among this cohort and help increase their career longevity.
Okay, so do we have Dr. Andre over here? Dr. Andre, are you there?
Yes.
Okay, welcome. I'm glad to see you. I request the judges to please have questions to Dr. Andrea with regard to his presentation. Dr. Sanskriti, Dr. Asis, and Dr. Millicent.
Yeah, this is Monica, a really great presentation, very, very relevant. And I took that away as something to do. Just a clarifying question in terms of sample size recruitment. How well would you say this is a random sample?
Okay, so we did do a sample size calculation based on an 8% margin of error and the 95% confidence interval, and we have achieved that. So our sample is representative of all cohorts.
Excellent. Thank you.
Okay, now I would like to go back to Dr. Asis. Do we have any question from Dr. Asis?
Yeah, it was a very wonderful presentation. Were there any confounding factors also in your research study?
I do not believe there were any confounding factors as we tried to factor that in. So we assessed if students worked, for example. So we thought that that would be a confounding factor. And we actually found that students who worked did have a higher prevalence of back pain.
Okay, thank you, Dr. Asis. Now I would like to get back to Dr. Sanskriti. Do we have any question to Dr. Andrea?
Yes, thank you for a wonderful presentation. Since the data was collected via a self-reported online questionnaires, did the study accounted for any potential biases like inaccurate recall or exaggeration of any kind of symptoms?
So the biases we tried to mitigate were selection bias. We sent it out to everyone via platforms that everyone has. With regards to recall bias, we asked participants questions regarding back pain in the past 7 days. That way we tried to mitigate recall bias. Also, literature shows that a year for health conditions is a sufficient period of time to try and minimize recall bias. That's why we didn't argue they had back pain more than a year or so.
Okay, thank you, Dr. Sanskriti, for your question. I'd like to thank Dr. Andrea for such a wonderful presentation.
Thank you.
Now, can I get the QR? Yeah, here you go. So we have the QR code on the screen. I request the audience to please vote for the favorite presenter. Okay, so I think now we need to move on to the next presentation. Our next presentation, the last presentation for the slot 2, is entitled Potential Herb-Drug Interaction Among Elderly Nursing Home Residents in Romania. This is supposed to be presented by Dr. Hanna Sebasi. Welcome, Dr. Hanna.
Hello, everyone. My name is Sebeshi Hanna, and I'm a sixth-year medical student at the George Emil Palade University of Medicine, Pharmacy Science and Technology, and I'm here to present you our research on potential herb-drug interactions among elderly nursing home residents in Romania. Herbal supplements are widely used, especially among elderly individuals, as complementary medicine. However, over-the-counter or OTC supplements are often not used with the caution they require, despite growing evidence showing the significance of herb-drug interactions, or HDIs for short. Elderly patients, due to their polymedication and the easy accessibility of these supplements, are particularly at risk. Cytochrome P3A4 is a crucial member of the cytochrome P450 enzyme family, which metabolizes about 50% of all clinically used drugs. These drugs include common ones like statins, immunosuppressants, and sedatives such as benzodiazepines. However, many substances can influence the activity of this enzyme, leading to important drug interactions. For example, inhibitors like grapefruit juice, ketoconazole, valerian, and ginkgo biloba can slow down the enzyme's action. On the other hand, inducers such as rifampin and St. John's wort can increase its activity, speeding up drug metabolism and reducing the effectiveness of these medications. Now let's take a closer look at valerian. Its pharmacological effects are largely due to the valerianic acid and its derivatives. Valerian is commonly found in products marketed as mild sedatives, anxiolytics, and sleep aids. It acts as a partial agonist on the 5-HT receptor in vitro and also inhibits both cytochrome P3A4 and P-glycoprotein, which can influence how other drugs are metabolized. In this table, you can see further interactions broken down that show how valerian enhances the sedative effect of multiple drugs, such as benzodiazepines, barbiturates, SSRIs, anticonvulsants, and antipsychotics. Now we have ginkgo biloba. It is widely used in supplements to enhance brain function and memory, making it popular among older individuals, particularly those with dementia. In the case of Alzheimer's disease, ginkgo is believed to inhibit the aggregation of beta amyloid peptides, which are implicated in the disease's progression. Additionally, it has an antiplatelet activating effect and decreases the expression of the peripheral benzodiazepine receptor. Like valerian, ginkgo also inhibits both enzymes, which means it can impact the metabolism of other drugs. This table shows how ginkgo's enzyme inhibiting effect leads to increased risk of bleeding in the case of warfarin, aspirin, and clopidogrel use, as well as reduced effectiveness of anticonvulsants, increased risk of serotonin syndrome in SSRIs, increased blood pressure with MAOI inhibitors and diuretics, enhanced effect of calcium channel blockers, and reduced effect of haloperidol and omeprazole. The aim of our study was to investigate the predicted HDIs using algorithm-based predictions focusing specifically on the co-administration of herbs and drugs among elderly patients in a nursing home setting in Romania. We used Medscape Interaction Tracker to predict these interactions and categorize them based on their severity. We collected demographic and clinical data from 275 elderly patients in 3 different nursing homes. Our study specifically focused on 10 patients using valerian and 23 patients using ginkgo biloba. We identified potential HDIs using Medscape Drug Interaction Tracker and graded them from 1, minor, to 4, contraindicated. We then conducted statistical analysis to better understand the frequency and severity of these interactions. The study included a total of 275 patients, of which 10 used valerian and 23 used ginkgo biloba. The average age of participants was 84.5 years with a standard deviation of 8.2 years for women and 73 years with a standard deviation of 11 years for men. Regarding gender distribution, 60.6% of the participants were female, while 39.4% were male. In this study, 304 potential drug interactions were identified. Out of these, 9.2% were related to interactions between valerian and ginkgo and synthetic drugs. The severity of these interactions were categorized as follows. 10.7% were classified as grade 1, 42.8% as grade 2, and 46.4% as grade 3, with no interactions classified as grade 4. Focusing on ginkgo biloba, interactions were primarily observed with antiplatelet agents, anticoagulants, and non-steroid anti-inflammatory drugs. For valerian, the most common interactions occurred with benzodiazepines, sedatives, and SSRIs. A significant difference in the interaction between valerian and ginkgo was noted, suggesting distinct patterns of interaction between these 2 substances. Additionally, a regression analysis revealed a significant correlation between the number of drugs a patient was taking and the severity of these interactions, specifically for grade 1 and grade 2. Here you can see the most effective drug classes, the green ones by ginkgo and the purples in the case of valerian consumption, as well as a pie chart showing the percentage of the upper mentioned severity grades. The number of possible interactions between valerian and ginkgo-treated groups was compared using the Mann-Whitney U-test, which revealed a significant difference with a higher number of interactions in the case of valerian. We conducted a regression analysis that showed a significant relationship between the number of drug supplements taken and the number of interactions with severity grades 1 and 2. Additionally, in the case of ginkgo usage, a significant regression was found for HDIs. In conclusion, the study highlighted a significant number of potential herb-drug interactions involving valerian and ginkgo biloba. Nearly half of these interactions were serious enough to warrant increased attention from healthcare providers or a consideration of alternative treatments. Ginkgo biloba most frequently affected antiplatelet drugs, making it a concern for patients on blood thinning medication. On the other hand, valerian commonly interacted with benzodiazepines, sedatives, and SSRIs, which could increase the risk of sedation and other side effects. The regression analysis revealed a significant correlation between the number of drugs and supplements taken. Yes, and it's important to note that the identified interactions on this study are based on predictions and have not been confirmed as clinical outcomes. This emphasis needed for future research to evaluate the actual clinical impact of these HGIs in a real-world setting to better understand the consequences and guide a safer patient care. Thank you so much.
Thank you, Dr. Sebastiana. It was a very good presentation. Now let me get back to judges. So I'd like to get back to Dr. Sanskriti. Do we have any question to Dr. Sebastian?
Thank you for your explorative research. I just want to ask one question. Why didn't you assess the doses or duration of valerian and ginkgo? Because it might varying doses impact the severity or frequency of herb-drug interaction.
I am sorry, I didn't understand the question.
Why didn't you assess the doses or duration of these two drugs usage? Because it might vary the doses impact on the severity or frequency of herbs drug interactions.
Yes, we didn't have much information about dosage and the duration of the medication. That's why we didn't take it into account yet.
Do we have any other question, Dr. Sanskriti?
Okay, it's fine.
Thank you.
Okay, thank you, Dr. Sanskriti. Now I would like to get back to Dr. Asis to have question to Dr. Sebasti with regard to her presentation.
No, I don't have. Actually, Dr. Sanskriti has asked already that question. So it's okay from my side.
Thank you, Dr. Asis. Now, do we have any question from Dr. Millicent?
Yeah, I think the same thing. I wanted to ask about the confounders. That was there a regression for confounders based on the duration of use of the medication and the dose? So I guess we are all thinking the same thing. Yeah, thank you.
Thank you very much. Okay, so thank you, Sebasti, and thank you all the judges. I would like to remind the judges once again to please make sure that you have submitted the score to every single participant allocated during your slot. So basically, I request the tech team please get the QR code on the screen so that audience can vote for their favorite presenter. So here you go. Here's the QR code on the screen. I request the audience to please vote for your favorite presenter, as we'll be having winner based on this also. Okay, so thank you very much. With this, we are concluding the slot 2 of our World Conference of Medical Student Research. And thank you very much. It was a wonderful session. I would like to thank the presenter and the judges over here, Dr. Sanskriti, Dr. Asis, and Dr. Millicent. Now we'll be having a short break of 32 minutes, a lunch break, and then we'll get back for the slot 3 of the research presentation. So see you soon. See you soon. Thank you. So I would like to welcome back the presenters and the judges for this session. We are done with the slot 2 of the research presentation. Now we are back with the third slot of this World Conference of Medical Student Research 2024. I would like to welcome all the presenters over here and the judges for the session. So without any further delay, let me proceed with the next presentation, the first presentation of this slot, which is basically a research article titled "To Test or Not to Test How a Positive Rapid Strep Test May Perplex the Diagnosis of Serum-Sickness-Like Reaction" by Dr. Christodoulos. So hello, Dr. Christodoulos. You can begin with the presentation.
Hello, can you see my slides? Okay. Do you hear me?
Yeah, you are audible. You can proceed with the presentation.
Okay. Hello, my name is Grigoriadis Christodoulos, and I would like to present a case report about serum sickness-like reaction in a patient with a positive rapid strep test. First of all, I'm a medical student at the University of Patras in Greece, and I would also like to thank these three doctors, Dr. Eleftherakis, Dr. Giftopoulos, and Dr. Asimakopoulos for their help. So, what is serum sickness-like reaction, abbreviated as SSLR? SSLR is a rare immunologic disorder which is mainly observed in pediatric patients. The typical presentation includes the following. A patient develops signs and symptoms of systemic inflammation 1 to 2 weeks after the initial exposure to a trigger. The trigger can be either an infectious agent, usually a virus, or a drug. The classic triad is fever, rash, and arthralgia or arthritis, but this is only observed in about half of these patients. The most sensitive but non-specific features of SSLR are fatigue and malaise. The prognosis of SSLR is excellent because serious complications are rare and it is a self-limiting disease. In this picture by my friend Despina, you can observe the main joints which are affected in these patients and the morphology of the rash, which can be urticarial, erythema multiform-like, or maculopapular. Another important topic for this presentation is the rapid strep test, abbreviated as RST. Rapid strep test is the most useful diagnostic test for the investigation of pharyngitis. It allows the differentiation between viral pharyngitis and bacterial pharyngitis caused by Streptococcus pyogenes, thus guiding the administration of antibiotics. According to the current guidelines, a rapid strep test should only be performed in patients who present with pharyngitis and center score of 3 or more. Although this test is considered highly sensitive and specific, its misuse in patients without pharyngitis can lead to false positive test results and unnecessary administration of antibiotics, like in our case. So, what is our case? A 63-year-old female patient presented to the emergency department. She was recently treated for a respiratory tract infection with amoxicillin clavulanate, acetaminophen, and ibuprofen successfully. However, 1 day prior to the emergency department visit, the patient developed malaise, high-grade fever up to 40 degrees, diffuse rash, and diffuse musculoskeletal pain. First, she visited her general physician, who examined her and performed a rapid strep test despite the absence of pharyngitis, which turned out to be positive. I must note that the rapid strep test in this patient was probably unnecessary due to the absence of pharyngitis. In this picture, you can observe the rash of the patient in the emergency department. The rash was present in the trunk and in the extremities. Note the maculopapular and urticarial morphology of the rash. While the patient was in the emergency department, we ordered some lab tests which revealed anemia, and elevated inflammatory markers, providing clear evidence of systemic inflammation without internal organ involvement. Our main concern was a serious streptococcal complication like acute rheumatic fever or toxic streptococcal syndrome, so we decided to admit the patient. The attending physician also decided to administer intravenous fluids and acetaminophen for symptomatic relief and clindamycin for empiric coverage of Streptococcus pyogenes. As I said, our main concern was a serious streptococcal complication, which was ruled out by negative adistreptolysin O titers, negative blood cultures, and normal echocardiogram. We also excluded other causes of infectious diseases associated RAS. So now, what is the most likely diagnosis? Given the extensive diagnostic workup, which was negative, and the classic presentation of fever, rash, and arthralgia in our patient, there was strong clinical suspicion of serum-sickness-like reaction. I must note that SSLR is a clinical diagnosis.
So, doctor, I'd like to interrupt over here. You just have 1 minute time left, so make sure you wrap up your presentation within that time.
Okay, there is no standard laboratory testing in order to rule in or rule out this disorder. So excluded other similar disorders, and we diagnosed SSLR and we decided to treat the patient for SSLR. The presentation was severe, so we administered corticosteroids with tapering. Tapering is very important in order to prevent the recurrence of SSLR. So what are the main key points of this presentation? Simple diagnostic tests like a rapid strep test should be used in a reasonable way in order to avoid false positive test results. These false positive test results can lead to misdiagnosis, even in our patient with a typical presentation of SLR, and unnecessary administration of antibiotics. We must exclude similar disorders like rheumatic diseases or infectious diseases before the final diagnosis of SSLR. Finally, I must note that we have to treat the patient, not the disease, not the test results.
So thank you very much, doctor. It was a great presentation. Now I would like to get back to our judges. So we have Dr. Manith over here, the judge allocated for the third slot of research presentation for the World Conference of Medical Student Research. Welcome, Dr. Manith. Do we have any questions to the presenter with regard to the presentation?
Oh, thank you so much for the welcoming. So I do have one question regarding the presentation. It was a good presentation, to be honest. My question is, you kind of said that there could be false positives regarding the rapid SIS test. What are the false positives that you expect, and how did you work around them and get to the diagnosis of whatever you have right now?
Okay, well, look, there was no evidence of pharyngitis in our case. The patient did not complain about throat pain. There was no lymphadenopathy in the head and neck examination. But I don't know why the general physician decided to perform this test, because streptococcal pharyngitis is a common cause of fever and rash. But Streptococcus can cause rash in disorders, in serious complications like acute rheumatic fever and toxic streptococcal syndrome, as I mentioned. But we did some tests. We did blood cultures. Blood cultures were negative. That decreases the possibility of toxic streptococcal syndrome. We ordered adistreptolysin O titers, which were negative. Adistreptolysin O titer is a very sensitive antibody for acute rheumatic fever. And the echocardiogram was normal. So there was no suspicion of valvular disease, which is... and we excluded other causes of RAS, and we decided that the patient's presentation was secondary to a benign disease like SSLR, and the symptoms were severe. So we administered corticosteroids, and after 2 days, the patient was just fine. So the good response to corticosteroids confirmed the suspicion of a benign immunologic disorder, which was triggered by the respiratory tract, by the recent respiratory tract infection, or amoxicillin, clavulanate, acetaminophen, or ibuprofen. All of these drug agents are known triggers of FSLR, but amoxicillin is the most common trigger epidemiological.
Okay, yeah, that sounds good. Thank you so much.
Thank you, Dr. Mani. Thank you, Dr. Christodoulos. Do we have any other question, Dr. Mani?
No, not at this moment. A good presentation.
Thank you very much, Dr. Mani, for that. Now, I'd like to request the tech team to please get the QR code on the screen. So I request the audience to please vote for your favorite presenter, as we are going to, as one of the parameters to decide the winner will be based on this. Okay, so now let's move forward. So now we are going back. Now we'll be moving ahead to the next presentation of this session, entitled Aortic Aneurysm Inflammatory Cell Detection with Deep Learning Methods by Dr. Nagy. So Dr. Nagy, are you there? So basically we have the recorded version of the presentation over here. I request the tech team to please play it.
Hello everyone. My name is Nagy Christoph, and I'm conducting research at Semmelweis University's Pathology and Experimental Cancer Research Institute in Budapest. My focus is on digital image analysis in cardiovascular pathology. Today, I will be presenting our study titled Aortic Aneurysm Inflammatory Cell Detection with Deep Learning Methods. Aortic aneurysms are the 15th leading cause of death in the US, a silent and deadly condition that often goes unnoticed until it's too late, causing over 5,000 deaths each year. Both atherosclerosis and inflammatory cells play a key role in this deadly progression. Acute and chronic inflammatory cells like neutrophils and plasma cells release enzymes that degrade the structural integrity of the aortic wall, making it vulnerable to rupture. Despite the critical role of inflammation, there is a gap in research how exactly these inflammatory cells contribute to aneurysm progression. Digital pathology, powered by AI and neural networks like multi-layer receptron and residual network, can change this. These advanced tools offer a precise cell analysis, with ResNet excelling in more complex tasks by speeding up the learning process. Our goal with this study was to leverage these methods to better identify and qualify inflammatory cells, compare them with traditional immunohistochemical techniques, and uncover their role in aneurysm growth. We analyzed 13 histological sections of aortic aneurysm samples from the Semmelweis University. First, I randomly selected these 13 hematoxinosin stained digitalized aortic aneurysm slides and selected the 6 regions on each of them, 3 regions with higher and 3 regions with lower inflammatory infiltrate. I proceeded an automated nucleus segmentation using the biological image analysis software BIASH across 10 slides, and I created a training database with over 10,000 elements, categorizing inflammatory cells into 5 groups, paying close attention to have similar nuclei number in each category. We applied MLP and ReshNet to the remaining slides, focusing on plasma and neutrophil cells. Immunohistochemistry was used for validation with CD138 labeling plasma cells and myeloperoxidase labeling neutrophils. Quantification was done using 3D HistoQuant Center nuclear quant module. Statistical comparison was done using ANOVA, comparing the AI models with immunohistochemistry, looking at accuracy and efficacy. Our findings showed a strong correlation between the deep learning models and immunohistochemical results. The proportion of plasma cells was 17 to 8%. Neutrophil detection was also consistent across methods between 7.9 and 5%. The similarity in results confirmed that AI methods can accurately detect inflammatory cells, which are directly responsible for weakening the aortic wall. This fast and reliable detection offers a new path for pathology by possibly predicting the stability of the aortic aneurysm, which can be the difference between life and death. In conclusion, our research demonstrates that deep learning models, particularly MLP and ResNet, can reliably detect inflammatory cells in aortic aneurysms. By integrating AI-driven analysis in pathology workflows, we can significantly improve diagnostic speed and accuracy, especially when it comes to detecting the inflammatory process that are critical in aneurysm progression. This method can also make the way for streamlined workflows in pathology labs. This way, we can achieve more data regarding the aortic aneurysm and better understanding the pathomechanism of it. Thank you for your attention, and I'm looking forward to any questions.
So thank you. Well, we had the recorded version of the presentation, but now we have the presenting author with us. Welcome, Dr. Nagy. I would like to get back to the judges to ask questions to Dr. Nagy with regard to his presentation.
Hi, Dr. Nagy. This is a good presentation and a good research topic to work on. So what do you think are some of the limitations that your work had?
Sorry, can you repeat the question?
What do you think are some of the limitations of your research?
The limitation now is mainly the hardware, because these methods require a large amount of technical hardware. But I think with cloud services, we can use more scientific computers, for example, that can help us to make more and more precise and a better training session, for example, and we can analyze more data.
Okay, that's interesting. So do you think your results are generalizable, or do you think the software or the methods that you're trying to apply are like ungeneralizable at this point for us to use in the regular clinical day and age?
On the aortic aneurysm samples, it is generalizable.
Okay, that's interesting. It's a good presentation. Thank you so much.
Thank you.
Thank you, Dr. Manik, for the question, and thank you, Nagy, for such a wonderful presentation. Now, can we get the QR code on the screen, please? I request the audience to please vote for your favorite presenter. Okay, so now we can move on with the next presenter. So now we have a systematic review and meta-analysis entitled Dihydroartemisinin and Piperacillin for Malaria Prevention in HIV-positive pregnant women, a systematic review and meta-analysis of clinical trials by Dr. Ammar Tariq. So welcome, Dr. Ammar. You can proceed with the presentation. Hello, Dr. Ammar, are you there?
Can you hear me? Can you hear me?
Yeah, you are audible. You can proceed with the presentation.
Okay. So, my name is Ammar Tariq El-Ghadi from University of Khartoum. I'm a recent graduate from the Faculty of Medicine. I will be presenting today the dihydroartemethanine piperquine for prevention of malaria in HIV pregnant women. The prevention of malaria during pregnancy.
Dr. Ammar, I would like to interrupt over here. Make sure that the slide is synchronized with your presentation, because the slide displayed over here is the concluding slide. Can you please run the slides from the beginning?
Okay. Is it? Now this is the first slide.
Can you please start, get back to the first slide and begin the presentation?
Okay. Our study is dihydroartemethanine piperquine for prevention of malaria in HIV-positive pregnant women.
I'm sorry, but I still can't see the first slide. It's again on the conclusion.
It's on the conclusion? Okay. Let me repeat this again. Is it now?
Yes. Yes, now it's clear. Yes, please go ahead.
Okay. So, the prevention of malaria infection during pregnancy currently rely on two important methods, which are the using the public health measure as the insecticide-treated nets, and the second one is the use of the chemoprophylaxis, which includes the sulfadoxine pyrimethamine. However, this drug have shown to have an increase in resistance in Africa recently. So an alternative, or we should have an alternative drug for prevention of malaria in these pregnant women. So our aim in this study was to compare or to find the efficacy and safety of dihydroartemethanine piperquine for prevention of malaria. The dihydroartemethanine piperquine is a long-term acting artemethanine compound, and it is a drug used in treatment of malaria. So our method, we conducted a systematic review and meta-analysis according to the Cochrane guidelines. We included clinical trials investigating HIV-positive pregnant women in their control and in their intervention and control group. The intervention group was the dihydroartemethanine piperquine, and for the control we focused on any other drugs. We included 3 trials with dihydroartemethanine as intervention and placebo as control. So our primary goal, or our primary outcomes, were the maternal, placental, and cord malaria incidence, and the secondary outcomes were the adverse effect. We searched 3 databases, including PubMed, Cochrane Library, and Scopus. We used the RIFMAN for conducting the meta-analysis. So our results show that there is 55% decrease in the odds of malaria during pregnancy for the dihydroartemethanine piperquine group compared to the control group. Also, regarding the malaria at delivery, there is a 46% decrease in the odds of malaria at delivery. These results are both significant, and regarding the placental malaria, also there is 39% decrease in the odds of placental malaria. Regarding the adverse outcome, there was no significant difference between the intervention and the control groups in our meta-analysis. So the incidence of most of the adverse outcomes were similar. This is the meta-analysis of a combined in all the adverse outcomes. Okay, so however, miscarriage alone have shown to have an increased incidence in the intervention group, which is the dihydroartemethanine group, and it's about 3 times higher in the intervention group than the placebo or than the control group. So from this study, we conclude that the dihydroartemethanine piperquine was an effective drug in preventing malaria during pregnancy in HIV positive women. There is no significant difference in the adverse event incidence, so it's to some extent safe. However, the high rate of miscarriage or the high incidence of miscarriage suggests that this drug must be prescribed with caution in this vulnerable population. Also, we recommend that further studies should be done or further clinical trials should be done to investigate the safety of this drug. That's all for this systematic review, and thank you.
Thank you, Dr. Ammar. It was a great systematic review. I would like to call judges. Do we have Dr. Manit over here? Yes. Welcome, Dr. Manit. Do we have any question to Dr. Ammar with regard to his presentation?
Yes, it was a good study and a good presentation, Dr. Ammar. I really loved, the way you kind of presented it or the slides. Now, I have a few more questions in regarding to your design of your study or the methods. So, I mean, you kind of did a systematic review and meta-analysis of multiple RCTs. I understand that. So, what do you think, was the definition of your outcomes, like, malaria or placental malaria? You didn't describe what you mean by malaria there. So,
Okay.
what do you think the malaria is, or how did you what were the criteria on saying it's as a malaria?
Okay, so our definition for malaria was there was two main definition. First was the peripheral malaria, which is diagnosed through ICT or the clinical malaria. These are the main definitions for malaria in my study. However, the meta-analysis was done on the combined clinical or peripheral malaria, or whether it's done through a peripheral test, ICT, or PCR, or the clinical, all of them.
So, regarding that, is this criteria uniform across all the 3 studies that you included as a part of your meta-analysis? All the 3
Yeah.
studies followed the same criteria to define malaria
No.
or placental malaria?
No. Because some of these studies have only focused on PCR, for example, or peripheral malaria. So while others diagnosed as clinical malaria. So we try to combine all this.
Okay. Okay, I understood that. Also, another question regarding the adverse effects that you had. You told me that most of the adverse effects, like low birth weight and stillbirth, were not statistically significant. Do you think increasing the power of the sample could have been, some criteria which could have given you a little statistical significance, given that if you get some further RCTs done in the future?
Well, I couldn't understand your questions. Can you repeat it?
Okay, no issues. So, you only had 3 studies with, so much amount of population size that you had. Do you think further research with further RCTs, if you can, get those data as well, do you think you could get some statistically significant results?
Yeah, I think that because this is one of the important limitation for our study, that there is only the randomized clinical trial, and you can see that the difference in the size of the sample for the different trials had affect the results. So yeah, further trials will generate a more statistically sound meta-analysis.
It's interesting that you did your meta-analysis using Refman as your software. Do you think carrying out a sensitivity analysis could have given you a clear picture with whatever results that you had?
Yeah, maybe it will give more clear picture.
Okay, it's interesting. Thank you so much. And it's interesting findings. Thank you for your presentation and your research.
Thank you. Thank you.
Okay, thank you. Thank you, Dr. Manit, for the question, and thank you, Dr. Ammar, for such a great presentation. Now, can I get the QR code on the screen, please? So here you can see the QR code on the screen. Please vote for your favorite presenter. Okay, so now let's move on. So now we have another presentation entitled Assessment of HIV Prevalence in Adults within the Allied Community in Benue State. And the assigned presenter is Dr. Oboli, Dr. Deborah Oboli. And unfortunately, she is not online with us, so I request the tech team to please carry on with the recorded video.
Hi, my name is Oboli Deborah. I'm going to be making a presentation today on the assessment of HIV prevalence in adults within Alede community, Benue State, Nigeria. But before I proceed, I really want to say a very big thank you to the World Conference of Medical Student Research for giving me this opportunity to showcase my work and to make a presentation in this conference. So I'm going to be talking a little bit about myself. I'm Oboli Deborah, a highly motivated early career public health professional and a mental health advocate. I have a very strong academic background from the Niger Delta University, and I am committed to advancing global health and eradication of infectious disease, both in Nigeria and on a global scale. My co-authors for this project are Buche Monica Norika, By Blessing Oluchi, and Yenginfa Tonte Megan. Now, for this presentation, we're going to be making it on this outline. All right, as a method of introduction, Benue State of Nigeria is Nigeria's high-risk zone for HIV. This is based on the Federal Ministry of Health. HIV itself is estimated to have a prevalence of 4.8% among adults aged between 15 to 64 years and is notably higher among females at 6.3% and lowest among males at 3.5%. Now, Benue State is the second highest HIV prevalent state in Nigeria. This is also based on the latest research from the Federal Ministry of Health. And then the infection rate continues to rise in rural areas despite relatively high awareness level, just like the Alede community, which propelled this research. Now, this study is focused on Alede community, which is a small Tiv community in the Benue State. And this study was conducted by randomly testing 500 adults, outpatients, aged between 15 to 64 years over a period of 5 months. Now, the aim of this study was to assess the prevalence of HIV among at-risk population and also to establish methods of risk reduction and to improve the health, quality, and length of life of adults within Alede community. The objective of this study were to determine the percentage of population currently living with HIV, to measure the proportion of people living with HIV who are aware of their status, and also to assess the proportion of people living with HIV who are linked to care and receiving the antiretroviral therapy. Now, this study was carried out as a hospital-based randomized study, and then it was conducted in the Alede General Hospital of Benue State, where I currently work. And it was carried out on 500 adult participants aged between 15 to 64 years with informed consent taken from all participants. Now, the sampling technique of this study was a seropositive sampling method, which was confirmed by supplemental assay. The data was collected over a period of 5 months using the rapid diagnostic testing algorithm according to the Nigeria's national HIV testing guideline. The data was analyzed using the IBM SPSS version 26, and all aspects of the work was conducted with the ethical approval of the Benue State Ministry of Health. Now, from the 500 respondents which participated in this study, now we selected them within the mean age of 39.4 years. And then from these 500 respondents, 205 were males and 285 were females. Now, over half of these respondents were married, and then approximately 70% had only secondary education. So the people that had university education or a higher level of education were very few. And then some of them too had below secondary education, because the population of people living in Alede community are majorly farmers, people that plant crops and then do agricultural businesses. Now, when 90% of the respondents were aware of HIV, only 60% had previously undergone testing, which is actually a problem we face in this community. Now, the prevalence of HIV was 5.6% all over, with 6.7% among females and 3.3% among males. Now, after this research was carried out, we found out that there were factors that contributed to high prevalence of HIV in this community. And some of these factors included certain cultural norms. These community people, they had cultural norms about HIV, like the use of contraceptive, the use of protection to prevent them from contracting HIV, and also the presence of large sexual networks. Network was also one of the contributing factors, and then the seasonal migration of agricultural laborers. So, like I said before, the major method of occupation, or the major occupation of people living in this community is farming. So during the farming season, some of these participants or the citizens of this community, they migrate from one place to another in order to plant their crops and then harvest. So during that period, they tend to be very promiscuous. And that was one of the reasons, even the major reason, why we saw the high prevalence of HIV in this community. Now, fear of stigma, which may prevent people from seeking testing or treatment, was also one of the contributing factors. In conclusion, now the prevalence of HIV.
Okay, so since this was a recorded show, I request the judge to please submit the score for the presentation. And at the same time, I request the tech team to please get the QR code on the screen for audience to vote. So here is the QR code for the audience to vote for the favorite presenter. Okay, so we can proceed now. So we can proceed with the next presentation now, which is again going to be a video presentation entitled Enhancing Medical Education, the Impact of Deliberate Practice on Learning Human Physiology by Dr. Julia Silva. I request the tech team to please play the video, the recorded video for the presentation.
Good afternoon. My name is Julia Souza, and I'm a medical student from Belo Horizonte, Brazil. And I'm the author of the abstract Enhancing Medical Education, the Impact of Deliberate Practice on Learning Human Physiology, alongside my colleague Lavinia Penido and our teachers Ayrton Martins and Augusto Scalabrini. Deliberate practice is a form of simulation-based learning, which is an active teaching method and in which the student's performance is monitored by the teacher. It is already known that these active teaching strategies produce better results than traditional ones because they enhance skills like self-confidence, teamwork, and leadership, among many others. However, they are still underutilized in the undergraduate level of health education. Our goal with this study was to determine the effectiveness of implementing deliberate practice in the teaching of human physiology in a medical course and a private medical school in Belo Horizonte. To do that, we did an observational mixed method study carried out in 2022 and 2023. An online questionnaire was developed by authors so students could answer and assess their perception of deliberate practice in the teaching of human physiology. The calculated sample size was 196 students that ranged from 9 different semesters. The questionnaire was divided into 5 blocks, being general questions, emotions, skills, debriefing, and personal opinion. The 5th block of personal opinion consisted of open-ended questions for students to identify aspects to be improved. And the Likert scale was the method chosen to evaluate the questions in the first 4 blocks, with responses ranging from 1 to 5, 1 being strongly disagree and 5 being strongly agree. Our information analysis was made using Fisher's exact test at 0.05 level of significance to determine the association between categorical variables. To do that, we summed up the responses in each section according to their correspondence in Likert scale. For instance, in the first section, titled General Questions, which had 5 statements about the student's learning experience, the scores were divided into 3 categories, 5 to 15 being mostly disagree, 16 to 20 neutral, and 21 to 25 mostly agree. Then we did the same thing for the other blocks. The emotions block was an exception because we divided into positive emotions like motivation and negative emotions such as anxiety. And then we subdivided them into categories 3 to 5, 8 to 11, and 12 to 15. The results were organized in tables to demonstrate the findings. Overall, the students had a positive perception of deliberate practice. In the general questions, for example, 83.7% of students completely agree that the access to realistic simulation environments contributed to their learning. In skills, for example, 66.8% of students strongly agreed that the deliberate practice helped them acquire skills like teamwork. On the emotions block, we had a greater variability of responses, which means students had different responses to being put in these scenarios. 67.9% of them completely agreed that they felt motivated, for example, while 37.8% agreed that they felt anxious. About the debriefing, 83.7% of them completely agreed that the mistakes made during the scenario, which were then reflected upon in the debriefing moment, contributed to their learning of the subject. We also had some very interesting answers to the open-ended question, would you change anything in the application of the scenarios? And we put some examples here to demonstrate. Some said that they would create more scenarios with smaller groups in each. Some suggested to approach topics in the scenarios that were also being studied in theoretical classes. And some said that they would like to put the practical classes in all semesters instead of just one. Someone also suggested to put some emotional preparation beforehand to diminish anxiety. And someone said to reduce the time of the briefing to make the classes more dynamic. Our statistical analysis revealed a significant association between the sum scores of each section and the binary response to the variable, do you like practical classes of human physiology? With the exception of the negative emotion sum. This indicates that higher scores, 21 to 25, representing agree and strongly agree, are associated with a greater likelihood of students liking the practical classes, except for the negative emotion sum. This is already to be expected because in this sum, these higher scores correspond to students answering agree and strongly agree to feeling discomforting emotions like stress and anxiety. And this would not have an association to the enjoyment of practical classes. So this is the table that we did with the results of our analysis and the values that we found. Practically speaking, these results could help us to develop and implement more active teaching strategies in a myriad of different health classes. Since the beginning of the medical school, for example, and this would then improve the training of future health professionals. So to conclude, the implementation of deliberate practice in the human physiology curriculum in our study demonstrated to have a positive outcome in students' perception and had a beneficial impact on students' learning and skill development. However, there is still need to further improvements and to refine the scenarios for a safer and emotional environment for undergraduate students. I would like to thank my colleague Lavinia Penido for being such a companion during this research, and also our advisors, Dr. Aito Martin.
Okay, so it was again a recorded presentation. Now, can we please get the QR code on the screen so that audience can vote? And at the same time, I request the judge to please submit the score for this recorded presentation. Okay, so now we can proceed with the next presentation. So moving on to the next presentation of this slot, it's again a video presentation coming on our way entitled Benefits of Pulmonary Lobectomy in Infection by Actinomyces. And the presenting author will be Mauricio. This is again going to be a recorded video presentation. I request the tech team to please play the video for this recorded presentation. So we have the presentation entitled Benefits of Pulmonary Lobectomy in Infection by Actinomyces. The presenting author is Mauricio Saldana Ruiz. And since the presenting author is not here, I request the tech team to please play the recorded video. Apologies for inconvenience. I think there is some issue with the technical team. They are joining soon and the video will be played soon. So basically, this is going to be the third last presentation of our third slot for this conference. I think we are back with the tech team, so I request them to please get the video played over the screen for the research entitled Benefit of Pulmonary Lobectomy in Infection by Actinomyces. Thank you very much.
Hello everyone, my name is Mauricio Saldana Ruiz and I will present our work entitled Benefits of Pulmonary Lobectomy in Infection by Actinomyces. This work was performed in the Mexican Institute of Social Security in Mexico. First, disclosures. Well, acknowledgement none to declare, financing none to declare, conflicts of interest by others none to declare, and compliance with ethical standards. Well, the informed consent was obtained from the patient. Background and aim. Well, our background is the next. Pulmonary actinomycosis is an uncommon disease with a non-specific clinical presentations, and usually their diagnosis is difficult and leads to a misinterpretation of malignancy, as we can see later. And our aim is to report a case of actinomycosis and the importance of performing the appropriate diagnostic test for their detections. Let's start with a case. 30-year-old female with no relevant history. She started 1.5 years ago with cough, chest pain, weakness, and hemoptysis. Then she received medical treatment from her physician. However, hemoptysis persisted. Then she came to our institution where KOH test and acid fast stain were negative. So a fungal infection and tuberculosis was excluded from the differential diagnosis. Then blood tests showed mild leukocytosis, as we can see in the table number 1. Later, a simple CT scan showed a mass and bronchiectasis in the posterior basal segment of her right lung. Due to the results of the CT scan, a biopsy was taken and showed squamous metaplasia and sulfur granules with dystrophic calcification, as we can see in the figure number 1 below. Then the treatment was amoxicillin daily for 12 months. However, 3 months later, the patient persisted with hemoptysis. For the persistence of the symptoms, it was decided to perform a right lobectomy. 6 months later, the symptoms disappeared, and now the patient is currently stable with no recurrence of symptoms. Let's start with the conclusion. Well, before the development of penicillin, this condition used to be fatal, so most of the patients pass away. However, nowadays this condition is less common. As we can see in the study from Kim et al., they reported only 94 cases in the first decade of the 21st century. The symptoms are non-specific, being misdiagnosed as a neoplasm. In our case, the biopsy was taken to rule out malignancy, so this is true. And well, Sang et al. In their retrospective study reported that only 5 patients had the correct initial diagnosis. 60 patients were diagnosed with lung cancer, the remaining with tuberculosis and lung abscesses. Penicillin and their byproducts are the main treatment, and in our case, that treatment was amoxicillin for 1 year. And in persistence of hemoptysis, surgical treatment can be added. We have a study from Song Yu et al. They demonstrated better outcomes in patients who underwent lobectomy compared to those who did not undergo this procedure. And the follow-up period is from 3 to 12 months. In our case, the follow-up period was for 6 months, and the patient was stable. And here you have our references, and that is all. Thank you for your attention.
Okay, so we are done with this presentation. I request the judge to please submit the score for this recorded video. And at the same time, I request the tech team to please get the QR code on the screen so that audience can vote for the fair representation. Okay, so now we can proceed with the next presentation. So our next presentation is Pathology of Cantrell, report of a unique phenotype by Dr. Manuel Alejandro. So welcome, Dr. Manuel. You can begin the presentation.
Thanks. Thank you. So this is a short presentation about a case report titled Pathology of Cantrell, report of a unique phenotype. I'm Manuel Vázquez. I'm a medical student at the Universidad del Valle in Cali, Colombia. And my co-author is Dr. Saldarriaga, an OB/GYN physician. So for pathology of Cantrell, we can see that this is a complex congenital syndrome, but is characterized by 5 diagnosis criteria. We can have supraumbilical omphalocele. With omphalocele, I mean the evisceration of the content of the abdominal cavity and the thoracic wall outside of the body with a membrane that covers it. We can also have a lower sternal cleft. With that, I mean like any external defect. Also, we can have diaphragm defects, like in this case, it was a partial agenesis. Also, we can have defects in pericardium, like the absence of it. And we can have any intercardiac anomaly. We can have tetralogy of Fallot. We can have total venous anomalous pulmonary return. We can have any defect in the trunks, but we can also have some congenital anomalies associated with it, with the syndrome, that are not from the diagnosis criteria. We can have cleft lip, hydrophytalis. We can have dilation in the jugular lymph sacs. Also, we can have hyperlordosis. And in the first echo that we do in the prenatal visits, we can have an increased nuchal translucency that can lead us to the diagnosis of this pathology. So for the case description, we have a 15-year-old gravida 1 patient. She presented to the OBGYN outpatient service of our hospital with the chief complaint that I've never seen a doctor about my pregnancy. At the time, she was the recent immigrant from Venezuela. She just got to Colombia like 2 weeks ago before her first visit. She was 37 weeks pregnant with no previous antenatal care, and also no echoes. So immediately she was scheduled for an detailed anatomy ultrasound that depicted thoracoabdominal ectopia cordis, and with that she was admitted to the high-risk pregnancy ward, and a physician meeting was called in order to decide what happens to this patient. So this is the some photos of the 37th week detail anatomy ultrasound. We can see thoracoabdominal ectopia cordis. We can see here VCI meaning inferior vena cava, and AO meaning aorta, and anomalous anatomy of the trunks leading from the ventricles. Also, we can see organs protruding outside the abdominal cavity and the thoracic wall. Here with Doppler usage technology, you can see the anomalous circulation outside of the body. So the physician meeting between neonatologists, the OBGYN physician, also pediatric surgeons, they decided to do a C-section at week 40 with possible surgical intervention of the newborn. Well, depending on the condition of the newborn, they will go into took him to the OR or not. So this is the newborn initial assessment. We can see a midline defect with completely skin-covered heart and bowel protrusion. The thing that's protruding here, just inferior to the sternum, is the heart. On everything below the heart is intestines and also the stomach, and we can see also part of the liver there. There are some dysmorphic facial features. We can see bilateral epicanthus. We can also see, well, in this photograph we cannot see the ears, but they are low set ears and a wide nasal bridge. So for the newborn follow-up, unfortunately, he got an Apgar score of 7 at 1 minute and 6 at 5 minutes. So he was intubated and they took him to the NICU in order to perform an echocardiogram that showed tetralogy of Fallot and partial diaphragm agenesis. With that, the pediatric surgeons and neonatologists plan a contrast-enhanced CT scan in order, well, to better detail the cardiac, like big circulation anatomy, like the pulmonary vein, the aorta, in order to plan a possible surgery. But unfortunately, after 8 days in critical conditions in the neonatal ICU, the patient died. So conclusions for this case report: there is a vast heterogeneity in the phenotype of the thoracoabdominal walls. It's just not omphalocele, gastroschisis, and pentalogy of Cantor. We have a wide heterogeneity in these cases, and it's important to be thorough about the physical features of the newborn in order to get an accurate diagnosis. Also, the ultrasound is a basic screening technique. It is unacceptable that our patients get here without an ultrasound. This is a case with a unique phenotype because of the covering of the all of the protruded organs outside of the body were completely covered by skin. This is a phenotype that wasn't described before in the literature. So we're contributing to this new review, suggesting new physiopathological mechanisms, like maybe the migration of the epidermal cells of the thoracic wall that can later on form the skin. And also, we can have a multidisciplinary involvement of OBGYNs, physicians, pediatric surgeons, neonatologists, for the prenatal reproductive counseling in these challenging scenarios. Not only just physicians, we can use the help of social worker, of the nurse and staff, to help this patient in order to achieve prenatal and reproductive counseling, and to explain the patient what are the risk of recurrence. This is all my references, and thank you all for listening.
Thank you, Dr. Manuel. It was a wonderful presentation highlighting the importance of multidisciplinary management in such a complicated case. Now, I would like to get back to our judge, Dr. Manit, to have question to Dr. Manuel with regard to his case report.
Thank you so much, Dr. Sudan. So it's a good presentation, Manuel. You kind of explained a bit elaborative way, and what all happened with the case, and I understand it's a very unique case to come by. So, can you predict any of the complications that the baby is going to have into the future?
With this kind of phenotype, with the pathology of
Yes.
Hantro?
Yes.
Well, yeah, it's like I said, it's a wide heterogeneity. Just not only the cardiac and great vessels anomalies, but we can also have cleft lip, and also some choanal atresia. So it depends, really it depends. But many of these patients, if they don't get the cardiothoracic neonatal surgeon, well, the prognosis is not good. So these patients usually have it's not a good state in the neonatal ICU, and these patients tend to die relatively in the short period of time, just after they are birth, their birth.
Thank you. Do you know of any emerging therapies or managements other than in managing those kind of phenotypes?
Yeah, can you repeat the question, please?
Do you know of any emerging therapies or management, in managing these kind of phenotypes?
Imaging therapies?
Yeah,
like
emerging or new therapies that are coming into.
new therapies. Okay, so actually here in our hospital, we were performing the first surgeries in utero, and if we catch these defects early, with the first ultrasound done in the 11 to 14 weeks of pregnancy, maybe we can plan an in utero surgery that our physicians are capable of doing. But in this scenario, in this challenging scenario with an immigrant patient, she got here like 37 weeks with no antenatal care, no ultrasound, so it was very challenging. But yeah, new therapies in utero surgery.
Thank you. Interesting case.
Thank you, Dr. Manit, and thank you, Dr. Manuel. Now, can we please get the QR code on the screen? I request the audience to please vote for your favorite presenter, as we'll be selecting winners based on this also. Okay, so I think now we can proceed with the next presentation. So moving on to the last presentation of this third slot, entitled Factors Associated with Greater in-Hospital Functional Recovery After Acute Ischemic Stroke in a Social Service Program in Physical Rehabilitation by Dr. Fernando Tienda. Welcome, Dr. Fernando. We are great to have you here. We can begin with the presentation.
Thank you. Well, good afternoon to everyone. I'm going to present our investigation titled Factors Associated with Greater in-Hospital Functional Recovery After Acute Ischemic Stroke with a Social Service Program in Physical Rehabilitation. My name is Fernando Tienda-López, and this is my team from the Neurology Service of the University Hospital, Dr. José Eleuterio González, in Monterrey, Nuevo León. Well, as all you know, the stroke is one of the main causes of morbidity and mortality worldwide. In this pathology, early physical rehabilitation, I mean the rehabilitation that occurs in the first 72 hours after the stroke onset, is a challenge in public hospitals in Mexico. Why? Is because just a few number of hospitals in our country have already a rehabilitation program, because the majority of our hospitals can't afford it. And early physical rehabilitation has shown an increase in functional improvement after an acute ischemic stroke, but the factors that determine the degree of improvement are not well established. So our aim was to evaluate the factors that influence the effectiveness of early rehabilitation after acute ischemic stroke. So we did an observational, retrospective, longitudinal, and analytical study. We included all acute ischemic stroke patients admitted from 2022 to 2024 in the neurology service of the University Hospital, Dr. José Eleuterio González of the Autonomous University of Nuevo León. All of our patients received early rehabilitation by students of the Medical Technical School in physical rehabilitation. And we evaluated the change at admission and discharge in the Lovett scale, Ashworth scale, Bartel scale, and NIH stroke scale. We did descriptive and inferential statistics, and we performed a logistic regression model to evaluate the predictors of a significant reduction in the NIH stroke scale score, defined as a reduction in score equal or more than 4. And we considered significance at a p-value less than 0.05. In our results, we included a total of 296 patients with 149 females with a mean age of 61.4 with a standard deviation of 12.9 years, with a mean of 4 rehabilitation sessions per patient. Our average length of stay was of 7 days per patient, and the most prevalent risk factors for acute ischemic stroke in our sample were hypertension, diabetes, and sedentary lifestyle. We found that there was a significant improvement in the median admission and discharge in the NIH stroke scale score, Bartel score, Lovett score, and Ashworth score, with a percentage of patients who showed some improvement of 55.9%, 25.8%, 32.2%, and 11.8% respectively. In this table, we can observe the demographics of our sample and also the main risk of stroke, the main risk factors for stroke, sorry. And in this slide, we can observe the change in the NIH stroke scale score between the discharge and the admission. And we can observe that there is an improvement at the discharge when we compare with the admission. And we can see it in the score at the discharge with a median of 8 versus a median of 5 with the score at the admission. And this difference and this change was statistical significant. And we can also observe this in the Bartel score, Lovett score, and Ashworth score. Also, we observed that the 44.8% of our patients discharged with a NIH stroke scale score less or equal than 4, and a quarter of our sample presented a significant reduction in the NIH stroke scale, defined the score, a reduction in the score more or equal than 4. And this was associated when we perform a logistic regression model with female gender, tobacco withdrawal, and previous use of antithrombotics. In our discussion, when we compare our study with previous literature, we found that Simic, Penich et al. Found that hypertension, previous myocardial infarction, atrial fibrillation, dilated cardiomyopathy, and advanced age were associated with a reduced effectiveness of therapy. Nasal et al., who performed a similar study, found the same association with hypertension, diabetes, and heart disease. Our center had a median NIH stroke skill score after the rehabilitation therapy of 5, and this is comparable to other global stroke registries with early rehabilitation programs, such as the Korean one with a median of 2 and the German one with a median of 7. And when we compare the percentage of patients with a Bartel score more than 90, we have a lower percentage of patients with this score and then the Austrian registry. An interesting study from Spain showed that when we implemented the rehabilitation program, they obtained a higher mean Bartel at the discharge, higher mean Bartel score at the discharge in patients with physical therapy when they compared this program when they had not the program in previous years. And this is comparable to our center. In the conclusion of our study, we found that gender, smoking, and the use of antithrombotics influenced early recovery after acute ischemic stroke. The involvement of students in rehabilitation facilitates functional recovery during hospitalization and represents an efficient and low-cost strategy, especially in developing countries like our country, Mexico. And this is beneficial for students who can practice their skills, the hospitals who spend less money, and above and more important and most important above all for the patients. Here are my reference, and thank you for your attention.
So thank you, Dr. Fernando. It was really a wonderful presentation. Now I would like to get back to our judge, Dr. Mani. Do we have any question to Dr. Fernando?
Oh yeah. I mean, before going to the questions, it was a great presentation and a great study. It was a detailed elaboration of your study. Can you just list me out a couple of strengths of your study that you have?
Can you repeat the question, please?
Can you just list me out a couple of strengths?
That complots?
Strengths of the study.
Oh, I don't understand you. Sorry. Can you
Okay, let me repeat the question. So what Dr. Manith is asking, he's asking about the strength of the study.
The strength of her study. Oh,
yes.
sorry. Well, when we compare study with previous literature, we found that we had higher size of the sample, and also this is kind of difficult. But when we compare to previous studies in Mexico, a less number of hospitals had already a rehabilitation program. So this is kind of interesting that we can have comparison between the patients in Mexico who had already a rehabilitation program versus who had not. That is the most of the hospitals in Mexico.
Interesting. Thank you so much.
Thank you, Dr. Manith, and thank you, Dr. Fernando. It was really a good presentation. Now, can we please have the QR code on the screen for Dr. Fernando? I request the audience to please vote for your favorite presenter. Okay, so thank you so much. So now moving forward, we are basically done with the third slot of this research presentation of the World Conference of Medical Student Research 2024. Now, before we begin the fourth and the final slot of research presentation, we are going to have a short coffee break. So stay connected with us. See you soon. Thank you. So, well, so welcome back everyone for the fourth and the final slot research presentation of the World Conference of Medical Student Research 2024. So let's begin this slot. I want to welcome all the presenter and the allocated judges for this slot. So let's begin this presentation with our first abstract entitled Knowledge, Attitude and Practice of Breast Self-Examination among Female Students of Niger Delta University by Dr. Ogoli.
Hello, my name is.
So again, we have the recorded video for it. I request the tech team to please play the video.
I'm going to be making a presentation today titled Knowledge, Attitude and Practice of Breast Self-Examination among Female Students of Niger Delta University. Before I continue, I would like to say a big thank you to the World Conference of Medical Student Research and the International Journal of Medical Researchers for giving me this opportunity to make this presentation and the platform to showcase my work. So next, I'm going to be talking about myself. I'm a young medical graduate from the Niger Delta University, Wilberforce Island, Bayelsa, deeply enthusiastic about public health, committed to improving global health through education and advocacy, particularly in promoting early detection and treatment of breast cancer. My co-authors for this work are Mgbedo, Yingifa Tonte Favor, and Guche Monica Anurika. So this discussion today will be tailored to these outlines here. So first of all, we'll talk about the introduction, the background, aim and objective, methodology, results, discussion, conclusion, and finally references. So as a method of introduction, cancer is the leading cause of death globally, but breast cancer affects 2.3 million women annually, according to the WHO in 2022, and this causes significant mortality, especially in less developed countries or regions like Nigeria, where I'm currently at. But in Nigeria, the incident rate of breast cancer is 54.3 per 100,000 women. But early detection through methods like breast self-examination is very crucial, particularly in developing countries. The aim of this study was to assess the knowledge, attitude, and practice of breast self-examination among female students of Niger Delta University, and also to provide insights into the effectiveness of current awareness efforts. Some of the objectives of this study were to determine the knowledge of breast self-examination among female students of Niger Delta University, to determine the attitude of female undergraduates of the Niger Delta University towards breast self-examination, and then to determine the proportion of female undergraduates that practice the breast self-examination. Now, for the study design, it was a descriptive cross-sectional study, and it was carried out in Niger Delta University, Wilberforce Island, Bayelsa. Participants included 376 female undergraduates aged between 18 and 30 years of the Niger Delta University, and the sampling technique was a multi-stage sampling technique. Now, the data was collected through a semi-structured, self-administered questionnaire. Data was analyzed using the SPSS version 21. Now, the knowledge score was categorized as poor between 0 to 4, fair between 5 to 7, and good between 8 to 9. Approval was obtained from the Research and Ethical Committee of the Niger Delta University, and participants were informed and consent taken as the participation was very voluntary. Now, the results of this research included, now, among the 376 respondents, 77.4% were single, while others were either married or in a relationship. Now, let's come to talk about the knowledge from our finding. We found out that 60.9% had good knowledge of breast self-examination, 35.4% had fair knowledge, and 37% had poor knowledge. Now, looking at the knowledge of breast self-examination that we gathered, it was really good compared to other researches. Now, for the attitude towards breast self-examination was generally positive with a 72.6%, agreeing that breast self-examination is not time-consuming. And then the practice of breast self-examination was reported by 64.4% of respondents, with 96.7% performing it at least monthly. And that was a very good practice. Attitude, practice towards breast self-examination was really, really good. It was really impressive. So high knowledge of breast self-examination among students from the medical department and those with a family history of breast cancer, and then increased awareness and education contributes to better knowledge and practice of breast self-examination. Now, the summary of this point is, now the students that had high knowledge of breast self-examination were students that were from the medical departments, like the medicine students, the pharmacy students, the nursing students, the medical laboratory science students. And then also, aside from this group of people, students that have had or has a family history of breast cancer, like maybe the mother have had breast cancer, a sibling has had breast cancer, or an auntie has had breast cancer, had good knowledge of breast self-examination. So just to conclude, to help to increase the knowledge or the practice of breast cancer, increased awareness and education would help to contribute this. Now, breast self-examination among female students in Niger Delta University is 64.4%, while about 35.6% don't practice it. But increased knowledge of breast self-examination is attributed to the increased rate of breast cancer education and awareness. There's increased knowledge, attitude, and practice of breast self-examination among females of reproductive age, just like our finding during this research. Now, this increasing awareness facilitates early diagnosis and better prognosis. In conclusion, significant level of awareness and positive attitude towards breast self-examination among female students at the Niger Delta University there's still need for continuous education and outreach in order to improve the regular practice of breast self-examination and enhance early detection. So, just like I said before, in order to conclude this discussion, this presentation, we need to increase the education and the outreach to improve the knowledge and the practice of breast self-examination among females, especially those within the reproductive age. This will help for early detection and will help for early treatment, reduce mortality, and increase life expectancy as a whole. So these are my references. And then thank you for listening to my presentation. Any questions?
So, okay, it was a great presentation in form of a recorded video. I request the allocated judge for this slot to please submit the score with regard to this presentation. And at the same time, I want to request the tech team to please get the QR code on the screen so that audience can vote for the favorite presenter. Can we have the QR code on the screen, please? I request the tech team to please get the QR code on the screen so that audience can vote for the favorite presenter. Okay, so here you can see the QR code. I request the audience to please vote for your favorite presenter, as this will be one of the factors to decide winner in the World Conference of Medical Student Research. Okay, so moving on. So let's begin with the next presentation by Dr. Lily Saran for an abstract entitled Pain Severity Ranking Among Patients with comorbid chronic pain, and post-traumatic stress disorder. Welcome, Dr. Lily. We are glad to have you here. We can begin the presentation now.
Awesome. Thank you. Good afternoon. My name is Lily Sharon. I am a second-year medical student at the Drexel University College of Medicine in the United States. And yeah, so today I'll be talking about pain severity ratings among patients with comorbid chronic pain and PTSD. Okay. So as a bit of an introduction to the two disorders I'll be discussing today, so post-traumatic stress disorder, or PTSD, is a psychiatric disorder that occurs after someone experiences or witnesses a traumatic event. It's often associated with people in the military, but it can happen to anyone that experiences that event. Some of the symptoms include panic attacks, sleep disturbances, and hyperarousal, also avoiding triggers that remind the person of the traumatic event, and irritability can also be seen. And it's very common for people with PTSD to have other comorbid disorders. They can be psychiatric disorders such as depression and substance use disorders, but they can also be medical disorders as well. For chronic pain, so we know pain as an adaptive experience that lets the body know if there's tissue injury or if there's something else wrong going on. And it is elevated to chronic pain when it persists beyond this adaptive response, which is typically longer than 3 months. And chronic pain can be due to a chronic health condition like arthritis or fibromyalgia, or it can be related to a traumatic injury. So comorbid PTSD and chronic pain is very common, and there has been a lot of research looking at the overlap of these two disorders. Some early research looking at military veterans found that those who were diagnosed with PTSD had higher incidences of chronic pain than those without PTSD. They also found that those diagnosed with PTSD reported a higher pain severity than those without PTSD. We've also found that this is a bidirectional relationship. So while PTSD diagnosis predicts development of more severe chronic pain, they also have found that higher severity of initial pain predicts a development of PTSD as well. And there's a pretty extensive neurological basis for this overlap. So mainly this is through the limbic system and the amygdala, which is associated with fear and negative memories. And this can be associated with the traumatic memories, including memories of pain as well. So there's the overlap with the neuroanatomy. And there's also been a number of studies that have found elevations in a number of biomarkers in the brain that is associated with both PTSD and chronic pain. So namely elevations in neuropeptide Y, allopregnenolone, and pregnenolone are associated. They also found a few other markers implicated in both disorders, such as GABAergic steroids, opioids, and endocannabinoids, and then several other immune factors as well. So for the current study, I wanted to keep looking at this relationship in a much bigger cohort. So I compared the reported pain severity of patients with only PTSD, only chronic pain, and those with comorbid PTSD and chronic pain in a retrospective cohort in this database called TriNetX. And TriNetX is a database with hundreds of patient data from hundreds of healthcare organizations around the world. For my study, I focused on patients between 18 and 90 years of age across 61 healthcare organizations in the United States and between the years of 2000 and 2024. As stated earlier, I had 3 study groups, those with PTSD and no chronic pain, those with chronic pain and no PTSD, and then those patients with comorbid PTSD and chronic pain. And then finally, I whittled down this population to only those who reported pain severity from a scale on a scale of 1 to 10, with 10 being the most severe pain. And the statistical analysis I used to compare the mean pain severity ratings was a one-way analysis of variance, and I used this in SPSS to compare them. So just a quick diagram of my groups for the study. So as you can see, we started with the entire TriNetX network population, which is over 100 million populations. We whittled it down to my 3 study groups, so the PTSD and chronic pain comorbid group in yellow, the PTSD group, and the chronic pain group. So these were the results of the study. So starting with the descriptive statistics, I just wanted to highlight the means, just looking at a superficial level for the 3 groups. So just looking at the means, the PTSD and chronic pain comorbid group reported the highest pain severity rating, an average of 5 out of 10, followed by the chronic pain group and the PTSD only group having the lowest pain severity ratings. Looking at the results of the one-way ANOVA, you see that this is a significant difference between the 3 groups. We also did a post-hoc analysis, not shown on this slide, that found that when comparing each pair of groups within the 3, they all were significantly different from each other, showing that this was a significant difference in pain severity ratings. So a little bit of summary of the findings that I just reported. So we did find that pain severity in those with both chronic pain and PTSD, the pain severity was exacerbated and reportedly higher than those with chronic pain without PTSD. Unsurprisingly, the group with only a PTSD diagnosis and no chronic pain had the lowest pain severity ratings. And these results pretty much confirm previous research. Of course, this was done on a much larger scale with the TriNetX database. There were a few limitations or avenues for future research. So through TriNetX, we weren't provided with the raw data. We were only provided with the means, the standard deviations, and the sample size. So we weren't able to establish all of the assumptions of the ANOVA, such as like the homogeneity of variance. So there may be some unreliability with the results of the ANOVA with that. There were a few confounding variables that we did not take. We didn't look at any gender or age differences. We also didn't differentiate between sources of chronic pain. So it may have been pre-existing or unrelated medical condition, or it may have been chronic pain that was related to the traumatic event resulting in PTSD. And finally, we did not establish a temporal relationship, so we did not distinguish between those that had chronic pain prior to onset of PTSD or whether the PTSD came before the onset of chronic pain. For future considerations, we think that this is really important for looking at different pain management or psychiatric care in the population with comorbid PTSD and chronic pain. I also think it's important in the future to look at pain management and other stress-related disorders that may have an impact on pain severity as well. All right, so that was my presentation. I'd like to thank my mentor, Dr. Eduardo Esperidian, for helping me with this project, the people at TriNetX for helping me navigate their platform, the Drexel MSSRF Summer Research Fellowship for the support for this project, as well as the International Journal of Medical Students for the opportunity to present today.
Thank you, Ms. Lily Saran. It was indeed a very wonderful presentation. Now I would like to get back to our judge. So we have Dr. Mani for this final slot of research presentation. So Dr. Mani, do we have any question to Dr. Lily?
Oh, hi, Lily. It was a great presentation to begin with. I see that you kind of took a couple more minutes in the beginning to get us through into the world of PTSD and chronic pain, which is very much needed for us to understand the significance and the magnitude of the results. It was a good presentation all through. So I have, the question, the presentation was well through, and, you had your limitations and future research, suggestions established. Regarding the point with the Trinitex, is that a publicly available database?
Yes, it is publicly available. You do need to go through training to have access to it, but yes, I believe so.
Okay, so since it's publicly available, I assume that it's de-identified and you didn't need ethical board considerations for that.
No, we did.
Approval, IRB, yeah.
Yeah, so we did not need IRB approval for that.
Okay, yeah. Thank you. That's also my question. It's a great presentation. Thank you.
Thank you.
Thank you. Thank you, Dr. Manik, for the question, and thank you, Ms. Philip. It was a very great presentation. Now, can we please get the QR code for Ms. Lily Cyril? Okay, so you can see the QR code on the screen. I request the audience to please vote for the favorite presenter. Okay, so now let's move forward. So continuing our presentation, now we have a case report coming on our way entitled Anti-NMDA Encephalitis Associated with a Mature Ovarian Teratoma, a compelling case report. I request the presenting author, Dr. Antonio, to please proceed with the presentation of this case report.
Hello, good morning. My name is Antonio Mena Luna. I'm a second-year medical student here in Mexico, and today I'm presenting a case report titled, as you guys recalled, Anti-NMDA and encephalitis associated with a mature ovarian teratoma. Well, to begin with, I'm gonna give a little bit of a presentation or a background. I'm a second-year medical student from Mexico, and I do a research assistant at my university. And to give a little bit of background about the case, anti-NMDA or anti-N-methyl-D aspartate receptors in encephalitis is epidemiologically classified as a paraneoplastic and autoimmune encephalitis that mostly gives neuropsychiatric manifestations. Around 80% of the cases are mainly focused in women. This is a pathology that comes present mainly in female patients, and it's half of them are associated with an ovarian teratoma that is most of the times mature. And what's the importance of these receptors is that these receptors are located specifically in the hippocampus and the forebrain, and they play a main role in the memory, cognition, and learning process of us. That's why the clinical manifestations of them are really sporadic and different sometimes. Then the pathogenesis of the anti-NMDA encephalitis is, as I said before, it's an autoimmune mechanism in which our body, specifically the ovarian teratoma of the women, produces anti-NMDA autoantibodies. And these autoantibodies, they internalize the NI1 subunit of these receptors, and basically they decrease the synaptic function, leading to neuropsychiatric disorders. Anti-NMDA encephalitis accounts to 50 to 80% of the autoimmune encephalitis cases. And one of the best ways to overcome this pathology is through the surgical excision of the teratoma and immunosuppressors to basically during immune intensive care to better outcomes and lower relapses. Most of the times, this pathology comes out onset in the 21 years old, but cases have been reported from 8 months to 85 years old of age. This is more common in patients under 30s. Patients that are, just like in this case, a postmenopausic patient, are extremely rare. Only 2 to 3 cases have been published ever, and the last published was of a patient that was 60, and that was in 2017. There's 4 different stages, as the literature has classified them as the prodromal, psychotic, non-response, and hyperkinetic stages of this whole disease. As we're gonna see later, as these stages go by, the outcomes and the outcomes are worse, and most of the times, whenever the patient gets to the non-response stages, they commonly die. And this is often misdiagnosed with other kinds of encephalitis, mostly caused by herpes virus, and due to the psychiatric disorders that are various. And this case that I'm going to present next is about a mature ovarian teratoma that it was presented in a postmenopausal patient that almost died, but thankfully it was saved due to the diagnosis, a correct diagnosis of anti-NMDA encephalitis. So this patient was a 56-year-old female patient, which was already postmenopausic, with no medical history prior. She was admitted to the emergency room on February 15, 2023, and she was presented dysphagia, anorexia, drowsiness, nausea, and muscle weakness, confusion, and unresponsive to external stimuli. On February 17, 2023, she was admitted to the Houston Methodologist Hospital, and she was diagnosed with anxiety and depressive disorder with psychotic symptoms. After 2 days of the hospitalization, she was treated with ceftriaxone, naproxen, haloperidol, lorazepam, mirtazapine, and pantoprazole. After a month of hospitalization, the patient's cognitive, psychiatric, and motor function started deteriorating, resulting in a loss of mobility and dyskinesia. So basically, the patient was progressing without the doctors knowing what was going on. Her family basically discharged her from that hospital on March 26, 2023, and she was transferred to her home country here in Mexico, where she was admitted on the hospital that I was working in, which was the Hospital of Finiquito in Monterrey, Nuevo León. The patient had acute symptoms, including spatial disorientation, mild integrated amnesia, bradyphagia, incoherent speech, and disorganized thought process. But the neurological examinations showed no signs on the focal impairment. And also a really peculiar finding that we got in the hospital, it was that the CT scan and the electroencephalogram there were all normal. But the MRI revealed a little bit of cortical brain atrophy, but no signs of any kind of other type of encephalitis. And on March 31, 2023, she was treated with intravenous acyclovir and dexamethasone because we thought that she had encephalitis due to herpes zoster and herpes simplex virus associated with the limbic encephalitis. And despite the acyclovir and the naltrexone treatment, the patient's cognitive decline and the memory issues, and she had rigidity worsening. So what happened is that the patient had no other medical history, and she was admitted to the emergency room. And then a real-time PCR was done to her to discard any herpes simplex virus, and we led to the administration of anti-NMDA antibodies, texting serum, and on the cephalorachidix fluid, and through the abdominal pelvic CT scan. And by the fourth postoperative day, the patient regained movement and the loss of rigidity, and her corticate-like proceeding resolved. Basically, on the PCR for these antibodies of the anti-NMDA, they were positive. So we're able to find the way to cure her through immunosuppressants, and we also had to resect the ovarian teratoma that she had on the right ovarium. And by the fifth postoperative day, the wind of the mechanical ventilation and her sleep pattern returned to normal. And after this, the patient showed no psychiatric symptoms, and it was a gradual recovery, and the patient got stable. And these are the imaging results that we find. And as we can see on the right ovarium, there was a huge ovarian cyst that was oval, well-defined lesion with 5 density, and it has cyst components and nodular calcification. It was a measure of 150 times 76 times 147 milliliters, and had a volume of 881 cc's. As we can see, it has a peripheral encasement of post-contrast, and the lesion was near to the left ovarium, but predominantly on the right ovarium. Also, that microscopic histopathological examination of the left teratoma, it showed us different type of tissues. It had catenarized stratified squamous epithelium with sebaceous glands. It also had gastrointestinal glands, glial neural tissue with myelotapia, and also meningeal tissue with fibral background and glial protein appearance. According to the literature, these two tissues are mostly predominant in this type of teratoma due to the production of the antibodies. And due to this differentiated glial and neural tissue is why the variants are producing antibodies against these receptors and causes encephalitis in general. And in conclusion, what we want to come up with is why we think it's important in this case in particular is that in this case, a diagnosis of anti-NMDA receptor encephalitis was confirmed through the detection of a mature ovarian teratoma that contained neural tissue. This is an uncommon finding in this pathology, likely to the key trigger from the encephalitis. Also, notably, the condition is exceedingly rare in postmenopausal women, as I already mentioned before. And according to literature, only 5 to 10% of the cases are reported during this demographic. The uniqueness of this case lies not only on the patient's age, but also on the typical onset of the clinic and the clinical progression because this clinical progression was in less of 3 months. The patient deteriorated extremely fast, and also emphasizing the significance of the pathology. Anti-NMDA receptor encephalitis progresses through multiple stages with fatal outcomes, and it's the very symptom often mimics psychiatric disorders, making the recognition a little bit challenging and heightening in the critical role of serological testing to differentiate from more common conditions, and given to the scarcity of the report cases and limited literature that is about this case and this kind of pathology particularly, we believe that our case provides a valuable insight containing a broader understanding of this rare disease, and it's underscored the importance of prompt diagnosis and optimal clinical management, which could improve outcomes in the future. And last but not least, we would like to acknowledge to the patient who kindly gives the consent for the presentation of this case, and to the ING for giving us the opportunity to present this case to you guys. And this is our reference. Thank you so much.
So thank you very much. It was a wonderful presentation. Now I would like to get back to our guest. So Dr. Monique, do we have any question to Dr. Antonio with regard to his presentation?
Yeah, I just have, it's a good presentation. I just have one question. Given that it's a rare disease and it's a rare occurrence to happen, what do you think should be, your physicians could have approached a little different in diagnosing this case?
I think that personally, so as I presented, we were the second hospital that received her. At the beginning, since it had a vague variety of symptoms, that most of the times they were confused. It was confused at the beginning with depression. Then other doctors considered she might have Alzheimer's and Parkinson's due to the variety of the pathology. We got into that detail of probably being anti-NMDA receptor encephalitis because one of the doctors that was working with us said that during his service, he had this kind of particularly case. So I feel that the reason why it was misdiagnosed very lately is because there's not a lot of literature about this topic in specific. Also, most of the times due to the age of the patient, also doctors, well, I'm a student, but further I'll be a doctor, hopefully. I feel that sometimes we just make assumptions. So, okay, this patient's already postmenopausic when we don't take in account other pathologies that could have been. For example, we go to the most common as herpes simplex that could cause this kind of encephalitis in this age gap of patient. So I feel that the reason why it was misdiagnosed and hopefully at the end of the day we were able to diagnose her is because of the very small information and literature that it is about this pathology specific, and also in this niche of age, which is 50 and over, because I've already mentioned, as I said in the statistic, only 5 to 10% of patients cases that are reported nowadays are of postmenopausic women. Also, most of the times, we also did a systemic review of this disease specifically. Almost 70% of the results that we got in the systemic review were all from 18 years old to 20 to 30. As I mentioned at the beginning, the oldest patient we found in the systemic review was a 60-year-old patient from Asia, and that was presented in 2016, 2017, if I'm not mistaken. So I feel that the shortage of this kind of cases that occur, because it's not a really common disease that occurs currently, I feel that and the low information or the really little information about this makes also a really difficult finding or disease to diagnose if we don't know a lot, or we don't expand our plus options in our patients. I feel so.
It's an interesting presentation. Thank you so much. Thank you for answering the question.
Thank you so much for the opportunity.
So thank you very much, Dr. Monique, for the question, and thank you, Antonio. It was a wonderful presentation. Now, I would request the audience to please scan the QR code to vote for the favorite presenter. Okay, so now let's move forward. So we are heading towards the next case, the next abstract to be presented, entitled The Effect of Laterality on Squamous Cell Carcinoma Size and MOHS Micrographic Surgical Procedure by Dr. Freda. Welcome, Dr. Freda. You can begin the presentation.
Great, thank you. Hi, everyone. My name is Sheila Sharifi,
Today I'll be talking about the effect of laterality on squamous cell carcinoma size and Mohs micrographic surgical characteristics, and I'm presenting on behalf of my team at the University of Miami. Just a little bit about me. I'm a third-year medical student at Georgetown University in the United States, and I'm currently a pre-doctoral research fellow in the Department of Dermatology at the University of Miami. So Mohs micrographic surgery is a minimally invasive technique designed to treat skin cancers in cosmetically sensitive areas such as the face, hands, etc. It involves a sequential removal of horizontal layers of the tumor as opposed to vertical, which was a traditional excisional method. And these slides are processed in real time to determine if the margins are cancer-free, promoting more cosmetic outcomes. Certain activities and lifestyles of our patients, such as those that drive for a living and may be exposed to the left side of their face, render patients susceptible to uneven distributions of sun exposure, favoring specific lateralities of skin lesions. So with that in mind, the aim of our study today was to determine if there were differences in recovery course and lesion sizes for Mohs based on the laterality, right or left, of their lesions. In order to do so, we performed a retrospective chart review in a single academic center. It included 255 patients with confirmed squamous cell carcinoma that underwent Mohs micrographic surgery, confirmed by biopsy, and we gathered various metrics. This included anatomical location, right or left, preoperative tumor size, postoperative wound size, and the number of layers removed during surgery. We then performed a statistical analysis where we computed the average and standard deviation for left versus right-sided SCC tumors with the above parameters. And following that, we computed a two-tailed t-test to determine if there is a statistically significant difference. Our results are as follows. Of the 255 patients analyzed, 121 had right-sided lesions and 134 had left-sided, so we can see a slight left-sided preponderance. The means for the preoperative tumor size for right versus left were as follows, 1.73 centimeters versus 1.79 respectively. The means for the layers removed for right versus left tumors were 1.69 versus 1.61 layers respectively. And the means for the postoperative wound size for right versus left were 3.44 versus 3.63, with the standard deviations listed here in the slides. And the p-values, importantly, for all of these were greater than 0.1, indicating a not statistical significance in the values we conducted. So with that in mind, there was a slight left preponderance of the SCC cases, yet we did not find any statistical difference in the preoperative tumor size or the postoperative wound size or the number of layers removed during surgery. Hence, differences in occupational or activity-based sun exposure did not appear to have a significant effect on SCC tumor size laterality in this patient cohort. So the increase in left-sided cases could potentially be due to leftward sun exposure in certain populations I mentioned earlier, or it could also be due to normal statistical variation we see in scientific analysis. Importantly, our study is limited to patients at a single academic center performed at the University of Miami, potentially leading to a geographical bias in results. And we recommend further research to analyze a larger patient cohort to better quantify the prevalence of left-sided tumors. That's all I had for you today. And if any questions, I would love to answer.
So thank you very much, Dr. Sheila, for this wonderful presentation. I'd like to request Dr. Manit to have, do you have any question to Dr. Sheila with regard to her presentation?
Hi, Sheila. It was a short but sweet presentation. Thank you so much. And it was a research, interesting research question to begin with. So, what do you think are kind of, few of the reasons why the study ended up being statistically not significant?
I think it had to do with our sample size. I also think, like we said, although there might be a slighter preponderance to the left-sided tumors, ultimately how we care for these tumors might be more regimented, resulting in not statistically significant results. And that is what we hope anyways. Whether or not patients have left or right-sided tumors, we would assume that hopefully the postoperative wound size and the layers removed would remain somewhat the same.
Interesting. Thank you so much.
Thank you. I appreciate it.
So thank you very much, Dr. Munir, for the question, and thank you, Dr. Sela, for such a wonderful presentation. Now, can we please get the QR on the screen for the audience to vote? Okay. So I think we can now proceed with the next presenter. So now we can proceed with the next presentation for this session for abstract entitled Effect of a Low-Dose Cardiac Rehabilitation Program on Cardiovascular Conditioning Parameter in Patients with Heart Disease. And this is supposed to be presented by Dr. Mgbedo. So welcome. We can proceed with the presentation.
Hello, good afternoon everyone. I'm going to talk about my recent research, named Effects of a Low-Dose Cardiac Rehabilitation Program on Cardiovascular Conditioning Parameters in Patients with Heart Disease. All the story took place in the Cardiology Department of the University Hospital Dr. José Eleuterio González of the Autonomous University of Nuevo León. First of all, a little of background. We know that cardiac rehabilitation is a secondary prevention that recently has a really high evidence intervention that has shown a reduction in overall mortality in ischemic heart disease and, for example, acute myocardial infarction, heart failure, etc. The optimal dose of rehabilitation is not well defined due to the heterogeneity of studies in different meta-analyses. Cardiac rehabilitation is a safe and cost-effective intervention that has proven to reduce overall mortality associated with ischemic heart disease with a relative risk of 0.85 with a confidence interval of 95%. Something that I would like to clear is that in developed countries, the referral rate is only 50% if a patient with heart disease arrives to a cardiologist, of which only 80% attend to that referral. In Mexico, it's really different. The referral rate is even lower, at least 5%, and the coverage of centers with CRH-CDS is very low. So knowing that, our aim was to evaluate the effects of a low-dose cardiac rehabilitation program on cardiovascular performance parameter assessed by cardiopulmonary or conventional exercise testing before and after physical training program in patients with heart disease. What were our methods? This was a retrospective study. We enrolled 32 adult patients in the cardiac rehabilitation program. We exclude all those patients that didn't have any cardiovascular disease or do not complete at least 5 rehabilitation sessions or 80% of attendance on those sessions. How we define low-dose cardiac rehabilitation? Low-dose is defined as 5 to 11 sessions, but we focus on every patient has at least 10 sessions. Results from the initial and final comparative conventional and/or cardiopulmonary exercise tests were obtained. We include functional capacity in METs, chronotropic response, pressure response, heart rate, and blood pressure recovery, double product, that is the systolic blood pressure plus the heart rate, present or absence of ischemia, arrhythmias, determination of ischemic threshold, and ergospirometry parameters such as peak oxygen consumption, ventilatory equivalent carbon dioxide, and oxygen pulse. Aerobic and anaerobic thresholds also were evaluated. So our patients were identified from a hospital registry. Descriptive and inferential statistics has been reported, and we use SPSS version 24 for analysis. We consider a significant p-value less than 0.05. In this diagram, we can see how every patient was evaluated. First of all, obviously had an initial evaluation. We stratified every patient and we made a prescription. Every patient had 10 sessions between 2 or 4 weeks. Aerobic exercise of moderate intensity was the main idea of every cardiac rehabilitation, and every cardiac rehabilitation long between 20 to 30 minutes. We focus on every patient had a cardiologist that had a training rotation in a foreign country or in an online course. And we also involved different nursing staff and nutritionists and clinical cardiologists. What were our results? Of those 32 patients that we include, 65.6% were male and this is what we obtained. We observed that the peak oxygen consumption achieved was in the initial 20.7 versus 24.2 milliliters kilogram per minute with a significant p-value. This is really important because we know that at the end of the 10 sessions, the patients had an increase in how they need a less cardiac response to a stress test. So also we evaluate the predicted oxygen achieved. That also was a significant, and it also increased. We also found an improvement in the ergonometric performance indices that were the heart rate divided by the workload, that is the heart rate workload index, and double product workload index. This also was significant. No significant difference was found regarding pressure or chronotropic response parameters, heart rate and blood pressure recovery, or double product. In this table, we can see the different variables that we evaluate and the different p-values that each variable had. But the interesting thing was the significance of ischemia and also the double product work index that we found. In conclusion, it was concluded that in patients with heart disease, a low-dose rehabilitation program is effective in improving cardiovascular condition and parameters such as peak oxygen consumption and reducing the ischemic threshold, allowing the use of low-dose rehabilitation to be recognized as a useful tool in Latin American countries as Mexico. Thank you so much.
Thank you. Thank you very much. It was a wonderful presentation. Now I would like to call Dr. Munit to please, do we have any question to Dr. Pablo with regard to his presentation?
Yes, I have a presentation, to be honest. What are few of the strengths of your study that you think of right now?
The strength?
Yeah.
Okay. We did a sample, but the number of patients that we required, we don't reach it because in Mexico that is the problem, that not every patient wants to enroll to these protocols because they are a long duration, we could say, but there was a convenient sampling, I could say, and it was 32 patients, and we tried to cover every patient that we could afford.
That's interesting. Also, do you think what else needs to be done with your research so as to generalize the results?
Yes, in the future, I think Mexico, and not only Mexico, many countries as Mexico in Latin America, the economy not in every city is really well, and as well as the population, and every person needs to find like public health free that allows that more protocols be presented. We require more economic fund for like improve all these protocols. But yeah, we try the best that we can.
Okay. Last question. Do we have any confounders affecting your results?
Confounding what? Sorry?
Do you have any confounding factors affecting your results?
Conforming factors?
Confounding factors?
Confounding variables, you say, right? I could say that not really, because we found that the optimal dosage is 36, for example, but there is very low research about 10 doses. So we made that 10 doses, and we found that the most important parametric value that is evaluated in the optimal doses is the peak oxygen consumption. So we use this as the more important parameter to evaluate our results. So maybe if the confounding variables, I not seen anyone, but if you can show me one, I will really glad to hear about it.
That's an interesting answer. Thank you so much.
So thank you, Dr. Malik, for the question, and thank you for such a great presentation. Now we are marching towards the final presentation of this. Okay, so I'm sorry, before that, We have the QR code on the screen. I request the audience to please scan the QR code and vote for your favorite presenter. We have the QR code on the screen. Please scan the QR code and vote for your favorite presenter. Okay, now I think we can move ahead. So we are marching towards the end of this conference. So now we are into the last presentation of this final slot, the fourth slot of research presentation for the World Conference of Medical Research. So it's my pleasure to invite Dr. Scott for his systematic review and meta-analysis entitled Understanding the Role of Inflammation in ALS-FTSD, a systematic review and meta-analysis investigating the inflammation. Welcome, Doctor. You can proceed with the presentation.
Hello, I'm Scott Purdy. I'm a medical student at the University of Aberdeen in Scotland in the UK. I'd first like to say thank you very much for this opportunity to present our research at this brilliant international conference. The title of our study is Understanding the Role of Inflammation in Amyotrophic Lateral Sclerosis and Frontotemporal Spectrum Disorder, a systematic review and meta-analysis. Firstly, a bit about us. Last year, myself and Will Daly, who was a final year immunology student, undertook this project supervised by Dr. Fergal Waldron as part of Gregory Lab at the Institute of Medical Sciences at the University of Aberdeen. ALS is a rare, severely debilitating and fatal neurodegenerative disease characterized by the progressive degeneration of upper and lower motor neurons. Clinically, it manifests as progressive muscle weakness, muscle atrophy, and loss of voluntary function. Although there is a large degree of disease heterogeneity, the majority of patients will sadly die of neuromuscular respiratory failure within 2 to 4 years of diagnosis, with only around 5% of patients living beyond a decade. Now, not all patients have this classical purely motor phenotype we think of with ALS. Around 40% have extra motor symptoms, which are usually characteristic of frontotemporal dementia. This is why it's now widely accepted to be part of a spectrum disease termed ALS-FTSD. The exact etiology of ALS-FTSD still remains unclear. However, it is likely multifactorial. It's been identified throughout the literature that the most critical risk factor for this disease are genetics and family history. To date, over 50 genes have been identified to contribute to the disease. Of these, the most widely studied and most common are SOD1, C9orf72, TDP43, and FUS. Now, SOD1 was the first gene identified with the disease. However, it's been widely studied, and so the focus of this research was around C9orf72, TDP43, and FUS. The importance of both systemic and neuroinflammation in ALS-FTSD is well established, but sadly still poorly understood. Immune dysfunction has been demonstrated in situ in the brain and spinal cord of living ALS-FTSD patients through PET scanning, as well as being identified in peripheral blood samples. It's also been widely shown in many studies immune neuroinflammation and systemic inflammation in post-mortem studies. So our methodology. We aimed to quantify the immune system's contribution to ALS-FTSD by meta-analyzing experimental data which applied anti-inflammatory interventions in animal model studies. We also sought to critically appraise and summarize the current body of literature on the topic, all of this following the rigorous standards laid out by the Cochrane Institute. Quantitative analysis of the data was presented as forest plots. Analysis was undertaken for survival and motor function, as these are the two most important outcomes to measure in motor neuron diseases. Now, just to quickly explain forest plots so you can understand the results. A forest plot is a way of pooling the results from multiple studies to demonstrate an overall trend. As you can see on the screen, individual studies are shown as boxes with a horizontal line to represent their standard deviations, with the black diamond at the bottom representing the pooled results with a 95% confidence interval. The center line demonstrates whether these results are statistically significant, you can see in the top diagram there that these results are inconclusive. The black diamond is across that center line, so these are not statistically significant and they're inconclusive. In comparison, you can see in the bottom diagram, the diamond is on one side favoring the control and is not touching this line, which demonstrates a statistically significant result favoring the control. So moving on to our results, our systematic research search over 3 databases revealed 6,135 studies, which after screening and data extraction, 9 studies were included for our meta-analysis. So you can see in our first diagram here is the forest plot for survival in ALS-FTSD mouse models. You can see from the black diamond that the pooled data demonstrates that anti-inflammatory interventions significantly improve survival in these mouse model studies compared to untreated controls. This with a p-value of 0.01. So we know that anti-inflammatory interventions do improve survival in these models. Secondly, you can see here our forest plot for motor function. Again, you can see from the black diamond here, the pooled data demonstrates that motor function is significantly improved with these anti-inflammatory interventions, this time with a p-value of less than 0.00001. Clearly demonstrating that anti-inflammatory interventions improve motor function in these models too. So therefore, from our results here of the meta-analysis, we can see that decreasing inflammation significantly improves both survival and motor function in these ALS-FTSD mouse models. So, we also sought to critically appraise and summarize the research field and review it. You can see from the graph on the left here that the vast majority of animal studies in this research field utilize mouse models. Furthermore, on the right-hand side here, you can see that of these mouse model studies, by far most studies used the SOD1 genetic model. Now, although this was the first gene discovered in association with ALS, it's actually been shown now to not be representative of the wider human population with this disease. It makes up around 90% of the literature, but only around 2% of human cases have this type of pathology. Whereas the other important models, such as TDP43, CNNORF72, and FUS, are clearly underrepresented in the literature, especially TDP43 and C9, which have been shown to be most representative of the pathophysiology which the majority of real patients have. Around 97% of ALS-FTSD patients will have TDP43 proteinopathy, showing that this is far more representative and important when we look at human disease. So where do we go from here? Well, we can clearly see from the results that interventions which decrease inflammation significantly improve both survival and motor function in these preclinical studies. This suggests that inflammation represents a hugely promising area of therapeutic development, which can hopefully then be translated into human disease. This is much needed as there is a consistent history of ALS drug trials failing to translate good results from preclinical models into human disease. Currently, there's only one licensed drug which has met the rigorous criteria to be licensed in the UK for ALS. This is riluzole. It was discovered about 30 years ago, and since then there have been over 120 clinical trials globally for 70 different drugs, all of which have come up with poor results. So our study also reveals that within the preclinical ALS research, there's perhaps an over-reliance on mouse models, and there's clearly an over-reliance on a single gene, SOD1. This could explain why preclinical studies have not translated well into human trials and show a real issue with the current body of research. So in conclusion, targeting inflammation has a statistically significant impact on both survival and motor function in ALS-FTSD preclinical models, the two most important areas in motor neuron diseases. And it clearly represents a promising avenue for future human treatment development. We also demonstrated that the current body of preclinical research is clearly not representative of human disease. So further research is required to improve the models used for this research and to further research into inflammation to allow us to clearly understand the pathological mechanisms of this disease and allow for the development of future treatments to actually benefit patients. Thank you very much for listening, and thank you for allowing me to present at this conference. I'd also like to thank my excellent research partner, Will Daly, Dr. Waldron, Dr. Gregory, and everyone at Gregory Lab for making this study possible. Thank you very much. Oh, sorry, I think your mic's muted.
Thank you, Scott, for your presentation. We're now going to hear from our judge.
That was a beautiful presentation, to be honest. Very undecluttered, very systematic way of presenting as per your study that you did. So I have a few questions regarding your inclusion criteria because you didn't touch a lot upon that. Can you elaborate a bit more on what criteria did you include? What did you use to include your studies, that you used to get from all those 1,800 studies towards 9?
Yes, so our inclusion criteria, we began by doing the systematic review of the literature. So the focus of our study was animal model preclinical studies. So we began by categorizing all of this literature from all those studies that you mentioned. From there, we looked at where the majority of the literature was to allow us to do a review that would give us good data and show some reasonable trends that you could extrapolate information from. And from there, we came across mouse models. We then looked at which genes were included in these mouse model studies. As I said, SOD1 being hugely overrepresented, but it's also been reviewed widely in the literature. So actually any review on that wouldn't be novel research. So from there, we decided to focus on the three other most common models, and that's how we came across this inclusion criteria, which then got us down to those 9 studies.
Okay, that's interesting. And can you comment on the databases that you used while you first initially searched for doing the systematic review?
Which databases? I suppose the 3 we used were PubMed, Medline, and Embase. The overall choice for these was really detailed by Gregory Lab. They do a lot of excellent research into ALS. And from their expertise, these 3 were chosen as they represent most of the best and leading journals in this area of research.
That's interesting. I just have a quick question with one of your slides. If you can, show one of the slides with the results section, they were color coded right at the table. So I just want to go back and see the forest plots. Is that possible? Chloe, is it possible to get back to one of the slides? Yeah. So what exactly was the reason for color coding these studies?
Yes, I should have outlined that. So it's to make it clear which of the genetic models are used. So you can see here the red is the TDP43 genetic mice, the yellow are the C9orf72 mice, and the blue are the FUS genetic mice.
Okay, and do you think strategizing them or stratification according to the genetic mice used could have given you a little more different results?
Sorry, can you repeat that?
Do you think stratifying them according to the individual genetic mice used could have given you a different result, or do you think on the broader spectrum it's going to be the same?
I think on the broader spectrum it would be similar. The exact numbers would be different. But although, as you said, that could have made different results, and it could be seen as a limitation, but actually it also works well within this data. ALS is a hugely heterogeneous disease. It's got a wide array, and that's why it's been so difficult to develop good drugs for. And actually doing it across these different genes really shows off this heterogeneity. And actually, if anti-inflammatory measures can be used across these different models, then it really shows that they could be used to develop drugs which could be used on all ALS patients, much like riluzole is. But yes, that could also be seen as a limitation.
That's interesting. Thank you so much. Beautiful presentation.
Thank you.
Okay, thank you, Scott. We're going to now have the QR code to vote for your favorite presentation. Okay, and now we're going to present our last abstract. It is from Ana Maria Diaz, and it is called Dengue, Neurological Manifestations Case Series in a Tertiary Hospital in Central Colombia. You can start when you're ready.
Thank you. Good afternoon, everyone. My name is Ana Maria Diaz Aldana, and today
Okay, it looks like we're having some technical issues, so we're going to pull up the video for her presentation.
everyone. My name is Ana Maria Diaz Aldana, and today we'll be presenting a study conducted by my team of dengue neurological manifestations in a series of cases from an Adventist hospital in Central Colombia. This presentation will focus on 3 clinical cases relating their neurological completion due to dengue infection. Dengue, transmitted by the Aedes aegypti mosquito, is one of the most serious public health challenges in tropical regions. Beyond its systemic effects, dengue can cause rare but several neurological complications such as encephalitis and encephalopathy. These complications arise during the critical phase of the disease, characterized by capillary leak and multi-organ damage, and manifest as seizures, altered mental states, and other central nervous system symptoms. In this presentation, we will review 3 cases from our hospital, highlighting the neurological impact of dengue. Our first case is a 23 years old male with no prior medical history. He presents fever, abdominal pain, and generalized tonic-clonic seizures. Upon admission, he was found to have thrombocytopenia, elevated transaminases, and signs of multi-organ involvement, a non-contrast CT scan, and a contrast enhanced MRI of the brains were normal. The clinical diagnosis was dengue encephalitis with warning signs. He was treated in the ICU with mechanical ventilation, sedation, and anticonvulsants. After 8 days, the patient was extubed and eventually discharged with full recovery and no neurological sequelae. Here we visualize an uncontrolled CT of the skull, axial slice, and contrast enhanced MRI of the brain within normal limits. The second case involves an 83 years old male with multiple comorbidities, including hypertension, chronic kidney disease, and dilated cardiomyopathy. He was admitted with fever, lethargy, and altered mental status. A brain CT can show an acute subdural hematoma, but didn't require neurological intervention. His hospital cures was completed by recurrent seizures and a prolonged ICU stay. Despite his advanced age and comorbidities, he improved gradually and was transferred out of the ICU after 27 days. However, his recovery was slower and more complex due to underlying conditions. Here we visualize the CT scan of the brain, axial slice, and contrast and enhanced MRI of the brain with the mentioned findings. Our final case is an 18 years old male who presented with progressive headache, fever, and episodes of projectile vomit. He later developed a seizure and altered consciousness. His brain imaging showed diffuse cerebral edema and cerebral fluid (CSF). Analyzer revealed moderate Kositbovornchai consistent with viral encephalitis. The diagnosis of dengue encephalitis was confirmed with serological testing, including positive Deng. He required anticonvulsivant and intensive care, but he recovered with significant neurological damage. Here we visualize a simple axial section of the head CT indicating the presence of a hematoma. In the description, all of 3 cases showing evidence of acute dengue infection with central nervous system involvement. There was variability in clinical presentation and progression. Notably, all patients were male, which is consistent with a study of Kolmani Rahul et al., where 61.7% of patients with neurological manifestation of dengue were male. Age and comorbidities plays a significant role in prognosis. Case 1 and 3 involving younger male with no significant comorbidities and shorter ICU stays and quicker recovery. In contrast, case 2 on elderly patients with a high chance of comorbidity index has a more complicated and prolonged course, consistent with findings with Rowett et al., who reported that severe dengue is more likely in older adults and thus with comorbidities such as hypertension, diabetes, and renal failure. It's essential to highlight that neurological involvement is more common during epidemic peaks. The diagnosis of dengue is discarded relied heavily on serum tests, neuroimaging, and CSF cytochemical analysis. However, the sensibility of CSF PCR and antibodies is limited, making epidemiological links and clinical suspicion crucial, especially in endemic regions. To conclude, these cases underscore the importance of considering dengue as a potential cause of several neurological complications, particularly in endemic areas. Timely clinical evaluation and multidisciplinary management involving specialists in infection disease, neurology, and intensive care are essential for improving patients' outcomes. The ongoing needs for public awareness and surveillance is critical as early detection can reduce the morbidity and mortality associated with dengue. Furthermore, the prospect of an effective vaccines offers hope for reducing the burden of this disease. Thank you. These are the QR of bibliography and complete case series report. Thank you.
So thank you. Thank you very much, Anna. It was a great presentation. I would like to request the judge to please, do we have any question to Ms. Anna with regard to her presentation?
Okay.
Oh, hi, Anna. It's a good presentation, a good recording. So, do you, I mean, like, this, complication or this kind of a course of disease due to dengue has already been well researched. What exactly do you think is a novelty in your case series compared to existing literature?
Okay. First, dengue is a viral disease of great significance in global public health, especially in tropical and subtropical regions like Latin America and Caribbean. It's transmitted through the bite of infected mosquitoes of the Aedes aegypti, which proliferates in densely populated urban areas with favorable environment and climatic conditions. This disease presents a broad clinical spectrum from mild cases to several potential life-threatening forms. Approximately 10% of cases can progress to several dengue, meaning that 1 in 10 infected individuals may require intensive medical care. Additionally, while neurotoxicity is uncommon, the virus can cause neurological manifestation that these cases that further complicate patient prognosis and management. These features underscore the urgency for preventive control, prevention, and educational strategies to mitigate the impact of dengue.
Thank you. Thank you so much.
Thank you. Thank you, Dr. Manik, for the question, and thank you, Anna, for such a wonderful presentation. Now, I request the tech team to please get the QR code on the screen so that audience can vote for the favorite presentation. Now, I request the audience to please vote for the favorite presentation. So thank you very much. I think we can proceed now. So I think this was the last presentation for this final slot. And with this presentation, we are going to conclude the most exciting this World Conference of Medical Student Research 2024. Thank you all for marching us with this 7 hour of long journey. But still, the most exciting part of the conference, disclosing the winner and the award ceremony is remaining. But before we disclose the winner, we are going to take a short break of 12 minutes. So we'll get back soon. Be with us. Thank you very much.
Hello, everyone. We're going to be presenting the awards. So I'm going to go down through the list, and this is going to be recorded for those that haven't stayed on that are going to hear the announcement, and then we're going to send the certificates via email. Okay, so starting with the special mention to the most innovative study, we have aortic aneurysm inflammatory cell detection with deep learning methods, and that was presented from Christoph Nagy. And for most liked research presentation awarded by the public, that went to When Immunodeficiency Meets Neurosurgery, Brain Abscesses in a Wiskott-Aldrich Syndrome Patient. And that was presented by Alkrarha. And we're going to go through the highest placements during the abstract review process. First, we're going to start with the case reports. So in second place for highest score during the abstract review process for case reports, we have the benefits of pulmonary lobectomy and infection by actinomyces. And that was presented by Mauricio Alejandro Saldana Ruiz. And in first place for highest score during the abstract review process for case reports, we have the anti-NMDA encephalitis associated with a mature ovarian teratoma, a compelling case report by Antonio Medina Luna. And we're going to go on to the pre-revision process for the original research. In third place for highest score during the abstract revision process for original research, we have MARVELS, Medical Students Advancing Research Visibility, Education, Leadership, and Support, a student-driven initiative. And this was presented by Molly Meda. And for second place for highest score during the abstract revision process for original research, we have factors associated with greater in-hospital functional recovery after acute ischemic stroke with social service program in physical rehabilitation. Oh, okay, I'm going to slow down so we can present the banners.
Thank you, Chloe, for the announcement of the winners for this session. It's really an exciting moment for all of us, the most awaited moment of the conference, that is, award ceremony and disclosing the winners. You all did well. I want to congratulate all the participants. You truly did the amazing work, and special mentions and special congratulations to the winners of the session. As already announced by Chloe, I would like to congratulate winners for this conference. Chloe, do we have any more announcement with regard to winners?
Yes, we have a lot of winners to announce.
Yes, please go ahead.
So I think Camillo is putting together the banners so we can go through them at a time. And he just got access to the...
Yeah, exactly. So basically we are waiting for our tech team to put the banners so that we can announce the result accordingly.
Okay, so for special mention to the innovative study titled, we have the aortic aneurysm inflammatory cell detection with deep learning methods, and this was presented by Christoph Nagy. And we can announce the next one. So whenever we did our QR code poll for the public, the person that had the most amount of votes, that was the favorite of the conference, was When Immunodeficiency Meets Neurosurgery, Brain Abscess in Wiskott-Aldrich Syndrome Patient. And that was presented by Alkrarha. And there were 174 people that voted for this presentation as being the favorite. Congratulations to all of the winners. And we're going to continue going.
And yeah, congratulations to all the winners of the season.
Okay, and for second place for highest score during the abstract revision process for case reports, we have the benefits of
pulmonary lobotomy infection by actinomyces by Mauricio. I want to congratulate the author for such a great presentation. Similarly, moving on. So for the first place for highest score during abstract revision process for case reports, we have anti-NMDA encephalitis associated with a mature ovarian teratoma, a compelling case report by Antonio Medina Luna. Congratulations for the first place with the highest score. Similarly, for the third place for highest score during the abstract revision for original research, we have Marvels, medical students advancing research, visibility, education, leadership, and support as student. I want to congratulate the authors for holding the third position during the abstract revision process for original research. Similarly, moving on, for the second place for highest score during abstract revision process for original research, we have factor associated with greater in-hospital functional recovery after acute ischemic stroke with a social service. Congratulations to the authors for scoring the second highest position for original research. Moving on, first place for the highest score during the abstract revision process for original research goes to effect of a low-dose cardiac rehabilitation program on cardiovascular conditioning parameter in patients. I want to congratulate all the authors of the study of the abstract for holding the first position during the abstract revision for original research.
Okay, I'll call out the next one. So second place for best case report presentation based on the judging scores here at the conference was vertebral artery dissection secondary to malignant hypertension, precipitating a posterior circulation stroke by Avi Singh. Congratulations.
Okay, similarly, the first place for the best case report presentation at the World Conference of Medical Student Research based on the score given by the judges goes to Fox-Wallis disease, a case report by Monica Rendicate. Congratulations for holding the first position.
And third place for best research presentation based on the judging scores was psychiatric outcomes in patients with trigeminal neuralgia treated with anticonvulsants. Let's see what the rest of the title is. With or without antidepressants, a retrospective cohort study using Trinex. And that was presented by Ashley Deng.
Similarly, for the second best research presentation at the World Conference of Medical Student Research, original research based on judge score goes to understanding the role of inflammation in ALS-FTSD, a systematic review and meta-analysis. I want to congratulate all the authors of the abstract for holding the second position based on the scores given by the judges.
Okay, and first place for best research presentation at conference based on the judging scores was pain severity rating on patients with comorbid chronic pain and PTSD by Lily Sharon. Congratulations. And we just wanted to mention that the winners of the conference will be invited to have a fast track publication in the abstract book volume 12 of the IJMS. And we will see you all again next year.
And as already mentioned, the conference will be start accepting the abstract for the 2025 conference in June. Now, I want to congratulate all the winners. I want to extend my heartfelt thanks to everyone who contributed to making this conference a success. It has been a remarkable 7.5-hour journey of engagement and learning. So as we wrap up, I would like to invite the director of the conference, Dr. Omar, for his closing statement for the World Conference of Medical Student Research 2024. Welcome, Dr. Omar.
Thanks, Dr. Sajjad and Dr. Chloe. So now we have finished the third edition of the World Conference of Medical Student Research. I hope you enjoyed it and that it has achieved its intended goal. I would like to thank all people who worked on this conference, from our organizing committee, our editors, and our great judges. We have all put a lot of effort to make the conference this great. And of course, we welcome all your suggestions for future conferences. Also, I would like to thank the authors for this presentation. You all did a great job. And I would like to congratulate the award-winning researchers. And we need to mention that the winners will be invited to have a fast-track publication in the journal, so that the abstract will be published in the abstract book of volume 12 at IJMS. And finally, we will be waiting for you for the next conference, which will open for abstract submission next year in June 2025. So be ready to send your contributions and have the opportunity to present it at the largest conference for medical students in the world. So thank you for attending, and we look forward to seeing you again next year. I'm Omar Jbour, the director of the third edition of the World Conference of Medical Student Research. Thank you.
Okay, thank you. Thank you, Dr. Omar, for your kind words and for your effort in making this conference successful. We have our abstract manager, Dr. Hanna Sibasi, joining us. So we'd love to hear from her. Welcome, Dr. Hanna.
Thank you so much for having me.
Okay, thank you. Thank you very much. So as we wrap up, I think it's time to say goodbye. Thank you all once again. We look forward to seeing you next year. Thank you very much. Thank you for marching with us with this extensive and exhaustive 8 hours of session. I want to thank every single one of you for your effort in making this conference successful. Thank you very much. Thank you all.